of the PSG meet Kolkata. Is on 12th of November. We would like to introduce Dr. Ashish Dengra, sir, which is a diabetes, thyroid, and obesity specialist, which is a director at Mahi Diabetes Thyroid Care and Research Center, Jabalpur, Madhya Pradesh. Here is the diploma in diabetes, Cardiff University, UK, FISCM, FMS, and fellow RSSI in fellow diabetes of India. He is a done CPS diabetology, All India Institute of Diabetes at SL Raheja Hospital in the year of 2008. The preceptorship course in diabetes done in Italy in the year of 2011. Uh, he has done the postgraduate certificate course in diabetology at Boston University. He has also done the advanced certification course in diabetology, Cleveland Clinic in the US. Certification course in diabetology at ADA. Certification course in evidence-based diabetes management in PHFI. Certification course in management of thyroid disorder, certificate course in diabetic food management, and Ashish Dengra sir is the organizing secretary at Jabalpur Diabetes Update and Jabalpur Thyroid Update and MMRF Insulin Workshop. He is the current president at API, president at Jabalpur Endocrine Society, organizing secretary at RSSBI Madhya Pradesh chapter 2020. He is the vice president at RSSBI Madhya Pradesh chapter, honorary secretary and founder of Mahi Medical and Research Foundation. He is also member of AACE Endocrine Society of India, API, IMA, RSSBI, ITS, Diabetes India, and IACM. Awards and recognition for him is he received RSSBI Fellowship Award for the year of 2020. Received the Best Diabetes Awareness Initiative Award at RSSBI 2040 in Diabetes India. Best State of Art Diabetes Food Clinic Award. Presented paper in various national and international journals.
Thank you, dear, for kind introduction. And I would like to thanks at the outset Rutul and Amit and the team PSG for inviting me to deliver a talk on the important topic that is the LADA in pregnancy. Can you see my slides?
Yes, sir.
Yeah. So to begin with, we are dealing with a case symposium. I will be dealing with the LADA patient in pregnancy. This is Mrs. ABC, in a 25-year-old woman referred for newly diagnosed gestational diabetes after having a oral GTT test. Her 1 hour postprandial glucose was 150 milligram, and she denied any history of polyuria, polydipsia, polyphagia, or visual disturbances. And she came to our clinic at 28 weeks of gestation. During this pregnancy, she had gained weight of only 5 pounds by 31 weeks and denied any complications. Before the pregnancy, sorry, her baseline weight was 205 pounds and her BMI was 33. So she is obese. Her medical history was significant for a single pregnancy 4 years ago that was not complicated by GDM, but she delivered a healthy baby with normal spontaneous vaginal delivery. She denied any subsequent history of impaired fasting glucose or IFG or IGT. She denied a family history of type 2 diabetes also. However, her 4-year-old daughter got type 1 diabetes and she denied of any tobacco or alcohol use. So this is a background. This female coming to your clinic with the previous history of normal delivery and her baby developed type 1 diabetes, and in this pregnancy she is having IGT and IFG. So after being diagnosed with GDM, she was started on appropriate dietary counseling and was advised the home blood glucose monitoring. But despite of this, she was not well controlled and she was started on NPH insulin 5 units before bedtime. She continued to monitor fasting and 2-hour glucose gradually, and her NPH dose was titrated to 14 units at bedtime. But despite of this, her postprandial hyperglycemia was not controlled. So insulin Lispro was added as per the 1 unit per 20 gram of carbohydrate she consumed. Her blood glucose control improved on intensive insulin therapy. Her hemoglobin HbA1c was excellent at 5.5 with the start of the basal bolus therapy, and at term she delivered a healthy boy with the normal delivery. And the patient was scheduled for a postpartum OGTT after a few weeks, and she denied of any hyperglycemic symptoms, and she had lost a total of 17 pounds since delivery and was close to her baseline weight of 207 pounds. her 75 gram OGT was showing fasting blood glucose of 117 and 2-hour glucose of 179, and A1C was 5.8. So she was having borderline raised when she was followed up in the first visit. And her consistent IGT was, and she was still nursing. It was planned to return her after the 8 weeks. She was called, and then OGTT was again done, and she was having very high glucose levels of 200 and 350 fasting and postprandial for 3 days, and she was having symptoms of polyuria, polydipsia, and blood vision. So, my dear friends, what is this patient? We have to dig up and see whether it is a type 2 patient or whether it is a LADA. So this patient was insulin was initiated with basal insulin glargine 15 units at bedtime and insulin lispro for bolus insulin coverage at major meals. Because of the family history of type 1 diabetes in her daughter and acute exacerbation of hyperglycemia postpartum, an antibody test was done, and her GAD antibody was positive, IgG auto antibody was positive, islet cell, and the non-fasting C-peptide level was borderline, that is 794 picogram per liter. So this patient is following in between type 1 and type 2 because the antibodies are positive, and despite of the positivity of antibody, the C-peptide is moderately secreted. So because of the presence of pancreatic antibodies, she was diagnosed with LADA, that is latent autoimmune diabetes in adults. The intensive insulin therapy, that is basal bolus therapy, was started. Within the next 6 months, she was started on insulin pump because she was affording and had excellent glycemic control. 1 year after her diagnosis, she became again pregnant, and she was well maintained on the basal bolus therapy or on the insulin pump, which she continued. So the message is that you don't go that every GDM patient is type 2. You have to take proper history, proper pedigree charting, and antibody testing should be done. So what is LADA? How LADA is diagnosed? Why it is important to recognize and diagnose LADA? This we will see in the few slides. So LADA is an adult onset diabetes with positive antibodies and slowly progressive beta cell failure. LADA does not present like type 1 diabetes with significant weight loss and ketoacidosis from progressive rapid beta cell failure. Because of the slow progression of beta cell failure, LADA simulates type 2 diabetes initially, but gradually the insulin levels goes down and the patient is adult onset with positive antibodies, and lack of ketosis is the major 3 features of LADA. At diagnosis, C-peptide levels in LADA are at intermediate levels between type 1 and type 2, which our patients was seen, and positive antibodies are there, but gradually the beta cell failure develops and patients start behaving like type 1. But the ketosis is rare initially. UKPDS have shown 10% of the newly diagnosed type 2 diabetes were found to have antibody positivity, that is, they were LADA. Autoimmunity is a strong predictor of insulin requirement within 6 years in all age groups, and the predictive value increases with decreasing age. Because of the earlier need for insulin therapy, it is important to identify these patients with LADA. Insulin therapy can be started in a timely manner once this condition is diagnosed. So multiple studies have tried to best distinguish LADA from type 2 diabetes, and we know that the patients are not so obese, they don't have ketosis, and they may have some secreting of insulin through the C-peptide levels, but the antibodies are positive. So major features are age at the diagnosis is less than 50, acute onset of symptoms, personal history of autoimmune disease, family history of autoimmune disease, BMI is usually less than 25 are the major features of LADA. So family history of type 2 diabetes has not been shown to distinguish between LADA and type 2 diabetes and should not be used to exclude LADA. So only family history is not an important factor. Patients with LADA are more often unable to control their glucose levels through diet and lifestyle modification, like the type 2 diabetic patients without autoimmunity. Moreover, the failure rates of diet and lifestyle therapies are higher the younger the patients are. In patients with LADA, sulfonylurea therapy is associated with more rapid beta cell failure than insulin therapy. That's why we have to start insulin therapy early in LADA patients, and metformin should be avoided to prevent ketoacidosis. So the key message is that underlying process of the decline in the beta cell failure, LADA patient should be started on insulin early, and in the pregnancy, basal bolus therapy is giving the best results. and we should prevent the misdiagnosis of LADA or 1.5 diabetes, which is a in between of type 2 and type 1 diabetes. That's why it is also known as 1.5 diabetes. And you should be vigilant, because 10% of the patients of the type 2 diabetes which are diagnosed can be LADA. So during pregnancy also you should be vigilant, and usually we should start with basal bolus therapy for best control. So the clinical pulse, LADA occurs in 10% of adults who appear to present with type 2 diabetes. The clinical presentation is like type 2, but the antibody positivity, low BMI, and absence of ketosis is there. Within a few years, they require the insulin therapy. Patients with LADA require preventive screening assessment for micro and macrovascular complications also. And GDM, during GDM also, LADA patient can be picked up. So don't miss them. And for proper delivery of the well controlled sugar should be done in the patients with LADA also, to have the healthy mother and baby. Thank you. Thanks a lot for patient hearing. Thank you. So thank you. Thanks a lot for patient hearing.
Dr. Karshit, please introduce Dr. Renuka Prasad and start.
Thank you so much. Good afternoon, everyone. I'm introducing Dr. Renuka Prasad here. Welcoming you, sir. On behalf of this, am I audible?
Yes, please.
Okay. So, sir has an MBBS fellowship in diabetes and post-graduation diploma in clinical diabetes, endocrinology and diabetes BFM diploma in family medicine from UK. Post-graduation diploma in advanced diabetes care, CCBDM, CMHS, CCBDM, CCMTD. Sir is a managing director and consultant, New Diacare Center, Polyclinic, Mysore, Karnataka. Received Diabetes India USA Award 2021 for best contribution in diabetes care in challenging times. Received Sri Vasudeva Maharaj Award 2021 for medicine from Sri Vasudeva Maharaj Foundation, Mysore. Acharya Sri Vidyayana Rojvasava Award by Himalaya Foundation, Mysore. Viveka Smriti Award by Yoga Mahavidyalaya, Mysore. Researcher. The extensive use of SGLT2 inhibitors in patients with type 2 diabetes in clinical practice. A study from India. Thank you. Sir, over to you.
Yeah, thank you, Dr. Pratik, for your kind introduction. And I would like to share my case. I think it's visible. My slides are visible?
Yes.
No.
Yeah. No? Okay. Yes. On the outside, I would like to thank PSG team and Dr. Utul and the whole team for this wonderful program. I wish them to have a great success. And today I'm going to present on the pre-diabetes with pregnancy. So the pre-diabetes is not different than any other diabetes because it have a similar outcome. So the pre-diabetes with pregnancy, when we look into it, the women identified with this in early pregnancy have been reported to have an increased risk of adverse pregnancy outcome compared with a woman with lower HbA1c level at the booking. So the major congenital malformation remains the leading cause of mortality and serious morbidity in infants of mothers with a type 1 and type 2. So there are several studies have established in association between the elevated maternal glucose or even HbA1c level during the embryogenesis and high rates of spontaneous abortion and major malformation in newborns. A clinical trial of preconception care to achieve the stringent blood glucose control in the preconception period and also during the first trimester of pregnancy have been demonstrated a striking reduction in the rate of malformation compared with the infant of women with the diabetes who didn't participate in the preconception care. So in that way, the ADA 2020 has defined the elements of preconception care program. The patient education is about interaction of diabetes, pregnancy and family planning, education in diabetes, self-management skill, and physician-directed medical care and lab testing, counseling by mental health professionals when indicated to reduce the stress and improve the adherence to the diabetes treatment plan. These are the four elements are important for the patient to achieve the level of a sustained glycemic control, which is necessary to prevent the excess of congenital malformation and also spontaneous abortion. With this background, I would like to present one of my case. She is 20-year-old female presented with a pre-diabetes with a history of PCOS and also obese. She visited our center when she came to us. Her BMI was 31.2, obese category, and as they were planning for the pregnancy. We have taken proper diabetes and family history. Very unfortunate, she had two abortions in the last 6 months. She was under stress, and there was no cause for the abortion. But only thing, because she has PCOS and also pre-diabetes, they brought to us. And on physical examination, looks obese. The signs of insulin resistance like insulin tax and also acanthosis and aggregants were present. Her BP was normal. There's no orthostatic changes. A dilated retinal examination by the ophthalmologist revealed no diabetic retinopathy. A cardiovascular screening was done, which was normal. Neurological examination has shown no signs of autonomic neuropathy. And lab evaluated the pre-diabetes status. Like PS was 110, postprandial 180 milligram per deciliter, A1C was 6.3. Renal profile was normal. Thyroid screening done, shown abnormal, no abnormality. Now, coming in that case, when they came to us with the pre-diabetes, in general, because one point, in general, we need to treat them with a lifestyle and diet. The second thing, in this case, she already had 2 abortions and they're planning for pregnancy. So we need to consider both the factors and we need to treat them. In this case, actually, what we provided is the diabetes education, at most important at any moment of when we diagnose the diabetes or even the pre-diabetes stage. And lifestyle changes, as we know, the diet and exercise, that is the most important thing. And blood sugar monitoring, that's where most of the time we are going to miss even patients too. And most important, because she had even a history of abortion, so needs to counsel her properly. Now coming to the diabetes and exercise, we know that the participation in the regular physical activity, it improves the blood glucose control and can prevent or even delay the onset of type 2 diabetes. And both moderate walking or even vigorous activity have been associated with a decreased risk, and greater volume of physical activity may provide the most prevention. The Dequing study in China, which well-known study, included even exercise-only treatment arm and reported that even modest in exercise, like even 20 minutes of mild to moderate, 10 minutes of strenuous exercise, or even 5 minutes of very strenuous exercise 1 to 2 times a day, it reduced the diabetes risk by 46%, and compared to the 42% for the diet plus exercise and even 31% diet alone. So in that way, I think exercise play an important role. And we know the other familiar studies like the Finnish diabetes prevention study and US diabetes prevention study, that program, DPP program, that is a well-known studies. They have shown that even pre-diabetes level or even lifestyle and even diet modification will make a marked change in their life and arrest the progression of type 2 diabetes. Now, we have given the proper exercise as well. And come to the diet part. Emphasize advice on healthy, balanced diet. Like eating is applicable to the general population when providing advice to the adult with type 2 diabetes was given to her. We encouraged to have a high fiber diet, low glycemic index source of carbs in diet, such as fruits, vegetables, whole grains, pulses, includes low fatty dairy product and oily fish. and control the intake of the food containing the saturated and trans fatty acids as we consider like any other diabetes. One of the most important factors, particularly in the pregnancy, is the weight gain. We know that the table shows the weight gain target for the pregnancy depending upon the pre-pregnancy weight range. So the weight also play important role, and in this case, this patient has an obese category. As her BMI was high, more than 30, so recommended weight gain was the 5 to 9. But in this case, before the pregnancy itself, we plan to reduce her weight. We advise her to reduce her weight by planned customized diet plan, regular exercise, advised by dietitian, explain about the healthy weight during the pregnancy. And with this, actually, the proper preconception care. So she reviewed after 2 months with the following blood reports. Her fasting sugar was 88, postprandial 118, and HbA1c is a 5.8. Weight gain, the weight loss happened by 5 kilos. Asked them to proceed further with the pregnancy as glycemic control was good with a strict monitoring of glucose level. And we referred to the obstetrician for initial assessment. And she was prescribed the folic acid, folate, and essential vitamin for a healthy pregnancy. And even during after that, the pregnancy was positive and UPT was positive. She followed up with us, and even during that time, she was having regular follow up with us, and she used to strictly monitor the blood sugar through the. We used to connect through the teleconsultation apps, and actually, while even in the first trimester. So again, we followed the same. Recounseling was given about our diet, exercise, blood glucose monitoring, and management of hypoglycemia. Few setting of psychological counseling given as she had 2 pregnancy loss in the past. And after that, I think she completed the full term and she delivered a male baby of weight 3.5 kgs 2 months back, and asked her to strictly adhere to the diet and exercise. And we asked her to monitor the sugar for every 6 months. And most important, I think we put her on CGMS at that particular time, even before the time and during the pregnancy as well. You can see she can able to maintain a good glycemic control throughout her pregnancy, and we kept on changing every 2 to 3 months because you know the CGMS is not very cost effective. So we asked her to monitor at least every 2 to 3 months once. So we are able to get the better readings throughout the pregnancy. I think this is showing her report, and you can able to see that she maintained very well throughout her pregnancy, and pregnancy outcome was very good. And I just wanted to highlight this case as even in pre-diabetes is most important, especially those who are planning for pregnancy. So as usually now the people who came with such a bad history, we need to take care of them in a better way, just treating any diabetes patient. With this, I would conclude my talk. Thank you. Thank you.
I would request Dr. Ankit to introduce Dr. Manisha, please.
Good afternoon, ma'am. Dr. Manisha Gupta has done MBBS and SC Diabetes and Endocrine in the Royal College of Physicians, UK. Postgraduate Diploma and MSc in Endocrine, University of South Wales. Clinical Associate Consultant in Center for Diabetes and Endocrine and at Regency Hospital Private Limited. He has a recipient of Alan Drass Fellowship in 2020, ISAPD, and for winner of USB Award for the Best Innovation in Diabetes Care in Challenging Situation in 2020. Certification in PG Diploma in Diabetes, CCGDM, CCBDM, Fellowship Certificate of Diabetes, and she has contributed as a co-author in various chapters and presented several papers in national and international conferences. Welcome, ma'am.
Thank you, Chairpersons, for this kind and warm introduction. I would like to extend my thanks to Dr. Rutul, Dr. Amit Dey, and Dr. Tharveen Panchal for giving me this opportunity to be a part of this wonderful event. I'm glad to be here. And I will be talking about best practice with SMBG. Okay. So I think my slides are visible. I will be talking about SMBG in pregnancy in Taiwan. Taiwans are like very close. I've been working with Taiwan since so long. All good to go? I'm audible. My slides are visible. All good. Yeah, right. Thank you so much. Thank you. So as we all know that type 1 itself is an autoimmune disorder, and there might be various comorbidities like adrenal insufficiency or hypothyroidism, or another autoimmune disorder might be present once you're dealing with type 1. And they're entirely insulinopenic. The day of diagnosis, we need to start them on insulin, and certainly the management itself is very challenging, especially like once they're diagnosed with type 1 and then is pregnancy, the lot of things which we need to be addressed. Living with type 1 is not easy. Like for a day, 24 hours manually dosing and injecting insulin to survive, watching blood sugar like a hawk, 24 hours counting the carbs, it's very easy for us to tell them like, you need to count your carbs, take your dose accordingly, and whatever you eat, you need to be vigilant. So 24 hours continuous vigilant for their food, and 24 hours beeping, poking, squeezing, bleeding, and feeling highs and lows. So it's certainly not very easy to live with type 1 for a day. And then comes up with pregnancy. So I will be not talking about type 1. I'm focusing here more of the care and preconception care for the women with established type 1 diagnosis. All women should be counseled if they are planning pregnancy at their childbearing age. They should be taught about the laboratory investigation like HbA1c or sodium potassium or thyroid needs to be ruled out if they're planning pregnancy. Uncontrolled diabetes should be taken care pre-pregnancy, and medications such as statins, ACE or ARBs should be avoided for a minimum of 6 months once you are planning, any woman planning with pregnancy who is type 1. These are potential contraindication to pregnancy, whereas ischemic heart disease or who are untreated active proliferative retinopathy, renal insufficiency or severe gastroenteropathy, they should be counseled. If at all they have established diabetes, tell them what could be the these are the contraindication and what could be the precautions they need to take if at all they're planning pregnancy. So this is preconception glucose control for women with type 1. As per American Diabetic Association, preconception HbA1c should be less than 7%, or American Association of Clinical Endocrinology said it should be less than 6.5%. So we have individualized target. And now the woman has conceived. So post-conception care. So diabetes in pregnancy, the management goals are like quite vast. We need to educate. And this year, World Diabetes their theme is educate today, protect tomorrow. So this is the theme. So we need to take out some time, especially if you're dealing with type 1, educate is the awareness. The more they're aware, the more that they would deal better with their diabetes. Counseling regarding adequate nutrition, glucose control before conception, during and postpartum. Maintain close to normal glycemic control. They should avoid complications like micro and macrovascular complications. Weekly HbA1c is though not recommended in India, but in US it is recommended. And they do weekly HbA1c, people who could afford it, who are not doing SMBG regularly. So for us, the patient safety should be our first priority. These are the glycemic target for GDM, as very well mentioned by Dr. Dhengra and my another co-speaker, and they mentioned about GDM, the preprandial less than 95, 1 hour postprandial like 140 and 2 hours, postprandial 120 milligram per DL, whereas pre-existing type 1 or type 2 pre-meal 60 to 99, peak postprandial like that is 2 hours after meal 100 to 129 or 130, or HbA1c should be less than 6. These are AD recommendations. And we all see like this is what I usually follow in my clinic. I make sure that their pre-meal blood sugar or fasting should be less than 90, 1 hour less than 140, and 2 hours less than 120. So if you could maintain these targets throughout the pregnancy, the outcome would be great. And these are some expert recommendations. They say like, this is what I follow, and HbA1c less than 5. And though HbA1c does not hold much value in pregnancy, especially either is type 1 or type 2. But if at all they are not doing anything, like the few of our patients who don't do anything, they would just come, madam, sirf HbA1c ho gaya. So isi se aap dekh lijiye. So this also we clinician need to address this issue also. So if they're maintaining the HbA1c like less than 5 or 5.6 or something, they're doing good. So if you're maintaining the tight glucose control during pregnancy, the outcomes are really good. You are preventing them from any serious perinatal complications, shoulder dystocia, admission to neonatal nursery, and jaundice requiring phototherapy. So these are the possible outcomes with good tight control we are preventing from to our patients. Diabetes in pregnancy, the management once they are pregnant, so we need to have an entire team of dietitian, ophthalmologist to rule out any proliferative diabetic retinopathy, or endocrinologist, or a certified diabetologist. Nurse educators should be there to take care of our patients, and there should be a checklist. It should a combination of glucose monitoring, medical nutrition therapy, pharmacotherapy, exercise, waste management, and psychological support, which is certainly needed if you're dealing with type 1. So what is SMBG? SMBG is self-monitoring of blood glucose. In one of my study, I did it in where I'm from Kanpur, and I did it here. People have glucometer, still they don't do. And why they don't do? Because they have needle phobia, they don't want to prick themselves, they have some visual impairment, or readings are not appropriate. That's what happens when the patient who have glucometer, but they are not doing SMBG regularly. So you need to tell them the techniques, the targets, the recommendations, what the glucometer does. At least they have something to see, like hypo and hyperglycemic patterns. And we, the healthcare physicians, should able to do some additional education wherever we find time. And these are like, we need to have, planned SMBG. We should tell our patients, especially type 1, like they should do all pre or fasting, pre-meals, and 1 hour or 2 hour post-meal. And as we know the targets, so we can judge them accordingly. And SMBG, trust me, remains a cornerstone of glucose management. People in our country, they cannot afford, like, they're not able to afford the technology. So if they have a very customized SMBG, we can deal very well with the pregnancy thing. So this is my case. She's 31-year-old primary gravida. Why 31-year-old? Because marriage itself is an issue in type 1, especially type 1, like they still consider as sick ladies. So people do not want to get married to a type 1 woman, and this is a big issue. So she got married late at the year of, at the age of 30. School teacher at 6 weeks of gestation. She had 2 miscarriages in a span of like 1.5 years, and cause is still not known. No other autoimmune disorder. Preconception fasting was 110, postprandial 140, HbA1c 7, no family history of diabetes. And she was asked to do SMBG at regular interval. Customization of SMBG was done. Insulin dose titration was taught. Start walking and refer to gynecologist for the further advice. These are laboratory investigations. HbA1c, current HbA1c was 7.9, fasting 120, postprandial 170, albumin creatinine ratio, TSH, hemoglobin rest, all were not significant. So we could focus more on the management part, especially the pattern, dose titration, the diet part, do the SMBG regularly, minimum 3 times a day. And fasting was like falling between 80 to 95, 2 hours post-breakfast was 110, 120, and so on. Ultrasound was normal. We could do it like subsequently visit. And since this was a precious pregnancy and needed more intensive glycemic control, I will not talk more about technology here because that's not my domain. I need to stick to the SMBG part. And these are the images of SMBG of my patient. And you can see here the fasting was high and postprandial was high too. And this is a customized chart we follow here. Khali pet is fasting 2 hours after breakfast, pre-lunch 2 hours post-lunch, pre-dinner 2 hours post-dinner, and 2 a.m. was recommended to her, and subsequently visit. I have not put the entire images here. And these are the few images of her blood sugar reading, where you can see like fasting was appropriately like beautiful readings she could do. And the outcome was phenomenally good. She delivered at 38 weeks, underwent LSCS. Yeah, I did one of my study. It was a retrospective study of around some 33 or 34 patients of type 1. And most of the patients, they go under LSCS. And the reason is not known. They conceive naturally, but they perform they have been going under cesarean section. So this could be because the pregnancy itself is a very precious. Type 1 is a complicated diagnosis, and a lot of comorbidities might be present at the time. So the gynecologists, they preferred to do LSCS. Fetal birth weight was appropriate, 2.8 kgs, and there was no pre-maternal and fetal post-op. The condition was stable. And so this was the study. It was an Indian study, retrospectively observed. Patient with type 1, 34 patients were included, and HbA1c maternal fetal outcome were evaluated. Patients were divided into two who received continuous insulin infusion and who were on MDI, that is basal and bolus therapy. 1 time Lantus and 3 times regular insulin was prescribed. And HbA1c level was done in each trimester wise, baseline, first and second, third trimester. And these are the comparison of maternal and fetal outcome, where none of the, we had seen the duration, Apgar scoring, newborn birth weight, hypoglycemia, congenital anomalies, patients who were on insulin pump or MDI, the p-value was not significant in any. So what it concludes that if you are maintaining your patients very well on basal bolus, in spite, like if you do not use technology as well, with SMBG and basal bolus therapy, the outcome can be fair enough. So you just need to be customized. And there's certain limitation with HbA1c also. Like it doesn't tell the hypo and hyperglycemia, the peaks, the excursion cannot be ruled out. Magnitude and frequency of intra and interday glucose variations cannot be identified, and conditions like anemia, hemoglobinuropathies, iron deficiencies, in these conditions, the HbA1c would not give an accurate reading. So for this, we have technologies to take care of, and we have some limitations of SMBG. You tell your patient to do 6-point reading, they would come with 3. You tell them to do 3, they would come only with 1. So this is the limitation. As I said, they have needle phobia, or I've seen patients whose readings are like day to day, all the readings are same. So this what happens. And hypo episodes may go undetected, and the readings are intermittent. So just to overcome how to come with this and have better compliance, we have CGM and insulin pump. So that these sessions will be taken care in the evening probably. And the key points to learn, SMBG still remains the cornerstones. Once you are dealing with patients who are at the peripheries, SMBG still remains the cornerstone in management. Dose titration, it is important once you're dealing with type 1 diabetes. Pre and post conception counseling is mandatory. It's like you need to deal once I've been seeing my patients since their childhood, once they're diagnosed, now they are getting married, their sexual life, their pre and post conception counseling, there are lots to do in type 1, lots to do. And motivation psychological assessment is like should be offered, because they are dealing with a very, as I said in one of my previous slide, it is not easy, poking every time, like whatever you are eating, you need to be very vigilant. So these should be offered, they're psychologically depressed. And these are few images of my type 1 women. There's I'm working with here, very renowned endocrinologist here. He has long follow-up patients. And this is like all type 1 patients. And these, the extreme right is both the husband, wife, both are type 1. They have a daughter now. And they conceive naturally, deliver, they're all doing good, and the kids are also doing good. None of the child have been diagnosed with type 1, so that's a blessing. Thank you for patient hearing.
Oh, wonderful.
Thank you, Dr. Rotal. I was expecting this from you. I hope I did the proper judgment to the topic I was assigned to.
Wonderful. And over to our chairpersons if they have any question or anyone.
Hello, sir. I have one question. When the pregnant lady derived, what is best time to for the doing LADA antibody test?
LADA topic is given assigned to
Dhingra
glucose.
is not there. Dr. Manisha, you may also give
For
topic.
LADA, I think, as far as best of my knowledge, the GAD antibodies can be done at any time. Can be done at any time of the. It has nothing to do with pregnancy. So
Okay.
antibodies
And
can
then
be
C
done.
peptide as well.
C-peptide, as far as it should be done fasting and 2 hours post meal with corresponding blood sugar. The beta cell needs to be stimulated well if you are doing 2 hours post meal. So whenever you're asking for C-peptide, ask them for a corresponding blood glucose also. So that gives an appropriate results for your interpretation.
Okay, ma'am. Thank you.
So for Lada, I would like to answer that for any antibodies in our LADA or type 1 diabetes, it's better to do as soon as the patient is diagnosed, and it is always better to do this antibody during that initial first year, or if possible, then with 6 months of we have that titers come low after few months. So it do as early as possible.
Mhm.
Uh, Dr. You have anyone here want to discuss? Dr. Rakesh Parekh?
Hi, Rutu. Your voice is cracking, so I'm not sure whether it's the network issue at your end or my end. Am I audible clearly?
Is it okay now?
Yeah, in between we lose your voice. But is my
Yeah,
voice
yeah.
okay now? Because I have to.
It's breaking. It's breaking.
Who is
Okay.
breaking, mine or Ritu's?
Your voice is good, Dr.
Ritu's,
Rutul. Your voice is great.
Dr. Rutu's voice is breaking.
Okay. Hopefully, I'm audible now.
Yeah, yeah.
Yeah, you're audible, but it breaks in between. It's like kind of brittle.
Okay. Okay. Kind of a brittle. Great. So if we don't have any question, or we won't don't want to discuss anymore, we may move further to the case symposium number 2. It was very important symposium earlier, that LADA in pregnancy as pre-gestational diabetes or pre-existing diabetes is very important. Most of the cases come up with uncontrolled diabetes in this scenario. Recently, what I have seen in one of the type 1 diabetic patient came up with 11% of HbA1c, and telling me that, sir, galti se ho gaya. And this is not the thing that we should go ahead with. And actually, the gynecologist suggested that pregnancy should be terminated, but patient did not want to terminate it, and we had continued, though it's been only a few weeks. So let's see how it goes, but we don't know how things go. We should be very cautious, and we should explain each and our each of gynecologists fraternity and our friends, that you should do that pre-pregnancy counseling to all diabetic patients before they conceive. So with this, I will move further to the case symposium number 2, and I'll hand over the session to Dr. Birju Mori and Dr. Hina Goswami. Thank you very much, Dr. Manisha, Dr.
Thank you.
Renuka Prasad, and Dr. Ashish Dhingra. Thank you.
So, good afternoon, everyone. I'm Dr. Hina Goswami. We'll start with the case symposium number 2. So, the first lecture is by Dr. Parekh, Rakesh Parekh, sir. Can I have Dr. Rakesh Parekh, sir, slide, please? Dr. Rakesh Parekh sir's slide. I can introduce him.
Mahima, please upload the slide for Dr. Rakesh Parekh. Thank you.
Yeah. So Dr. Rakesh Parekh sir is from Jaipur, and he's a fellow of American College of Endo, Royal College of Physicians and Surgeon, College of Physicians and Surgeon, Bombay, RSSDI, Treasurer, RSSDI Rajasthan chapter, on editorial and reviewer boards of various journals. He has over 50 publications, including textbooks and chapters, and he is a principal investigator of several global phase 3 trials. He's going to talk on PCOS and GDM. So over to you, Dr. Rakesh Parekh, sir.
Thank you, Dr. Hina. Thank you very much for the nice introduction. And thank you, Amit, Rutul, and the whole team of PSG for inviting me to speak on this case-based symposium. Let me try to share my slides. Yeah, are the slides visible? Dr. Hina, are my slides visible?
Yes, it's visible.
Okay. So we'll start with a case. I have just put up a case which is a representative case. It's not a real patient, but just wanted to have some discussion on this case. So here is a 32-year-old female who comes to me with 16 weeks of amenorrhea and was referred for management of GDM by the gynecologist. The patient has a history of PCOS, for which the patient has been taking metformin 500 milligram twice a day. Her family history of diabetes is there in both the parents. She is obese, the body mass index being 28.7. Her blood pressure is normal, 124/82. HbA1c is 6.7. Fasting on the SMBG chart, the fasting is between 116 to 132, and 2 hour post meal is 178 to 212. So now, first let us start with the diagnosis. So is it a pre-existing type 2 or a GDM? Now, as we know that recently the definition of GDM has been revised, and now we call a patient as having GDM only if the diabetes is diagnosed in the second or third trimester of pregnancy, and that was not clearly overt diabetes prior to gestation. So this patient was diagnosed in the second trimester, so we can say that she is a GDM, but then how can we be sure whether she was having diabetes prior to gestation or not? Now, in this case, is HbA1c of any use if we want to see, like, in normal cases, we do HbA1c just to know about the prior glycemic status of the patient in the last 3 months. But in pregnancy, again, the guidelines say that A1c is not a reliable screening tool for GDM or for pre-existing diabetes at 15 weeks of gestation or later. So these are from the ADA guidelines. So HbA1c is not much of use here for us. Secondly, the patient is already taking metformin. So if the patient was having pre-existing diabetes and she is on metformin would have some effect in lowering the A1c. So that is why we cannot be very sure whether the patient had pre-existing diabetes, type 2 diabetes, or she is GDM now. So let's proceed with the management part of this. Now, we know that PCOS is often associated with many conditions like obesity, which is very common. Although in India, we do have lean PCOS, which is again common. But many of the patients of PCOS, they are either overweight or obese. So body mass index helps us a lot in analyzing these patients. Then eclampsia and preeclampsia has got a strong association with PCOS. So a PCOS patient becoming pregnant is at a higher risk of getting eclampsia or preeclampsia during the pregnancy. And that is why blood pressure monitoring is very important in such patients. Hypothyroidism, again, is very common. So TSH must be done at the baseline itself. And we also know that during pregnancy, there are chances of retinopathy worsening or nephropathy worsening. So fundus examination or fundus photography, along with serum creatinine and UACR, should be done at the first visit. And if normal, then maybe again we can repeat it between 24 to 26 weeks of pregnancy. In terms of medication, in case the patient is taking any antihypertensives like ACE inhibitors or ARBs, then we have to stop those during the pregnancy. If the patient is on statins, we have to withdraw statins as well. Also, the patient being pregnant, we have to start her on folic acid and potassium iodide. And if a patient is at a higher risk of preeclampsia or eclampsia, then the ADA guidelines recommend that we should start the patient on low-dose aspirin. Now, the most important component of managing these patients is the glycemic monitoring. So we have to explain the patients to prepare a sugar chart at home, I usually give a printed chart like this, which is in Hindi because most of my patients speak Hindi. And in this chart, they have to mention the dates and the blood sugar levels, whether they have done it pre-meals or post-meals or at bedtime or fasting. And then we have the targets for fasting and postprandial sugar levels as per the ADA. So fasting sugar should be maintained below 95 and 1 hour postprandial below 140, 2 hour postprandial below 120. These are the standard guidelines for managing any GDM patient. So these have to be explained to the patient. CGM is now being used in pregnancy, and even ADA recommends that the use of CGM helps a lot in achieving the A1C control. So if the patient can afford, and if you are sure that the patient is literate enough to titrate her doses based on the CGM values or CGM charts, this can be very useful tool for the patient for glucose monitoring. Now, in terms of management of hyperglycemia, we have 3 options. The first one being the lifestyle modification, which includes the medical nutrition therapy and physical exercise. Second is the oral antidiabetic drugs. So among them, we know that now the sulfonylureas we don't use, although some people are using it off-label, but it is not anyways recommended. Metformin is something which is controversial, and there is a lot of controversy regarding metformin. Some people advocate use of metformin specifically in patients who are PCOS patients and becoming GDM, while some bodies do not endorse it. Insulin always remains the drug of choice. So what are the guidelines of ADA? ADA says that lifestyle behavior change is an essential component of management of GDM and may suffice for the treatment of many of the women. Insulin should be added if needed to achieve glycemic targets. It doesn't mention anything about the OHs. Insulin is the preferred medication for treating hyperglycemia in GDM, and metformin and glyburide should not be used as first-line agents, as both cross placenta and might be harmful for the patient or the fetus. Now, if we start with lifestyle modification, it is very important, and we need to have an individualized diet plan for each patient. So for this, we should take the help of a qualified RD or a nutritionist who is expert in managing such patients of GDM. The ADA guidelines recommend that there should be adequate nutrition intake to promote fetal and maternal well-being, along with achievement of glycemic goals and promote weight gain. The minimum recommendation for carbohydrates is 175 grams, 75 grams of proteins, and 28 grams of fibers. MUFA and PUFA should be used, but saturated fat should be limited, and trans fat should be completely avoided. In terms of exercise or physical exercise, the patient should be advised to go for both aerobic or resistance exercise, or both of them with moderate intensity. And we must take the obstetrician on board before advising any physical exercise. In case the patient has got some other complications, the exercise might have to be limited. Ideally, we should recommend the patient to go for 20 to 50 minutes of exercise at least 2 to 7 days per week. Now, insulin is the drug of choice, as I earlier said, and in the insulin, most of the patients will require a basal bolus therapy because that is the one that you can easily titrate based on the fasting and post-meal values. Self-monitoring of blood glucose is very important and is a useful tool for titrating the doses of insulin. And if you educate the patient properly regarding the titration methodology, most of the patients can self-titrate the dose of insulin and manage it very well. Now, coming back to the controversial topic, I kept it for the last, metformin. So there have been so many studies, so many meta-analyses. This was a study which was published in 2006 when I was a student here, and it showed that metformin reduces the risk of abortion in pregnant women with polycystic ovarian syndrome. So at that time, it was very strongly recommended that the patients who are PCOS and who become pregnant, they should continue the use of insulin, continue the use of metformin, because that has been shown to be very beneficial in reducing the risk of abortions. Then there have been several other studies. I'm just putting a few of those. So in this study, which was published in Lancet, they concluded that in pregnant women with PCOS, metformin treatment from the late first trimester until delivery might reduce the risk of late miscarriages and preterm birth, but it does not prevent gestational diabetes. This another study, which is again looking at the effect of metformin on pregnancy outcomes, and this is a meta-analysis. So this concludes that metformin treatment in women with PCOS throughout pregnancy could increase the possibility of term delivery, full-term delivery, vaginal delivery, and reduce the risk of early pregnancy loss, preterm labor, pregnancy complications such as GDM, PIH, with no serious side effects. Moreover, metformin was not teratogenic based on the limited data. So the authors recommend that metformin treatment for women with PCOS during the whole pregnancy should be advised to the patients for the betterment of mother as well as the baby. So this was a meta-analysis, and they found that metformin has been useful in various aspects. This is another meta-analysis which is looking at the utility of metformin in preventing GDM. So this meta-analysis concluded that if PCOS patients continue to take metformin, the risk of GDM reduces significantly. Now, based on so many studies which have shown so many beneficial aspects of metformin, the government of UK endorses metformin to be used during pregnancy. This is from the official website of government of UK, and they say that the national guidelines in the UK already recommend metformin for use in diabetes during pregnancy and GDM if a healthcare professional feels it appropriate. So irrespective of whether the patient has PCOS or not, the UK government authorities recommend the use of metformin in patients with GDM or diabetes in pregnancy. And there are so many studies, as I said earlier, but if you want a glimpse of all these studies or the available information regarding the use of metformin in pregnancy, this is a very beautiful review article written by Dr. Gagan Priya and Sanjay Kalra sir. And in this, you will find reference to n number of studies and meta-analysis on the use of metformin, the beneficial aspects as well as the harmful aspects. So I'll highly recommend this, that we should go through this particular review article. Now, what does the ADA say? So ADA has said that a meta-analysis of 11 RCTs demonstrated that metformin treatment in pregnancy does not reduce the risk of GDM in high-risk women with obesity, PCOS, or pre-existing insulin resistance syndrome. So the current ADA guidelines say that there is no use of metformin if you want to prevent GDM. The second point, randomized double-blind controlled trials comparing metformin with other therapies for ovulation induction in women with PCOS have not demonstrated any benefits in preventing spontaneous abortions or GDM, and there is no evidence base to continue metformin in such patients. So again, they are highly against use of metformin. And they also mention about 2 RCTs in which the babies who were born to the females who were given metformin during pregnancy were followed for 4 years, and these found that the babies born to the mothers who received metformin had a higher BMI and increased risk of obesity during their childhood. Another follow-up study of around 5 to 10 years again showed that the offsprings who were born to such mothers had a higher BMI, waist to height ratio, and waist circumference, and a borderline increase in the fat mass. And that is why ADA does not recommend the use of metformin in such patients. So coming back to our case, now what would you do, or what should I do? So in my personal opinion, though it's a controversial topic, many of my gynecologist friends would like to continue metformin. Many of my colleagues also might prefer to use metformin because there is such a compelling data suggesting that metformin is useful in terms of maternal as well as fetal benefits. But I would personally go for a lifestyle modification in this patient, MNT by some registered dietitian, physical exercise. I will discontinue metformin in this patient. The patient has already crossed the first trimester. We'll start her on folic acid, potassium iodide, and low dose aspirin because the patient might be at risk of preeclampsia. Screen her for retinopathy and nephropathy. And also, I will advise her to do the home monitoring of blood pressure because the patient might develop hypertension or preeclampsia during the pregnancy. Self-monitoring of blood glucose and CGM I will offer to the patient, and I will put the patient on basal bolus insulin therapy. So I think that was my last slide. I thank you all again, and I end my presentation here. I will have to leave soon because I have another talk in some other conference. So maybe for the discussion, you already have the other speakers here, and you all can discuss it. Is it fine, Dr. Amit, Dr. Rutul? Am I allowed to leave? Dr. Hina? Actually, I have I'm attending a conference there. I have a talk immediately right now.
Yes, sir. Your presentation was wonderful, sir. Thank you. Thank you for your lucid explanation, sir. So we'll go for the.
Sure.
Yeah, you can leave, sir.
Sure. Thank you. Thank you, Amit. Rutul again. Thank you.
So, Dr. Birju?
Yeah. Thank you, Hinaben, and good afternoon. Our next speaker is Dr. Balaji Jagmohan. He is MD, postgraduate diploma in diabetology from UK, fellow in diabetology. consultant physician and diabetologist at Apollo Sugar Clinics, Bangalore. He is also into academics, a tutor in Medversity and fellowship in diabetes program, executive committee member of Apollo Sugar, visiting faculty IIM Ahmedabad. He is a founder and trustee of READ Foundation and Pearl. He has been conferred upon many awards like Best Clinic among Apollo Sugar Pan India 2016 Award, Best Clinician and Clinical Services Pan India Apollo Group 2017, Best Diabetic Center Apollo Group in 2018, Pillars of Medical Sciences Best Emerging Diabetologist in Bengaluru 2021 Award from the Health Minister and Government of Punjab, Unsung Heroes Most Prominent Diabetologist in Bengaluru 2021 Award from the Indian Chamber of Commerce in collaboration with Bombay Stock Exchange. And he has got various publications and poster presentations to his name at various national and international conferences like RSSDI, ADA, AACE poster presentation, and several publications in peer-reviewed journals textbook. So it's indeed an honor to introduce and welcome Dr. Balaji Jagmohan for his talk.
Thank you, Dr. Birju. Thank you, Dr. Hina. At the outset, I'd like to thank Dr. Amit as well as Dr. Ritul for having invited me for this prestigious conference. If you can give me access for screen sharing, please. Okay. Okay, my screen is visible now?
Not yet.
Yes.
Is it visible?
Yes.
Yes.
Okay, I'll put it on full screen. Is that fine?
Yes. Yes, sir.
Okay, so thank you and good afternoon to all the delegates who've joined for this webinar. It's indeed a pleasure to talk on a topic which is very relevant if you see in the pregnancy period, because these are the two most common endocrine abnormalities that we get to see during pregnancy, and that is hypothyroidism and gestational diabetes. So without further ado, this is the outline of my presentation. So I'll try to show two short cases, and then I'll try to talk about the pathophysiology of hypothyroidism and gestational diabetes. Then what does the algorithm as far as the recommendation of management of hypothyroidism in pregnancy and GDM states. Then there are some other guidelines, some national as well as international guidelines, which talk about the management of hypothyroidism in pregnancy and even in women who have gestational diabetes. And then lastly, I'll try to summarize my talk. This is the first case. Now we have a 33-year-old prima gravida. Now she's a known case of hypothyroidism. So she's already taking levothyroxine replacement therapy for her condition for the last 5 years. And currently her TSH is around 1. Her BMI is 32 and she has a positive family history of type 2 diabetes. And in fact, her mother had a history of gestational diabetes. Now, the antenatal checkups thus far have been uneventful. In the first trimester, in fact, the TSH was around 1. And in the second trimester at 24 weeks, a random blood sugar revealed that it is around 176. So she was advised an OGTT at this point. If you see the OGTT result, 75 grams glucose load was given, the fasting has come to 105, and after giving 75 grams, the 1 hour value is 191, and the 2 hour value is around 178. So she's been diagnosed to having hypothyroidism with gestational diabetes. So she's been started with lifestyle modification and basal bolus regimen for the management of GDM, and the LT4 doses based on TSH were adjusted subsequently. I come to case 2. Case 2, again, 32-year-old female. Now she's already nearing the third trimester, ending the second. BMI is 31. She has a positive family history of type 2 diabetes, and the antenatal checkup thus far for thyroid has been normal. And also the blood sugar monitoring during the first trimester was normal. But now at the second trimester towards the end, you can see the OGTT results again with 75 grams. The fasting is 95 after 75 grams. The 1 hour value is 175 and the 2 hour value is around 180. So she's been diagnosed now with GDM and she's put on a rapid acting analog along with lifestyle modification. Now, immediately after a few weeks, in the 38th week now of gestation, the TSH was measured and it was 8. And if you see the free T4, it has come to 0.2 nanogram per deciliter. So hypothyroidism immediately after GDM has been diagnosed, and she's been started with a levothyroxine 75 mcg with TSH monitoring to maintain with the target range less than 2.5 TSH. So there are two cases here. One is a case of hypothyroidism, and she then goes on to develop a GDM. And here the second case is you have someone who has GDM, and then subsequently in the third trimester, after a few weeks, she develops hypothyroidism. Looking into the published evidence, now there are a lot of studies. In fact, this is a meta-analysis that has clearly depicted that hypothyroidism has a clear role in glucose homeostasis and the development of gestation diabetes. There's another recent article published in 2022, and this clearly says that hypofunction of the thyroid gland and gestation diabetes have a relationship. Now, what is the relationship? In a hypothyroid pregnant woman, it is seen that the intestinal absorption of glucose is reduced, which is a good thing. Hepatic gluconeogenesis and glycogenolysis comes down. So the end result is that the hepatic glucose output and the post-absorptive glycemia comes down. So that gives a signal to the beta cells that, look, the blood sugars are within the normal range. So you don't have to strain too much to release insulin. But the whole catch here is the peripheral insulin resistance. Hypothyroidism increases peripheral insulin resistance and reduces the glucose disposal, also coupled with other hormones that are released from the placenta. So you have beta-HCG, you have human placental lactogen, you have estrogen and progesterone released from the corpus luteum. All of these hormones further increase resistance at the peripheral tissues, especially the skeletal muscle. There is a downregulation of the GLUT4 receptors. So there is postprandial hyperglycemia that sets in and hyperinsulinemia in the postprandial state. So to see in a nutshell this pathophysiology, hypothyroidism on one hand can reduce hepatic gluconeogenesis and glycogenolysis and reduce the absorption of glucose at the intestine. But it enhances the peripheral insulin resistance, it reduces the glucose disposal. So the end result would result in hyperinsulinemia and eventually that woman developing gestation diabetes. Here again, it is clearly shown the role of the placental hormone. So you have the placental human chorionic gonadotropin, you have the placental growth factor, proangiogenic factor, and soluble FMS like tyrosine kinase 1 factor. Now, these hormones are known to reduce the sensitivity of TSH to the thyroid gland, which means that TSH will not have an adequate stimulatory effect at the thyroid gland to release T3, T4. The end result is a reduced T3 and T4 secretion, and TSH eventually to compensate will go up. Now, this is an algorithm that is given by the American Thyroid Association in 2017. And they've clearly said that during the first trimester itself, we have to screen for hypothyroidism. So we have to look for TSH with reflex-free T4, which means you've ruled out any pituitary abnormalities. And if TSH is less than 0.1, treat it as hypothyroidism. And if it is between 0.1 to 2.5, then it's a normal thyroid function, no further workup. But if the TSH is between 2.5 to 10, then we will have to obtain a free T4 level. If the TSH is more than 10, then immediately you start with levothyroxine treatment. And if we get a free T4 value, which is below the 5th percentile, then there again, we'll have to substitute with levothyroxine treatment. And during the first trimester, every 4 weeks, we have to monitor the TSH and keep it below 2.5. In the second trimester, you can check it at least once to keep it below 3. Now, suppose the free T4 level is normal and TSH is between 2.5 to 10, then we'll have to obtain the thyroid antibodies. If antibodies are negative, then treatment is little controversial, not recommended ideally. But if it is positive, then again you go back to starting with levothyroxine therapy, monitor the TSH, and you follow the same protocol. Now, the Indian Thyroid Society, as well as the Federation of Obstetrics and Gynecology Society of India, they've clearly mentioned that all pregnant women should be screened at the first antenatal visit itself for the TSH levels, and this has a grade 2A and class B recommendation. And if you take a look at some of the international guidelines, you have ATA 2017, ETA 2014, and even ITS 2012. All of them have clearly said that during the first trimester, you need to keep the TSH less than 2.5, although ATA says you can even keep it less than 4. But during the second and third trimester, you have to keep it less than 3. There are certain markers which could be indicative of a potential risk of developing gestational diabetes if the woman already has hypothyroidism. So free T3 and free T3 to T4 ratio, if it is measured early in pregnancy, then that can be an independent risk factor for developing gestational diabetes. And it is shown that an increase in either of these markers can increase the risk of gestational diabetes after adjusting for all confounding factors like the BMI or even a family history of diabetes. So if you have an increase in free T3 to free T4 ratio, and there is a higher conversion of T4 to T3, then that is again a strong indicator of that woman developing gestational diabetes during the later part of pregnancy. ITS, Foxy again have clearly mentioned that if the woman has overt hypothyroidism, then we have to look at the TSH level, ideally keep it below 2.5. If she was newly diagnosed during pregnancy, then the starting dose of levothyroxine should be around 1.6 to 2 mg per kilogram per day. And first trimester, maintain it less than 2.5. In pre-existing hypothyroid patients, you might have to increase the levothyroxine dose by almost 30%. And then keep monitoring during the first trimester. Every 4 to 6 weeks, TSH has to be monitored. Once into the third trimester, between 26 to 32 weeks, at least once, the monitoring of TSH should be done. Now, if you have a euthyroid pregnant woman with thyroid autoimmunity, so here they're clearly saying that you'll have to check the TSH, you'll have to start levothyroxine and try to keep it below 2.5 in the first trimester and then below 3 in the second trimester. So there's a level B and C recommendation. Now, monitoring of thyroid function, again here, I've already mentioned it has to be done, TSH monitoring every 4 weeks. And the adjustment for levothyroxine should be done to keep it less than 2.5. In the second and end of second and beginning of third, anywhere at least once TSH has to be monitored and TSH has to be kept less than 3. That is my last slide, and these are the key take-home messages. Hypothyroidism and gestational diabetes can have interrelated pathophysiologies. There is a relationship based on not only genetic factors, but hypothyroidism itself can have a negative effect on carbohydrate metabolism and glucose homeostasis. So the risk of developing GDM is very high in pregnant women who already have hypothyroidism. In fact, during the first trimester, if a pregnant lady has a TSH more than 2.7, then some of the articles say that the chances of getting GDM increases by 8 times, and it is crucial to bring it down in order to prevent GDM. So on that note, I will finish my presentation and stop sharing my slide. Thank you for a patient hearing.
Thank you very much, sir. It was indeed a lucid and a very informative presentation. You made the correlation between thyroid hormones and pregnancy hormones and metabolic hormones interrelated very clearly. And as according to the schedule, we will keep the discussion at last. So may I request Dr. Hinaben to introduce the next speaker.
Thank you, Biju Bhai. So next speaker is Dr. Subhajyoti Ghosh. He is the affiliation and member of RSSDI from Dibrugarh Apollo Clinic, member of RSSDI, AIAARA, ADA, ACP, and his achievements are he is a rising star in diabetes Diacon 2019, awarded with best paper Diabetes India 2022 presentation, then Right to Health, converting dreams to reality by making health a fundamental right, Here's a study of risk factor of type 2 diabetes mellitus in rural population of Dibrugarh district. Then control of type 2 diabetes mellitus by community-based intensive multifactorial intervention. Then glycemic control through training of peripheral health workers. Correlation between diabetes and cardiac autonomic neuropathy. Then he is also the given study on a reversible model of metabolic syndrome and diabetic ketoacidosis in COVID new onset patients. Over to you, Dr. Shubhajyoti Ghosh. Sorry for my pronunciation, sir. Sir, you're mute. You're on mute mode. You're on a mute mode. Can't hear you, sir. Still can't hear you. Hello? Can't hear you, Dr. Bush. Mahima, just help him out, right?
Yes, ma'am. Sir, can you please join again?
Dr. Shubhajyoti, can you hear us? If you can hear us, just give us a thumbs up. Or you can just log out and log in again.
Can you hear us, Dr. Ghosh?
Dr. Hina, I think, okay, his audio is connecting. So must be some issue from his end. Yeah, so it's better he can log in and log out and log in. Or else we can take the next speaker and we can just wait for him to log back in again.
So he's the last speaker on our case discussion session.
Yes, right.
So Dr. Ghosh, you try to unmute again. It's showing mute. Can you hear us, Dr. Ghosh? Okay, so there is some problem from his side. I think he's joining again. We still can't hear you, Dr. Ghosh.
Dr. Ghosh, if you can put hands free, if you can insert your hands free and try.
Dr. Hina, Dr. Balaji, I think what he can try, probably he can log in from his mobile and we can share the screen here. He can try that, I think. He's trying that. Okay, I think he's trying that.
Okay.
So am I audible now?
Yes, yes, you're audible, but there's an echo as well. You'll have to switch off your laptop.
It's fine now?
Yeah.
Perfect.
So it's visible?
Yes, sir.
So good afternoon to everyone, all the delegates. And first of all, I would like to give a heartfelt thanks to the organizer of PSG, Dr. Amit and Dr. Rutul, for giving me the opportunity to speak. And this is one of the topic which is a bit interesting, like hyperthyroidism in GDM. So prior to going to any story regarding this case presentation, I will just want to highlight few points, like hyperthyroidism and pregnancy is uncommon. Like prevalence is 0.05 to 3% of the pregnancies. More of that, the clinical diagnosis of hyperthyroidism in pregnancy is difficult because the silent symptoms are almost seen in all the normal pregnancies. Until unless you got the specific finding of like weight loss, goiters, or ophthalmopathy. And to complicate it more, we find that the transient hyperthyroidism due to hyperemesis gravidum, so that complicates the scenario a lot. Thereby, to diagnose a case of hyperthyroidism, we need to confirm it by circulating free T4 and TSH. And already, so there are several studies which is saying that the overt hyperthyroidism documented with adverse hyperthyroidism has been documented with adverse impact on pregnancy outcomes. Despite its rarity, recognition and proper management of hyperthyroidism during the pregnancy is of utmost importance. So the story of today's case is a lady, Mrs. Adorable, of 32 years, who is a homemaker, is a member of traditional joint family, and a hobby of watching TV, painting, and dancing. So he came to the clinic with reported problem of intolerance to heat, significant weight loss, then pain of a neck and tremor. So on examination, found that the lady was at 6 months of pregnancy. Height was 156, weight is 68 kg. Blood pressure 132/80. Fasting was 120 and PP was 166. On examination, it was found that the lady had a palpable, painful, diffuse thyroid swelling, and the ESR was 110, and TSS was found out to be 0.009. And if you look into the case overview, we found that the family phenotype, the mother is overweight, father is obese, and there is a family history. There is a family history of diabetes and hypertension. So the diagnosis is that primary at 24 weeks of gestation with GDM with hyperthyroidism. So now a relationship between thyroid function during normal pregnancy. The relationship, it states that the pregnancy is a state of increased estrogenic state. Thereby we will find that in the increased serum thyroxine binding globulin, which lead to the increased high serum T4 total T4 and T3 concentrations. So during the first trimester, the stimulating effect of beta ECG on the receptors cause the fall in serum TSH level in the first trimester. But being aware of the changes regarding the serum free T4, TSH, and beta ECG level throughout the pregnancy would be helpful for interpretations of the thyroid function stage in hyperthyroid mothers. So, is that baby in the womb is at risk? So, what do we know that the likelihood of developing fetal hyperthyroidism during requiring treatment is related to level of maternal circulating thyroid antibodies level, then medicinal treatment given to the mother. So it has been shown that in a study that transplacental passage of stimulating maternal thyroid antibodies for hyperthyroidism or Graves' disease is 1.5% to the neonates when born to the mother Graves' disease. So it passes the placenta and stimulates the fetal thyroid and can cause to fetal hyperthyroidism, which may manifest as like fetal tachycardia, goiter, prematurity, heart failure, hydrops. So what can be the consequences of untreated hyperthyroidism during pregnancies? It can be like low birth weight, it can be like prematurity, it can be like eclampsia or the risk of miscarriage or like small bore gestational age of infant. So there have been some controversies regarding like the Graves' disease untreated should be treated or not treated. And prior, like our earlier speaker have already spoken about GDM. So only thing I want to highlight is that the GDM have in the past 20 years, its prevalence have increased substantially across the globe in multi-ethnic populations. So what we are seeing now is that 1 in 6 live births affected by hypoglycemia in pregnancies, 80% of them are having, mothers are having GDM. So this is a idea for we find that southeastern regions have the highest number of pregnancies with hypoglycemias in compared to the rest of the world. So now, if you look into what the prevalence of diabetes and thyroid dysfunction, like from large European meta-analysis, they found that 3.82% of the populations they have thyroid functions, and the prevalence among those with type 2 DM is significantly higher, like around 48%. Now, these are few recommendations saying about the thyroid screening. So mainly they're saying that in any high-risk woman, the serum TSH should be tested at the baseline along with the reflex anti-TPO should be done if TSH is at a range of 2.5 to 10. And along with that, thyroid palpitations and serum TSH should be monitored in your patients. But we don't have any specific criteria about for thyroid screening in type 2 DM patients during pregnancy. But still, the things to be remembered about that the excessive circulating thyroid hormone in hyperthyroidism is associated with poor glycemic control, which can lead to hyperglycemia and insulinopenia. Like when the normal individual develops hyperthyroidism, nearly 2 to 3% of them develop overt diabetes. Nearly 50% of those with diabetes with Graves' disease have some degree of glucose intolerances. Like thyrotoxicosis can precipitate diabetic complications such as diabetic ketoacidosis. Then endothelial dysfunctions increases the risk of cardiovascular comorbidities too. So if you will compare, if you look into a scenario of diabetes or like GDM with thyroid dysfunctions and pregnancy, we find a very complicated story, which will be like pregnancy hypertension, a patient, the lady may end up with preeclampsia. They might have like postpartum hemorrhage, they may have preterm delivery along with low birth weight for the babies. Now, how this hyperthyroidism affects? Because hyperthyroidism, what they leads to like increase in glucogen expressions and the glucose uptake in the skeletal muscles. So here they find that hyperthyroidism reduces the glucose-induced insulin secretions, whereas the hyperthyroidism enhances the response to beta cell functions to glucose. So thyroid hormone also increases the glucagon secretion of pancreatic alpha cell. Found to have like insulin autoimmune syndrome have been reported in Kalimazoo. So now what can be the best choice of drug? with hyperthyroidism and pregnancy, mainly the treatment is about antithyroid drugs, because in case of pregnancy, we cannot go with RAI or like surgery. So the treatment of choice will be like either methimazole or propyl thiouracils and carimazole. So if you look in the pharmacokinetics, you find that methimazole is not altered in pregnancy. Then then in the first and second trimesters, and the use of PTU should, that is propyl thiouracil, should be restricted in the first trimester of pregnancy only. And beta-adrenergic blockers may be used, but need to be very much limited, because there is also a possibility of inter-uterine growth retardations, transient neonatal hypoglycemias, apnea, and bradycardia. So now, regarding about, we are always concerned about transplacental passage of the molecules. It will see into both the molecule of methimazole and propyl thiouracil. You find that even though it's said that the PTU is extensively bound to serum albumin, but which is hypothetical linked, but it found that the passage is almost similar for both the molecules. Then the studies show that the transfer rate of across the placenta are independent of the perfusion, and this might be due to the highly efficient placental extraction of unbound drug. And also, it has been shown that for the level of propyl thiouracil in the cord blood was higher than the maternal concentrations in hyperthyroid pregnant ladies. And regarding the monitoring and adherence, like for any patient, we need to either start with methimazole of 10 to 20 mg, or you can start with PTU like 100 to 200 mg. The thing is that after first trimester, we need to trace the patient to methimazole, and at the end of after every month, we need to check the patient's free T4 in the upper level, free T4 in the upper 1/3 of each specific intervals. Serum TSH level of 0.1 to 2 is appropriate, but if the TSH is 0.1 is also acceptable if the patient is doing well clinically, and the serum T3/4 is within the appropriate range. So there can be a case where we can find patient need to have like subtotal thyroidectomy. In that case, suppose like the patient is having high free T4 and serum TSH is low, and if you are finding the classical features of their disease, then we'll go with the medical management. Suppose the patient is having the same pregnant lady is having the weight loss, nausea, vomiting, then we have to go for a ultrasonography, and we find that there is a heredity for more than we can get it. Okay, we need to go for the supportive thyroidectomy and the surgical procedures, all everything. Otherwise, we need, like if the patient is having gestational thyrotoxicosis, then we need to give a supportive treatment. So in case of like earlier, our Dr. Rakesh Parikh sir have already spoken about the treatment of GDM. And what I will just try to highlight about the insulin is the preferred medication for treating hyperglycemias. So the conclusion is that thyroid dysfunctions can worsen type 2 DM and diabetes, and can worsen the thyroid function too. So anti-diabetic drugs can alter thyroid function, and anti-thyroid drugs can also alter glucose control. So considering into the clinical implications of coexistence of type 2 DM and thyroid dysfunctions, and more systematic approach of thyroid testing on type 2 DM is needed. Regular monitoring of glycemic control with thyroid dysfunction is also suggested. More research is warranted to study the relationship between type 2 DM and thyroid dysfunctions, and especially more about hyperthyroidism in GDM, because literature is very sparse to get it. So to conclude the story, that Mrs. Adorable was treated with and followed up as with anti-thyroid drug, lifestyle and dietary modification have been done, because he can blood sugar was came into control with lifestyle and diet modifications, because no drug was needed over the period of next pregnancy, over the period of next second and third trimesters, and he was monitored monthly and delivered and healthy term girl and released within the 4 days after delivery. Thank you.
Thank you so much, Dr. Ghosh, for your lucid presentation. Almost everything was covered, and thank you so much for joining the session. And if any questions,
Dr. Hina, I would like to come in with a few comments and questions. And First of all, congratulations to all of you for discussing thyroid disorders in pregnancy. I think it's a very important topic. And since this is a case discussion symposium, and we have some time in hand, as I can see, so I think one very important clinical entity is subclinical hypothyroidism and subclinical hyperthyroidism. So I have a question to each one of you, Dr. Balaji, Dr. Shubhojyoti, Dr. Hina, Dr. Birju. How would you approach a case of subclinical hypothyroidism and hyperthyroidism in pregnancy? Your clinical experience and your practical approach. We're not talking about guidelines because this is a case discussion symposium. So I think we can have a small discussion on this. I think that would make the discussion more fruitful. And also quick, thoughts from your end about the referrals, because, in thyroid disorders, we often see that the referrals come into a physician or an endocrinologist a little late as compared to that, the referral for diabetes. So I think thyroid disorders in pregnancy need to be highlighted a bit more. So let's start with this discussion of subclinical hypothyroidism and hyperthyroidism. So I think we can start with Dr. Balaji, if he's still there with us.
Yes, definitely.
Yes.
Yeah, that's a very valid point, Dr. Amit, as you rightly pointed out. I think subclinical hypothyroidism, in fact, is much more common than an overt hypothyroidism that we get to see. So here what happens, we have the free T3, T4 levels, which are in the normal range, but you have the TSH, which is elevated. So such kind of woman, again, we will have to see the symptoms, what symptoms she has. Again, in pregnancy, it's very difficult to gauge whether weight gain has happened, depending upon which trimester. We'll have to look for cold intolerance and other symptoms suggestive of a hypothyroidism. And very important here is we have to look for the anti-TPO and the anti-thyroglobulin antibodies. So these are the two antibodies that I generally do a workup for. If the antibodies have come positive and if you have a TSH that is well above 2.5, then we have to substitute with levothyroxine treatment despite having a free T3 and T4 within the normal range. So that's what I normally do in my practice.
Great. Dr. Shubhojyoti, you want to come in on how would you approach a case of subclinical hypothyroidism? How often do you get a referral for this in your clinical practice as well?
With that, I would just like to highlight that recently, last month only, I got a referral from a senior gynecologist. The patient was referred with a TSH level of less than the normal. T4 was higher. Then the very next incidence, I asked them that to do a free T4. So we have found that free T4 was fine, and the patient didn't have any complaint of hyperthyroidism. So this is also one thing, she is having an subclinical hyperthyroidism, but which need not to be treated because the lady was at most possibly 3rd month of pregnancy. Because even if you look into the guidelines, there is still a point of controversies is there regarding the treating with all anti-thyroid drug, methimazole, propylthiouracil, because all these molecules, they are still not been comprehensively said about the teratogenic potentiality of those drugs. But if it is like overt hyperthyroidism, then we need to treat it. Other subclinical, we can wait and watch, and we can monitor it monthly wise, and we can just ask the mother to avoid few of the things and just go keep regular monitoring in the case.
Right. And I think the trimester at which you get the patient is also very important in deciding whether you will initiate treatment or not. Dr. Hina, Dr. Birju, you want to come in with your comments, your quick thoughts on how would you deal with a case of subclinical hypo and hyperthyroidism in pregnancy?
Yes, sir. I would like to go with Dr. Balaji because we have been getting and referred these patients very frequently, not so frequently as GDM, but definitely we have been getting these patients, and I usually follow the footsteps of Dr. Balaji, whatever he has said. One thing I would like to add is more frequent monitoring of thyroid function tests. If it is a subclinical variant, more frequent rather than whatever the guideline says, I just try to monitor at least TSH more frequently and see the trend in which it is moving, whether it is gradually going up or down or stable, and also free T4. So that's the way I go about for the thyroid subclinical hypo or hyperthyroid with diabetes. Sorry, GDM.
Right. Dr. Hina?
Yeah, I agree with both Dr. Balaji and Dr. Birju, sir. Mostly we have seen subclinical hypothyroidism more in GDM rather than hyperthyroidism. And as far as trimester is concerned, we usually see lesser, the TSH levels goes down. So symptoms we have to also, monitor, and the patient, especially in hyperthyroidic GDM patient, subclinical especially. So it's very difficult to diagnose first. Subclinical hypothyroidism, we all know that we have to keep the TSH below 2.5. So it's not, we might not go to, sometimes patients are not able to afford the anti-TPO antibody tests and investigations. So for the better development of the fetus and better development of brain development of the fetus, we can go for thyroid treatment, and also we can keep on monitoring that the patient the mother after postpartum requires the treatment or not. So irrespective, it's very important to treat hypothyroidism, subclinical hypothyroidism in pregnancy, because it helps eventually the growth of the baby. And hyperthyroidism subclinical is little controversial and not very frequently in practice. So I have more experience of hypothyroidism subclinical rather than hyperthyroidism. So
just one point
more about hyperthyroidism in GDM.
Just one point, if I may add. Sorry to interrupt, Dr. Hina. See, there's a condition called isolated hypothyroxemia. It's a rare condition wherein you have only the T4 levels which will be low. T3 and TSH will be normal. But if you have antibodies positive, anti-TPO positive, you might have to treat such conditions. You'll have to substitute with levothyroxine. So that's another thing. Apart from overt hypothyroidism, subclinical, this is another entity, isolated hypothyroxemia, but it's a rare one.
Okay. But as we go for free T3 and free T4 in pregnancy, so that becomes more diagnostic and helps us for further management. So as you rightly said, yes, I can also that this was a new thing for me. Thank you.
Thank you.
Thank you very much to all four of you for your insights, and I would hand it back to the chairpersons to take it forward.
So thank you everyone for having us. We can move forward to next session. Thank you everyone.
So would invite the next chairpersons, Dr. Dhrumil Patel and Dr. Akash Prajapati, to take over.
Hello. Okay. Am I audible?
Yes, you're audible. Go ahead.
Okay.
Yes.
So, first of all, good afternoon to all. And I would like to congratulate Dr. Rutul sir, Dr. Akash, Amit sir, Dr. Dharmendra sir for organizing such wonderful PSG conference, and would like to congratulate and thanks for inviting me as a chairperson for this case symposium. First speaker is Dr. Kunal Javeri sir. He's MD Medicines, consultant, physicians and diabetologist. He is the director and founder of Vises Clinic of Internal Medicines and Dr. Kunal's Diabetic Club, Ahmedabad. He's done PG, PPM diploma in diabetology, Chennai. He is diabetology fellow, Middlesex University, London, and he is an assistant professor, Kesarsal Medical College, and also a member of RSSBA. So, without any investing time, I would like to invite Dr. Kunal Javeri sir for your next case.
Thank you, Dhrumil. Should I share my screen? Can somebody allow me to share my screen? The people from the IT department have to allow me to share my screen. Yeah.
Yes, sir, you are allowed.
Yeah, I'm just sharing it. Okay, so am I audible?
Yes.
And my slides are visible now?
Yes.
Fine. So thank you. Good afternoon to all of you, and a very warm welcome for all the delegates on the PSG. And before I start with my talk, I must thank Rutul, Dharmendra, both of them, and the team of Dayacare and Bansi sir and all the faculties and people who have been involved for day and night hard work to create this success. And I'm really happy to be a part of this since the beginning of the story. And I would also like to thank Dr. Maulik and Dr. Padmanabh to help me out also for a certain part of the presentation, because I believe that this is something which is really very challenging for any diabetologist or an obstetrician to go for. And I will come to know on this case when we'll discuss out. So I will try my best to complete my talk in 15 minutes of case presentation, which is time allotted. So my case presentation today is about the pre-existing type 2 diabetes in pregnancy. Now, friends, let me be very clear that diabetes in pregnancy could be in two parts. It could be pre-gestational diabetes, where it could be a pre-existing diabetes type 1 or type 2, and it could be a gestational diabetes. So what I will be touching today about a case will not be about the gestational diabetes or type 1 diabetes, but it will be all about the type 2 diabetes in pregnancy, which is pre-existing. And my focus of patient's case would be concerning more about the preconception counseling and management during the pregnancy, which I believe is more practical to as a take-home message of how practically we deal with the type 2 diabetic patients, right? So labor and intrapartum and postpartum, already the cases are there in the further. So this would be my agenda today for the talk about the prevalence, why to worry, how the treatment is effective, about the case study, about the counseling, about the therapeutic options of medical nutrition therapy, exercise, and particularly, very obviously, pharmacotherapy, about the insulin and OHA, and obviously the take-home message. So before I start with my case, let me have a context to understand about why this case is very important, because there are multiple contributors to the maternal fetal complications. According to the FIGO, 127 million live births across the world. So this is one of the top 5 leading causes of maternal fetal complications. 21 million pregnancies across the world, they are complicated with the hyperglycemia. So prevalence itself is a big challenge. Out of 127 live births per year, nearly 21 million per year are complicated by hyperglycemia alone. And amongst them, 3 to 4 million are detected and treated. Unfortunately, the rest all goes undetected. And to receive the postpartum follow-up again, the lot of women are lost. So nearly more than 4 million cases in India are occurring. And again, the same amount of people and women, they are going unnoticed. Now, why is this worrisome? Let's understand from the ancient wisdom of India. We all know about the story of Veer Abhimanyu, who had an intrauterine programming of understanding how to enter into the Chakravyuh, but he could not came out. And we all know what happened to that Vidyodha. The same has been proven by modern science. And we all know that organogenesis occurs early in the first trimester, before the woman even first reports to the antenatal clinic. And by that time, already the organ damage and genetic program is already done. And what complications they come up with if we don't control sugar for this diabetic woman? It would be spontaneous abortion, fetal anomalies, preeclampsia, fetal demise, macrosomia, neonatal hypoglycemia, hyperbilirubinemia, and neonatal respiratory distress. Not only that, a kid in the future also would have obesity, hypertension, and type 2 diabetes. Now, is there any treatment benefit which is associated once you control the sugar? So that's clearly evident by the ECHO study, which says that nearly 1,000 women with GDM were considered for the routine treatment versus the intervention with insulin and so on and so forth. They have found that there is a clinically significant benefit to the women who have been treated with intensive care group with insulin and other benefits versus the potential complications of non-treating them for the diabetes treatment. So there is a clinical evidence available to benefit this. So with this background and with this understanding, a real life case I'm putting forward to you. She is 34-year-old female, Mrs. Desai. With no previous pregnancy, she came to the diabetes clinic with type 2 diabetes on OHA. She is overweight. She has PCOD, who is willing to have pregnancy, but not for insulin referred, not willing for the insulin. She is referred by a gynecologist for sugar control and advice. On detailed history, she had diabetes for 4 years. She had an onset of diabetes at the age of 4 years. At the age of 30 years, so 4 years long duration of diabetes. Vitals were pretty normal, except for the BMI was 29.43, so she's quite obese, quite overweight. Initial investigation showed fairly uncontrolled diabetes, which is a common story in India because she had never turned back to the proper way of understanding of diabetes and their management. So fasting was 171, postprandial sugar was 252, HbA1c was 10.4. She was on metformin 1000 mg BID, glamipiride 1 mg BID. Pioglitazone 7.5 mg OD and linagliptin 5 mg OD with combination of empagliflozin 25 mg OD. But unfortunately, she was on irregular medications and she was not following any dietary or exercise advices. She also had PCOD, for which initially actually metformin was started 2 years back before this, and then she turned out to have diabetes and this management was continued. Now, when she was referred to us, We had a detailed and team-based counseling done for both the partners. They were explained about the contraception till the HbA1c goal of 6.5 is not achieved. Pre-pregnancy evaluation was done. I'm not going into the detail. All the gynecologists know what to be done. So thyroid and TPO antibodies, and we'll come to know if the time permits for the guidelines. Diet counseling was done. Exercise was initiated appropriately, and pharmacological treatment, which was continued, was one. Metformin, 1 gram BID was continued, looking to the PCOD background, and because she had fertility issue also, and she was explained to stop on the confirmation of diagnosis. But as per the patient's willingness and consent upon the gynecologist also, she had a determination that she is going to continue for the first trimester because she was not ready for the higher doses of insulin. Pre-pregnancy, on detailed explanation, she accepted insulin therapy. All other OHAs except for the metformin, which was stopped. She was started with the basal bolus therapy, where insulin datamine 10 units before breakfast was added, and insulin aspart, which was started, which was a fast-acting insulin aspart, which was given pre-meal 3 divided doses for 4 units to start with, and SMBG was explained. She was non-pregnant at that time, so Freestyle Libre device was also explained, and she purchased it and she started using those data. With that, SMBG and Freestyle Libre device advice, we uptitrated her basal insulin to 14 units before breakfast, datamine, and aspart 88 units. After 3 months, when she came back, her fasting was 98, postprandial sugar was 100, and HbA1c was 6.6. So with the reasonable control, she was permitted to stop the contraceptive methods, and she was conceived, in fact, with the IVF a few weeks later. Now, intrapartum management. During the pregnancy, how she was managed. For the first trimester, a patient was offered to discontinue metformin, as explained earlier, but with the gynecologist help, she decided that with the consent given, she decided that she may continue with the metformin because she was not ready for the very high doses of insulin, right? So same dose of insulin and metformin were continued, and her SMBG was continued, and she did well. For the second trimester, the injection datamir was uptitrated up to 18 units as a basal, and bolus aspart was 10, 10, and 6 units. As naturally expected, the second trimester, the insulin requirement will go up. And for the third trimester, again, datamir was increased up to, was continued to 18 units, but insulin aspart requirement reasonably increased to 10, 12, and 4 units. According to the SMBG, this was managed. So these are the details of her investigation. I'm sorry for the busy slide, but there are details of her fasting sugar, the postprandial sugars, the random sugars which were measured, HbA1c details, and all those parameters which we measure. But to make it very easy for you to understand, these are the graphs of her fasting sugar and postprandial sugar. There was one spike in between. She had chikungunya fever, but fortunately she did well. That was the time when she had a fasting spike. But if you see the overall tendency from 200s to 100s, sugar started going down. This is a graph of her HbA1c. Again, when she started was around 10.4. When she ended up was below 7. So this is her HbA1c. So how delivery occurred? She had actually was planned for normal delivery, but she had a cord around neck, and because of some fetal distress in the brain cerebral artery, she was asked to go for the emergency cesarean section. And in fact, it did well. Baby was healthy and with a normal cry, 2.9 kilogram of weight, and no other maternal or fetal complications were observed so far. Insulin dose was managed during the delivery and postpartum period as per the guideline. So there was definitely a happy ending. Now, how we could achieve this happy ending was absolutely is absolutely based upon the guideline. So counseling, management, and pre-existing diabetes and pregnancy. So I would try my best to complete my next few slides just to make a brief history and making understand for the how to manage this type 2 diabetes who are entering to the pregnancy. So pre-pregnancy counseling in detail, if I have to explain, we have to educate and obtain maximum cooperation from both the parents. We have to make them explain that HbA1c should be less than 6.5. Fasting, pre-pregnancy should be less than 100 and postprandial less than 140. This is not during pregnancy. The criteria are different as per the DIPSI guideline. We have to emphasize the need for strict diabetes control and prevent maternal fetal complications. We have to check thyroid, as we discussed in the previous slides also and previous session also, TPO antibodies if needed. We have to check the immune status against rubella, and all entire battery of tests has to be offered, which were offered to this patient. Multidisciplinary approach is mandatory for this kind of patients, and these are also endorsed by Diabetes Care and DIPSI and a lot of guidelines across the world. Please remember that these patients are at extreme psychological stress, their entire families are at stress. And by and large, I believe that diabetologists, physicians or obstetricians, whomsoever are involved with this delicate cases are also under psychological stress. So unless and until you are not very well versed with this kind of handling situation, you have to keep in mind that counseling, diagnosing depression, relieve them for these all issues, and giving them assurance is also important. So as far as pre-pregnancy care is concerned, HbA1c 6.5 is nearly mandatory. Canadian guidelines says that at least less than 7 has to be endorsed. If patients on the OADs, it is ideal to switch over to the insulin if pregnancy is planned. Hypertension control can be done by alternative medications, but not by the ACE inhibitor, ARBs, and thiazides. They are contraindicated. Detailed retinal examination has to be performed, which was performed for this patient, but she did well actually. But laser photocoagulation is mandatory for somebody who is having long-standing diabetes and have proliferative diabetic retinopathy or NPDR also. Renal function, creatinine clearance, proteinuria management is also important. Even if patient is dyslipidemic, statins are contraindicated. So please remember, we have to stop. And all are endorsed by Diabetes Care Journal and all DIPSI guidelines. Now, as far as brief management, I have to explain, there are 4 pillars of management by which we could achieve this patient to have a wonderful outcome of the pregnancy. They are medical nutrition therapy, exercise, insulin, and oral anti-diabetic agents. So what are the basic principles of medical nutrition therapy? Because this part is going to be discussed by type 1 diabetes, GDM, or type 2 diabetes, or even for the pre-diabetic patient entering to the pregnancy. So I will be very brief to just have an outline of this, looking to the time constraints. So meal plan should be tailor-made. Small frequent meals are always better to avoid hypoglycemia. Avoid prolonged fasting. Bedtime snacks are very important, and ensure adequate hydration, 8 to 10 glasses of water per day. Recommended net weight gain are very, very clear in guidelines that underweight patient less than 18 should have a recommended weight gain of 11 to 13 kg, so on and so forth. For our patient who had overweight, 24 to 30 BMI, 5.5 to 8 kg, and she gained around 7.5 kg during pregnancy. So that's reasonably well. Energy requirements are also very clear for sedentary, moderate, or heavy workload pregnant women, which could be around 2250 to 3200 kilocalories per day. And as far as the underweight and overweight and obese are concerned, you can have a plus or minus of 500 to kilocalories per day over and above these. Energy distribution are as per the recommendation by the routine patients, except for the high requirement of some carbohydrate should be deliberately given as far as your weight is concerned. Folic acid, calcium, iron, B12 supplementation is also important. As far as exercise is concerned, the basic principles are very clear that 30 to 45 minutes per day of exercise is really required. You have to break up an extended period for sedentariness, complementary. You have to complement dietary recommendations and activities which are increasing the blood pressure, like lifting heavy weights and pushing heavy objects should be avoided. Otherwise, if obstetricians has a requirement of restriction of physical activity, we have to comply. Please remember, unless and until you have target clear in your mind, you won't be able to achieve your goal. So it's very clear, pre-pregnancy HbA1c has to be maintained less than 6.5. Intra-pregnancy monitoring of HbA1c is not much validated for a lot of reasons, but fasting plasma glucose, and this is I'm quoting with the DIPSI guideline, fasting of 90, postprandial of 120, and a mean average of 105. This is something which we are looking forward. We have to try our ways to this. And please remember, don't worry about hypoglycemia because they are very less likely to happen during pregnancy because of the natural hormonal balance. And weight gain of the baby or a weight of the baby should be between 2.5 to 3.5. So if you keep these values in your mind, you will be able to achieve this. Monitoring of blood glucose, I will just have a one slide. At least 4 times per day, SMBG is required, fasting and 3 postprandial. And after achieving the target, you can go for the lab investigation after 28 weeks till once a month, 28 to 32 weeks, twice in a week, more than 32 weeks a week. And other parameters also have to be monitored. Now, as far as insulin therapy, so I will complete in 3 minutes. I hope I have 3 minutes. The chairpersons, do I have 3 minutes to complete?
Yes, yes.
Fine, thank you. So insulin and FDA pregnancy category, this slide is very, very important because a lot of physicians and people have worry about what insulin to be used. So this is what I have quoted from the PubMed, one of the review article. The regular insulin, Aspart and Lispro have category B, right? So they can be used. They are the short-acting insulins, but as far as intermediate-acting insulin, NPH is also having category B. And Datamine is one of the choice of insulin because it is one of the only long-acting insulin which is approved as a category B for US FDA to be used in pregnancy. But Glulicin, Dagludec, inhaled human insulins, all are category C. And for Glargine U100 and Glargine U300, we really do not have human data. Previously, it was category C. So whenever you require short-acting insulin, my message would be to use Aspart. And the basal insulin, better to use Datamine. If patient is non-affording, you can go for NPH or 3070 preparations. So here is the action profile of the insulin preparations. Short-acting aspart, lispro, glulisin, and regular. Intermediate-acting NPH, and long-acting would be determined. Preferably, I would hope that some data would come for the glargine or degludec, where they are really more physiological. This slide would be very, very important as a take-home message that dose of insulin is trimester specific. This is not a routine physiology of any human being. So initially, first nearly 20 weeks, there won't be a major change. Once you have achieved your HbA1c level, you may maintain as these happened for this patient in the same trimester. But second trimester onward, particularly 20 weeks onward, there will be drastic increase and gradual increase in the requirement of the insulin, basal and bolus both. But there might be some shortfallings after 36 weeks or steadiness, which you'll observe. So these are the dosage guideline. I won't go into the detail of busy slide, but it is as per the week. You can go for 1 to 13 week, for example, 0.7 into 0.7 unit per kilogram, so on and so forth, up to 1 unit per kilogram. The basic principle remains the same. If your fasting is on higher side, go for an increment in the basal unit. If your post-breakfast, post-lunch, or post-dinner sugars are on higher side, you can increase the rapid-acting insulin analog before the same day. As far as the insulins are concerned, as I said, insulin analogs are better because they have immediate onset of action. Particularly, I would endorse the fast-acting insulin aspart, which is available as an FIASP, because to control the first post-hour, 1 hour plasma sugar to the range of 140, which is also debatable. But yes, a lot of physicians are also chasing it. This is one of the best molecules to have for. As far as long-acting insulin is concerned, I think Detamir is only approved. The rest of them are as off-label indications. Premix insulin could be good in the setup where this basal bolus therapy looks complex, but please remember it has its own caveats and side effects. So I would not prefer or recommend it on a higher side unless the issues of understanding by the patient or on a busy OPD, doctor do not have time to spare. And continuous subcutaneous insulin infusion pumps are also good, but the cost is also a disadvantage. So you can use if you are very well versed and patient is affording. As far as the anti-diabetic drugs are concerned, metformin is something which is across the world debatable. Initially, it was continued in the PCOD, and then there was 1970s study which showed that there is no major difference in parental outcome. However, there is no major study which are done. But one of the study which I would like to discuss in this forum is about the MIG study. The metformin in pregnancy study was done in 751 women with JDM, randomly assigned at 20 to 23 weeks of gestation, who received metformin versus insulin. The primary composite outcome was that how did these feed well? Did and how this pregnancy ended up. The results were very promising. 92% of the women continued metformin to the term and 46% needed supplemental insulin. But there was no significant difference in the primary composite outcome as far as the side effects of neonatal or mother is concerned. That clearly says that there are no serious adverse events with this metformin. But what could be the current status? So the final verdict is there are possible concerns for placental transfer of 10 to 16% and neonatal hypoglycemia. Currently, metformin is not accepted as a first-line therapy. It is always insulin. But women on metformin for PCOS may continue the drug during the discussion as our patient had been continuing. However, more evidences are really needed before metformin can be recommended as a first line of agent during pregnancy. Glibenclamide, big no, high risk of adverse events or outcomes are there. I'm quoting it from BMJ and other OADs like the thiazolonidions, DPP4s and GLP-1 and lot others are not great for pregnancy because there is no enough evidence. So I'm just concluding my slides. This is the last slide perhaps which I'm going through is women with pre-existing diabetes, particularly type 2 diabetes, should attain optimal glycemic target, that is HbA1c of less than 6.5 before the conception. Till then, please follow the contraception. Fasting of 90 and ppbs of 120 while pregnant is very, very mandatory as per the DIPSI guideline. The counseling of both partners, multidisciplinary team approach are very required. Medical nutrition therapy, exercise, and pharmacology all are integral part of the treatment. But amongst all the treatment, insulin is the treatment of choice. And as far as metformin is concerned for the management, you may continue during the pregnancy women who have been receiving it for the PCODs for conception, but still metformin is still not validated for at least initial first few weeks of the pregnancy. We can quote the mixed study after 20 weeks, you may use it to cut down the dose of insulin. Right. So I would end my talk by saying Professor V. Shishya's words that diabetes-free generation, if you really want, you have to focus on the fetus for the future. So please control your sugars well during the pregnancy. As this case had a happy baby and happy mother, I wish all of you would do so after this session. Thank you so much.
Thank you, Dr. Kunal Javeri sir, for your lucid and indeed presentations on how we should take care type 2 diabetic women who becomes pregnant. Thank you very much. So we will take question answer session at the end of the this session. So I would like to ask Dr. Akash Prajapati sir for inviting our next speaker.
Yeah. Thank you, Dr. Dromil. And now I would like to invite Dr. Nishil Chovatia. He's done his fellowship in Department of Endocrinology and Diabetology. He's working as a consultant diabetologist and endocrine specialty at Diabetic Clinic, Surat since 2020. And he is also visiting faculty at multi-speciality hospital in Surat. And his research work, and it is a paper presentation in the clinical study of the patient of the hepatic encephalopathy at Susa Medical College, empagliflozin and linagliptin, FDC and add-on metformin in Asian Indian subject to is 2020. Poster presentation at case of the psychosis, heroin of the phenolem toxicity in February 2017. And also another paper presentation in the case study of inflammatory myositis at the International Journal of the Current Research in December 2018. And he's also done his dissertation in the clinical biochemical and serological profile in the patient with the hepatitis E. And I would also like to invite Dr. Nishil Chovatia. Over to you, Nishil.
Thank you, Dr. Akash, for the wonderful introduction. Can I request the IT team to allow me to share my screen, please?
Yes, sir. You are.
Are my slides visible?
Yes.
Okay. So I think without me wasting much time, we'll move forward with our today's topic, that is hypertensive disorder in pregnancy. So currently, this term has been obsolete from our current guideline. Hypertension in pregnancy. So now we call it as hypertensive disorder in pregnancy. So what is hypertensive disorder in pregnancy? So when we measure patient blood pressure, so systolic blood pressure of more than 140 mm of Hg and diastolic blood pressure of more than 90, we call it as a hypertension in pregnancy. That should occur at least on at least two occasions, at least 4 hours apart. This complicates almost 6 to 10% of the pregnancy. It might be classified as mild, moderate, and severe. I won't go in that details. So classification of hypertension disorder in pregnancy is, if it is less than 20 weeks of gestation, we call it as a chronic hypertension. And if it is of more than 20 weeks of gestation, then it is preeclampsia, eclampsia, gestational hypertension, or chronic hypertension with superimposed preeclampsia. So today we are having this case symposium. So let's start with the case. So there is Mrs. ABC, 35 years of age, gravida 2, para 2, no living issues. Previous 2 early preterm induced delivery around 26 weeks of gestational age for severe preeclampsia. Both babies expired due to prematurity. Now patient is having 1 month and 15 days of amenorrhea, UPT positive, USG 6 week single live intrauterine pregnancy, blood pressure of 150 and 90. So can we predict PIH in this patient? Which tests are to be done? And can we prevent PIH in this patient, and what drugs are to be used? So what is preeclampsia basically? So preeclampsia is multisystem progressive disorder, which is characterized by the new onset of hypertension and proteinuria, or hypertension and significant end organ dysfunction with or without proteinuria after 20 weeks of pregnancy or postpartum. So what are the criteria for diagnosis of preeclampsia? So systolic blood pressure of more than 140, diastolic of more than 90 on at least 2 occasions, that is 4 hours apart. After 20 weeks of gestation, there should be proteinuria of more than 0.3 gram in 24 hours of urinary specimen. There might be thrombocytopenia, there might be renal dysfunction, liver dysfunction, there might be pulmonary edema, new onset of persistent headache, or visual disturbances or CNS disturbances. So what are the severe features of preeclampsia? So there might be severe headache or visual changes, thrombocytopenia, or liver dysfunction, that is increase in liver enzymes. So why is this important? So it is one of the main cause of maternal and fetal and neonatal mortality and morbidity. So what are the outcomes that we see? The outcome in the maternal side would be maternal death, CNS dysfunction, hepatocellular injury, thrombocytopenia, DIC, ARF, pulmonary edema, etc. And fetal outcome would be IUGR, that is intrauterine growth restriction, low birth weight, preterm delivery, etc. So antiplatelet agents that are to be used, it is aspirin, which is indicated in mild, moderate, or high risk of patient. We can start with 75, we can increase the dose to 150 milligram of aspirin. So how to prevent preeclampsia? We need to evaluate early in pregnancy for the risk factor of preeclampsia. establish gestational age, do the routine workup, weight reduction, avoid multiple pregnancies, avoid excessive gestational weight gain, educate high-risk patient about the signs and symptoms of preeclampsia, low dose of aspirin, that is 75 milligram per day from 12 weeks to delivery. In low dietary calcium intake, daily calcium allowance is 1.5 to 2 grams of calcium. A second clinical scenario, the second case is Mrs. ABC, 35 years of age, gravida 2, para 2, with no living issues, previous to early preterm induced delivery around 26 of gestational age for severe preeclampsia. Both babies expired due to prematurity. Patient is having 28 weeks of pregnancy and blood pressure is 150 by 100. Urinary albumin is nil and no signs of end organ damage. What is the diagnosis? So here we see that there is no end organ damage or there is no proteinuria. So this is the clear-cut case of gestational hypertension and how we will manage. So gestational hypertension. So most common cause of hypertension during pregnancy is gestational hypertension. It is temporary and it is the provisional diagnosis. Preeclampsia, if proteinuria or any new signs of end organ damages occur, then we can term this patient to be having as preeclampsia. Chronic hypertension, if blood pressure is elevated more than 12 weeks postpartum, then it might be a case of chronic hypertension. Urinary protein and creatine ratio of more than 30 milligram. Evaluate the feature of severe diseases. Perform lab tests of RFT, LFT, coagulation profile. Assess the fetal well-being. I think our gynec colleagues might know it well. And weekly follow-up is necessary. So we all know that for gestational hypertension, blood pressure should be more than 140 and 90. So this is the third clinical scenario. So Mrs. ABC, 35 years of age, gravida 2, para 2, no living issues, previous to early preterm induced delivery around 26 weeks of gestation, and both babies expired due to prematurity. Now the patient is having 30 weeks of pregnancy, blood pressure is elevated 150 by 100, urinary albumin positive, no signs of end organ damage. So what is this diagnosis and how will we manage? So this is again preeclampsia without the feature of severe disease. So rather wasting time on preeclampsia, I'll move forward. So what are the antihypertensive drugs to be used? So currently there is no consensus as the optimal blood pressure threshold for initiating the therapy. Antihypertensive treatment did not reduce the occurrence of preeclampsia or perinatal death, preterm birth or abruptio placenta. Antihypertensive treatment was associated with almost 40 to 70% reduction in occurrence of severe hypertension, and antihypertensive treatment did not increase the frequency of delivery of small for gestational age infants. So what are the medicines that we use currently? So these are the agents that we use, that is methyl dopa. We can start with 250 milligram per oral twice a day. We can increase it up to 1000 milligram 8 TDS. So that is 3000 milligram daily dose. So what are the effect of this? So the agent greatest available data in pregnancy and follow-up of with limited maternal dizziness and fatigue. Labetalol, this is the most commonly used drug by our gynec colleague. So we can increase the dose from 100 to 800 every 8 hourly. The first line of antihypertensive agents that we use, nifedipine, which is short acting, and nowadays extended release nifedipine is also available. So we can use it up to 120 milligram of the daily doses. It is used as a second line after use of labetalol. The third is hydralazine, which we start with 100 milligram and we increase it to up to 200 milligram of the total daily dose. And it is considered for acute hypertensive crisis, no delay onset. It might cause reflex tachycardia, flushing and headache. AC inhibitors and ARBs, they are contraindicated and has adverse fetal effect in later gestation. So they are not to be used. So the agents pictures, these are the same way. So this shows which category this molecules falls on. Again, so hypertension refractory to the first line acute therapy. So nicardipine 5 mg per hour IV by infusion pump and can be increased to the maximum of 15 mg per hour. Esmolol, that is again the beta blocker, start with 250 to 500 microgram per kg over 1 minute, then IV infusion of 25 to 50 microgram per minute and titrate incrementally to the maximum of 300 microgram per minute. Nitroglycerin and nitroprusside are also used if the other molecules are not working that efficaciously. So administration of corticosteroid. So I won't go in that detail about corticosteroid because majority of our gynec colleagues might know that we need to give corticosteroid for the pulmonary maturation. And Maxup we use for the preventive measure to prevent convulsion and seizure in the woman. So So eclampsia. So what is eclampsia? It is generalized tonic-clonic seizure or coma in patient with pre-eclampsia. The incidence is almost 2 to 3%. Most patients have premonitory signs and symptoms in hours before the initial seizure, followed by generalized tonic-clonic seizure. Tongue might be bitten. Most patients begin to recover responsively within 10 to 20 minutes. Fetal bradycardia for 3 to 5 minutes is common finding during and immediately after the seizure attack. Preterm is approximately in 50% of the cases. So what is management of pre-eclampsia? So prevent the maternal hypoxia and trauma, treatment of severe hypertension if present, prevent recurrent seizure, and evaluation for the prompt delivery. So Maxaf, we all know that almost 4 milligram of Maxaf is used for over 15 to 20 minutes, followed by 1 to 2 gram per hour as a continuous infusion. We need to monitor urinary output, deep reflexes, respiratory rate, and serum Maxaf level if needed, and dose in case of compromised renal function, and toxicity and antidote. So what are the long-term consequences? So there is chronic hypertension, ischemic heart disease, atherosclerosis, and the other cardiovascular diseases. Neurovascular consequences are stroke, retinal detachment, diabetic retinopathy, metabolic are type 2 DM, metabolic syndrome, dyslipidemia. Renal are glomerular dysfunction, and CNS is cognitive dysfunction. So this is the interesting case which I have seen before 2 years. So a 26-year-old pregnant female, G2P1, presented with hypertension and proteinuria at 20 weeks of gestation. She had history of pre-eclampsia in the first pregnancy. Family history was remarkable as the mother had hypertension in her 4th decade. At 20 weeks of gestation, blood pressure was found to be elevated of almost 146 by 100. Aside from mild headache, she reportedly had no other symptoms. On physical examination, patient had a tachycardia with heart rate of 100 beats per minute. So the baseline laboratory investigation were normal. Liver function and the renal function was normal. The blood glucose level was almost 90. Patient had microcytic anemia. So the quantification of urinary protein indicated that mild proteinuria with protein creatinine ratio of 40 mg per millimoles. Echo suggested that the patient has LVH. So what could be the differential diagnosis? So it might be preeclampsia, essential hypertension, renal artery stenosis, and many more. So when we evaluated this patient, she did not have any other symptoms. Then we did urinary catecholamines level. So we came to the diagnosis of pheochromocytoma, which is a rare cause of hypertension in pregnancy. If unrecognized, it is associated with significant maternal and fetal morbidity and mortality. The diagnosis can be established by measuring catecholamines, that is non-adrenaline and adrenaline, and other metabolites. So catecholamines levels in 24-hour urinary collection was found to be markedly raised, which was almost 5,659. And this patient was diagnosed with pheochromocytoma. MRI was done for the pelvis with gadolinium enhancement, and it shows that it had 4.2 centimeter of solid lesion in mid-abdominal aortocaval region of both, and it did not have any changes in adrenal gland. So we came to know that on the basis of the existing investigation finding, it was concluded she had extra adrenal paraganglioma resulting in hypertension. So what was the management that was done? So at 22 weeks of gestation, the patient was started on phenoxybenzamin, titrated up to 30 milligram in morning and 10 milligram in the evening. Propranolol was added several days after commencement of phenoxybenzamin. And apart from mild postural dizziness, the medical therapy was well tolerated during the remainder of the pregnancy. And in the 3rd trimester, the systolic and the diastolic blood pressure was normal. We did a genetic study for this patient, and it came out to be SDHD deficiency. So it's a gene which was deficient in that patient. And then after delivery, patient was operated for the same after 4 months of delivery. So what is the take-home message for today's talk? So hypertensive disorder in pregnancy affects almost 6 to 10% of the pregnancy, which contributes to 12% in maternal mortality. Systolic blood pressure of more than 140 and diastolic of more than 90. Gestational hypertension might be temporary diagnosis, preeclampsia definition, and that we all now we have understood very well. So the prediction depends on the severity and the complication. So antihypertensive agents to be used in non-severe hypertension and in severe hypertension. The target blood pressure should be less than 135 and 85. So antihypertensive we use is labetalol, hydralazine, nifedipine. The target blood pressure should be less than 130. ACE inhibitors and the ARBs are contraindicated in pregnancy. So this is for delivery for gynec colleague. Thank you for giving me time. Over to you, Dr. Akash and Dr. Drumil.
Thank you, Dr. Nishil. Such a nice discussion on the management in the hypertension in GDM. Now I would like to invite Dr. Ajay sir for our next session. Dr. Ajay is a MD Medicine and he is also practicing as a diabetologist and metabolic physician in Ahmedabad. He is also director of the Niyanta Diabetes and Metabolic Clinic and Shraddha Hospital in Ahmedabad. And he is also certificate in the diabetes from the CMC Vellore. And his specific area of interest in diabetes and metabolic disorder, diabetes and hypertension, thyroid disorder, and geriatric health. I would like to invite Dr. Ajay Prajapati sir.
Thank you, Dr. Akash, for giving me opportunity. Thank you, Dr. Rutul and Dr. Dharmendra and all PSG group team for inviting me to discuss case-based discussion here. Am I audible and visible?
Yes, sir.
So, after a wonderful session about hypertension and pregnancy, we will have a good case-based discussion about postpartum management of GDM patient. So, whenever there is a pregnancy-related any illness, there will be a lot of confusion. There is a lot of controversy, and each and every statement do not supporting having enough data to discuss, and we do not have any 100% evidence for each and every molecules. So we have a wonderful discussion today about all the different topics. Today, when we are discussing about management of diabetic during pregnancy, we have a lot of discussion about pre-pregnancy control of sugar, what is the issue, counseling, what need to do, what need to do during the pregnancy, what need to control before the pregnancy, which protocol we have to follow. So today our talk will be restricted to case-based discussion in postpartum stage. So whenever we think about any question about postpartum issue, there are a lot of confusion in our mind that how patient was diagnosed during pregnancy, which was the type of the diagnosis, in which trimester patient was diagnosed, and how it was controlled, whether patient was managed just with lifestyle modification or insulin was needed. If yes, then which insulin, just control with basal or basal plus or what, which dose he has required, how frequent dose has been taken and how frequent monitoring has been taken, what adverse effect can be possible to the baby after delivery, whether patient has been undergone close supervision with gynecologist or not, which molecule we have to think about in postpartum phase, what are the chance of developing type 2 diabetes in GDM mother, what are the chance of developing glucose intolerance in baby, which investigation to do in postpartum. So there are a lot of questions keeping up and popping up in our mind whenever we see any postpartum female. So let's discuss some simple case that we encounter in our daily practice routinely. Here we have a 30-year-old female, Mrs. Sudha. She was presented with itching the private part, nausea, lower abdominal pain, and she has got weight about 4 kg in last 2 months. After delivery, she has excessive appetite, she has craving for food, and she feels lethargic and tiredness. She has consulted gynecologist for itching the private part. Gynecologist has done so many investigation and laboratory reports and referred for further treatment. Just 2 months back, she has delivered 3.8 kg baby at 34 weeks, and cesarean section was done for delivery. She had abnormal sugar level in last trimester which was well managed with basal insulin, that is a Levemir, at bedtime, and aspart with lunch and dinner. 8-unit Levemir was received at bedtime, and 6 and 8-unit with lunch and dinner respectively, and that was gradually up titrated till end of the delivery. After delivery, just after finishing and delivered a baby, blood sugar was found reasonably good and was closely monitored, and before discharge on third day postpartum, blood sugar was normal without insulin. On follow-up, she has consulted gynecologist twice in 15 days after discharge, and everything was fine. Patient was asymptomatic. Initial glucose reading was done on a daily basis on 3 to 4 days. Then, when once the sugar was found normal as per advice, sugar was not monitored frequently and was normal. She was not on any treatment after delivery, and later on she was not monitoring any sugar data. While evaluating detailed past history, there was no significant illness. Her father had type 2 diabetes and he was taking oral hypoglycemic agents. Vital data was normal. BMI was 32. Systemic examination does not reveal any major abnormality. And a present laboratory report, which was done by gynecologist, due to which she has referred to a doctor, that was fasting blood sugar was 130, HbA1c 7.1, TSH 3, lipid normal, blood count normal, creatinine normal, urine showing 8 to 10 pus cells. Ultrasound was done due to lower abdominal pain, and just delivered a baby. Sonography was also normal. So, in conclusion, we have a 32-year female recently done LSTS 2 months back. At present, she is feeding to her baby, found itching in private part due to urinary tract, genital tract issue, and abnormal sugar level. So now we have a question in our mind that she was GDM. She was well controlled with Levemir and Aspart in last trimester, and those were not much higher, but till whether she has given proper advice, why she had come on second or 8th week with abnormal sugar report and private part issue, whether she was converted to type 2 diabetes or she was undiagnosed type 1. So in nutshell, we can think that most likely she had GDM, and right now she found abnormal blood sugar level at the end of 2 months of postpartum stage. There was no previous data showing abnormal sugar level in first trimester, and immediately after delivery, postpartum sugar level was also normal. So it can be a GDM which was developed type 2 diabetes because HbA1c is 7.1 and fasting sugar is 130. So in all our data, 40 to 50% of GDA patients may develop type 2 diabetes later in her life. So what are the issues? What happens? Why we are concerned about sugar monitoring? Why we are concerned about close supervision? Why we are concerned about frequent follow-up? Even though post-delivery sugar was normal, even though we are thinking that this lady should be monitored, there need of meticulous follow-up after delivery, and there should be close partnership and close relationship and close conversation between diabetologist and obstetrician, which is very, very crucial and which is not possible due to busy practice of diabetologist as well as gynecologist. So what we have to do? What should be the strategy? How we can prevent development of diabetes later on? Postpartum follow-up of GDT is a mandatory in all cases of GDM after 6 weeks. At the end of 6 weeks, if normal glucose tolerance, then we have to reassess glycemia at the 3 years interval. If at the end of 6 weeks, patient having a pre-diabetes, means impaired glucose tolerance or impaired fasting glucose, then annual assessment of glycemia and intensive lifestyle modification should be there. Intensive lifestyle modification includes proper training about exercise, proper dietary modification, well-balanced diet, stress-free life, proper sleep pattern, timing of diet, meal content of diet, and etc. But if we found at the end of 6 weeks that these parameters are favoring a type 1 or type 2 diabetes, then we should consider and treat as a diabetes, but there are certain issues till patient is lady, till patient and till female is giving breastfeed to a baby, there are certain restrictions about use of molecules. All GDM, even though they are not having an abnormal GTT, there should be lifestyle modification aiming at weight reduction also, because in postpartum stage, there will be lots of weight gain, and that going to create a trouble in the later of her life. In postpartum stage, all our management plan should be individualized according to need of the patient, according to clinical condition, according to custom, according to religion, according to cultural pattern, and according to family lifestyle and family health and family dietary pattern. We need a glycemic management. We need a close supervision of glycemic management. Nutrition management should be well planned. Patients should encourage to reduce carb intake, specifically simple carb intake, less than 50%. Protein intake should be promoted. Saturated fat intake should be restricted. Fiber and milk products should be involved. High fiber diet should be involved. There should be certain strategy with discussion with gynecologists about contraception to prevent again getting pregnant in the breastfeeding phase. Future pregnancy planning should be well planned to avoid small interval pregnancy and to have a better healthy baby in a next planning. Lifestyle changes is the necessity to prevent further weight gain and to prevent further metabolic changes, and OGTT at the end of 6 weeks is a must. And if it's missed, then whenever patient comes within 6 months or 1 year, we have to do it and we have to follow the certain protocol. So there are specific criteria about it, that is at the end of 6 weeks, give a 75 gram of glucose as we are giving in the GTT. At the end of 2 hour OGTT, we have to follow. If it's normal, then we have to assess every 3 years. If it's impaired fasting or impaired glucose tolerance or both, we need a proper lifestyle changes. Metformin may be considered, and yearly assessment of glycemic status should be there. If these reports convert it as a diabetes type 1 or type 2, we should follow the protocol of diabetes treatment. This is the ACOG guideline for postpartum screening of abnormal glucose tolerance in women who had a GD. So in postpartum diabetes management, as we have discussed, lifestyle is base of treatment, well-planned diet, scheduled exercise, stress-free environment, and proper sleep pattern, which is very, very crucial. After delivery, baby is sleeping at erratic time. That's why mother's sleep will be disturbed, and this disturbance of sleep will create a whole trouble in his circadian rhythm that's going to create lots of issues. Usually in postpartum phase, if we can say that which is a safe molecule, only metformin and insulin is safe. Need of insulin should be as per requirement. That decision should be taken by diabetologists. Use of other OHA is not 100% safe. Glyclazide, glibenclamide, or glyperidide, or gleburide, or glibenclamide, or glimepiride, all they can pass through breast milk, and they can create certain times hypoglycemia, and there are certain issue related to baby. DPP-4, there are no enough data. SGLT2 inhibitors can create a trouble, sometimes development of kidney related issues, and other OHA like pioglitazone and acarbose are not well studied, still not having enough evidence and profound data to use such molecule in postpartum stage. So if we can say what we can use very safely with 100% safety precaution, then metformin and insulin is the molecule that we can use very safely. Other all molecules are in caution. Sugar monitoring should be individualized as per need, as per just impaired glucose tolerance or type 2 diabetes or type 1 diabetes, and follow also should be modified as per need of the patient and as per clinical characteristic of patient. We need to keep on evaluating end organ to prevent further end organ issues. Vaccination should be promoted as per protocol. Contraception should be well explained and should be followed in proper. So thank you very much. I will end my session here, and I will have finished my talk in 40 minutes, and I will hand over the session to Dr. Akash for proceeding ahead. Thank you very much.
Thank you, Doctor. Yes, Dr. Akash.
Yes. Yeah. So we have no more question for the further session.
Now the session is open for the question and answer. So if any question, then ask. My question to Dr. Kunal Javeri, sir. Dr. Kunal, sir.
Yes.
Yes.
So,
patient is already on taking glargine, and patient become pregnant. So we should continue glargine, or we should take change to another insulins.
Well, there are two scenarios with that.
Yes,
so first of all, if we go as per the guidelines, it is as far as long insulin is concerned, it is only Datamir that is available as a brand name of Levemir by Novo Nordisk, which is available in India. It is only approved, and if you still wish that NPH preparations, either insulated or so on and so forth, there are multiple brands of NPH, are only approved as a category B. There is no category approval for pregnancy diabetes management. So the safest insulins are these long or intermediate acting. Now, as far as glargine is concerned, I showed in some of the slides that previously it was considered category C, but for whatever the reason, I cited from the PubMed, one of the article in BMJ, which says that there are no enough data to show the intrauterine transfer of glargine, either U100 or U300. So my advice would be better to avoid it, or if at all patient is comfortable and convenient, then you may take consent from the patient that the risk will be on your shoulder. It is not contraindicated, but it is not proved. So it will be off-label indication to continue with the glargine. And I know off-label, lot of physicians and clinicians are more convenient to use glargine U100, U300, and that would, but particularly glargine 100 is something which is available widely across the country, across the chemist level and across the hospitals. So they are using, but believe me, it is off-label use right now. So officially, you cannot say that it is absolutely safe to go for. But as far as the experience of a lot of clinicians are also concerned, a lot of patients have been managed on glargine and there was no significant side effect which are observed. In fact, there is one advantage also, because if you see the pharmacokinetics of Datamir, it is not a truly second generation basal insulin. It's actually a first generation basal insulin which has some peak followed by a trough, and it is actually not acting for nearly 24 hours. Whereas glargine is roughly acting for nearly 22 to 24 hours. So in that way, hypoglycemia chances are very less. And as I showed in my case, I use Datamir in before breakfast condition, because there is breakfast, there is lunch which are going on. At the night time, a bad time if you give, there are chances to go midnight hypoglycemia. So as far as pharmacokinetics is concerned, Datamir is not a great insulin or ideal insulin for management of as basal insulin. But yes, as far as the guidelines are concerned, it is the only safest available. Nobody can come you to the court and sue you that you prescribe your wrong insulin.
Yes. Good. Nice. Any other question?
We can conclude the session. No more questions.
Fine. Thank you so much, Akash, and thank you so much, Rumil, Ajay, and Anishar. It was a wonderful session to have shared with all of you. And thank you, Rutul and Dharmendra and Bansi sir also for wonderful conference. Thank you so much.
Thank you very much to all the speakers, the chairpersons of the Case Symposium 3 for your wonderful insight on the management of GDM and the other topics. So I think we move on to the next symposium, and we'd like to invite Dr. Vidisha Patel and Dr. Pranav Pathak to take over as chairpersons. I hope our chairpersons are with us.
They haven't tried.
Our team, can you confirm that our chairpersons are with us? Otherwise, I think the speakers are there. If the chairpersons are not there, then I think our previous chairpersons can continue. Okay, Dr. Akash, I think you can continue introducing the next speakers as well, if the chairpersons are not there.
So for our next session, I would like to Dr. Anushree Mehta. She is also consultant diabetologist and co-founder of the Beyond Injection and the Complete Insulin Pump Clinic, visiting faculty at the SVT College from the MNC Nutrition, Assistant Secretary, CGP IMA Mumbai West, and he is also attachment with the Kasturba Health Society, Delhi Parle West, Juvenile Diabetes Foundation, Oshivra, Wound and Vein Advanced Clinic, Juran West, Ramakrishna Mission Hospital, and Arogya Nidhi Hospital. I would like to invite Dr. Anushree, madam, please.
Am I audible?
Yes.
Okay, I can share my screen, right?
Yes.
Okay. Okay. So I would like to thank Dr. Rutul for inviting me to be a part of this very exciting and very different conference. We see a lot of diabetes with pregnancy and we see a lot of GDM. And today I'm going to be presenting 3 cases of IVF with GDM or prediabetes. I will not take a lot of your time, don't worry. I think a lot of the things that we have to do has already been covered. Now, when we deal with patients who've undergone IVF and then they develop GDM, it's always very tricky because these are already precious pregnancies, and you want to do everything that you can to protect the pregnancy, to make sure that she undergoes, she delivers the child and has a normal, healthy baby. Most of the patients who undergo IVF do have risk factors for developing GDM in the future, like PCOS, which is one of the commonest indications for an IVF. So let's look at case 1, a 34-year-old woman having undergone IVF, conceived, and she visited me at 24 weeks. She had an abnormal OGTT report. Her BMI was 30, blood pressure was normal. She had no history of PCOS, but she had a family history of type 2 diabetes in her father. So this was her OGTT report. Her fasting was 100. 2 hours post 75 gram glucose was 180. And her HbA1c was 6. I'm not going to go into the controversies of diagnosis of GDM because I think they've already been dealt with. But this is the most favored guideline where the fasting sugar should be above 126. And if the 2 hour post 75 gram glucose is above or equal to 140, we consider those patients to have gestational diabetes. Now, how will you treat this patient? So I think it's already been highlighted that the first line of management would be lifestyle modification. But even before we move on to medical nutrition therapy, what is very, very important is to give education to the mother. She has to be educated about the implications of GDM. She has to be told that she is going to have to follow a very strict regimen as far as the diet is concerned. for a healthy child, because it can cause macrosomia. It doesn't cause congenital anomalies, thankfully, but it can lead occasionally to stillborns. And what is very important is it can lead to complications at the time of delivery. So the mother has to be explained that she is a high-risk pregnancy. She has to follow up both with the physician and has to be in constant touch with the OBGYN. She has to be told the principles of medical nutrition therapy. I practice in Mumbai, so nutritionists are very easily available to me. But this particular patient completely refused to go to a nutritionist. And as much as I don't want to take charge of that role, I had to play a little bit here because the patient was just not ready. The patient has to be told that she may require to take insulin. Because I remember when I was doing my PG, and whenever we used to hear lectures on GDM, we were always told that, most of them don't have an issue. They are ready to take insulin. But we do occasionally come across patients in practice who are not very, very open to the idea of taking insulin even during their pregnancy. The number is small, but it still exists. And we want to, help each and every patient. What is very important is that she should be told that she has to monitor her blood sugars throughout pregnancy. Even if they normalize with MNT, she can't leave monitoring, because as she progresses through the trimesters, the body's insulin requirement increases, the body's insulin resistance increases, and the blood sugars may rise. So she has to monitor blood sugars regularly throughout her pregnancy. And the window of opportunity in pregnancy is very small because we only have 9 months. The target setting, these are the standard targets that I've taken from DIPSI. Fasting should be less than 95. 1 hour post meal should be less than 140, and 2 hours should be less than 120. So generally, I advise most of my patients who are pregnant, have gestational diabetes or pre-existing diabetes, to do a 7-point glucose profile, which is fasting, pre-meal, 1.5 hour or 2 hours post-meal. Now, I'm just going to share very superficially a few of the principles that I shared with this particular patient. One of the things that works beautifully, which has been mentioned in all of the guidelines, is splitting the breakfast into 2. Okay, so if she's having 2 chapatis and sabji for breakfast, we tell her, okay, have 1 chapati and a little sabji. And then again, after 1.5 hours or 2 hours, you have another chapati and a sabji. So don't have your whole breakfast in one go. You split it into 2. Pregnancy is not the time for obesity correction. We just have to make sure that she doesn't gain any additional weight beyond what she needs to gain. So we expect a 10 to 12 kg weight gain at the end of term. We can, especially if she has gestational diabetes, give her low GI choices. So what we tell her is that you add protein and fiber in every meal. So if you're having chapati and sabji for breakfast, add a bowl of sprouts with that. Okay. If you're eating only khichdi for dinner, make sure to have a bowl of soup or vegetables with that. So you add protein and fiber in every meal. That will lower the GI and help to achieve better control. If you look at the ADA recommendations, they say that only 35% of the total calorie intake should be carbs. So their daily requirement is 175 grams of carbs, 71 grams of protein, and 28 grams of fiber. Okay, metformin is a controversy. I'm not going to go into too much detail. There is a beautiful review article which shows that metformin does have benefit in PCOS, and it does help to prevent weight gain during pregnancy. If you look at the guidelines, they're also contradictory. NICE recommends it as a second line, and ADA says that it should be used as little as possible. Okay, so this is the review article, and this is the MIG tofu study. So this patient was very compliant to the recommendations. She achieved her targets with medical nutrition therapy, and we didn't have to actually go on to any other mode of treatment for her. She had a C-section at 9 months and a healthy baby girl with a birth weight of 3.5 kgs. The second case was a 32-year-old who was a known case of PCOS. She was already on metformin, and she conceived with IVF. Her first antenatal visit itself for A1C was 5.7, and it was a twin pregnancy. So at 16 weeks, she again repeated the blood sugars, and the fasting was 130, post lunch 220, and the A1C had shot up to 6.5. So when she had a A1C of 5.7, she had already visited the nutritionist. She was already on medical nutrition therapy. The only thing that was lost, or the time that was lost in this patient, is because she did not monitor. She was not told the importance of monitoring, and we lost time. And by the time she came to me, her sugars were already in a range where I didn't want to think twice. I just started her on insulin. Again, metformin in this patient, because they already lost time, I really didn't want to experiment with withdrawing or adding anything. So I continued the metformin. You may stop the metformin if you feel that would be appropriate in that particular case. So I started her on regular insulin with NPH twice a day. Okay, I gave her targets. Again, we need a blood sugar chart to decide on the insulin therapy. So we did a 7-point blood sugar profile. She was started with very small doses, and we up titrated the dose every 3 days till the target was achieved. After that, I had asked her to do a 2-weekly follow-up with a lab report, and what was explained to her was that every trimester the insulin requirement goes up. So it is not your failure, it is the requirement of the body, and we will have to go up on the insulin every trimester. Unfortunately, this patient was lost to follow-up post-delivery. She came back to me at 3 months with type 2 diabetes, and we started her on insulin and gradually shifted to OHAs. This is the last case, which is a little different but very close to my heart. So this is a 40-year-old woman who was a known case of type 1 diabetes for 30 years, and she had history of recurrent miscarriages. She came to me as soon as her pregnancy was confirmed. Okay, she was asked to take low molecular weight heparin for her infertility. Her last A1C, which was done 2 months ago, was 9%, and we repeated the HbA1c at the time, and it was 8%. So what we did for her is we set the targets, which are the same. I'm not going to go through 95 fasting and post meal 140. It is very, very difficult to achieve in a patient with type 1 diabetes, but we tried our best. I roped in a nutritionist colleague of mine who worked very, very hard on this patient because she had a lot of what if buts and don'ts. She had a lot of fasts, which she just did not want to give up, even though she was pregnant. I recommended her to use a CGMS for monitoring. The CGMS targets in pregnancy are a little different. And our aim was that we'll try to bring the HbA1c as close to 6 as possible. She was on analogs and glargine. And because of the sensitivity of the case, even though glargine is a little controversial, I continued because she was doing well in terms of her fasting sugar. So I didn't want to change something that was working for her because we didn't have a lot of time. I really wanted to make sure that diabetes is not the reason for her miscarriages. Okay, so this is the CGMS target. Look at this for type 1 diabetes. You keep a target range of 63 to 140 and try to achieve 70% there. That is what we were trying for this particular patient. This is just a little bit about the insulins. We have an RCT on degludec, although it's a little bit more costly. Detamir is the one that is preferred the most during pregnancy after NPH. But we have a lot of observational studies which have shown that glargine is actually quite safe during pregnancy. Unfortunately, in this patient, we followed up with her, and she actually managed to bring her A1C down to 6.9. But at 10 weeks, she had a miscarriage. So, it was very disheartening, but at least we know that we did everything that we could in our power to make sure that the cause of the miscarriage was not diabetes, because her sugars were actually almost very close to the targets. And, we did the best we could. And I wanted to give her that chance. Thank you. I'm 2 minutes before time.
So I think it was very nicely elaborated. I just want to ask one question. Would you be using glargine in patients who are not initiated on glargine?
No, I would not prefer initiating somebody with glargine for the first time during pregnancy. I would prefer giving detamir, or I would go with simple plain NPH.
And how is your experience regarding the conventional insulin and the newer insulin analogs? I mean, I think you will get lesser episodes of hypoglycemia.
Yes, yes. So I think the biggest challenge in pregnancy is achieving the postprandial targets. So, analogs actually are very, very good in terms of achieving postprandial targets, because the peak occurs at 1.5 hours for during pregnancy. So analogs probably would be a better choice over regular insulin during pregnancy.
Yes,
I do agree with that. Yes.
If cost is not a factor, I think it should not be that very
yes.
costly.
If cost is not a factor, I do agree. If cost is not a factor.
Yes, I think we can have the next speaker now. So the next speaker is Mittal, and Dr. Mittal, he is MBBS, MD Medicine, consultant physician and diabetologist, and he has won many awards, and he's also a member of Association of Physicians of India. So I will ask you to kindly proceed with your session.
Thank you, respected chairperson, and thank you, PSG team, for giving me the opportunity helping the conference. My topic is today's the case on the isolated post-breakfast hyperglycemia in pregnancy. Am I audible?
Yes, yes.
The case is the patient named Rekha, 29-year female, gravida 3, parative live birth 1, history of 6 months amenorrhea, came for routine checkup. Gestational age 26 weeks 4 days, married since 9th year. Gestation 1, she had a boy 8 years, and in second gestation she had LSCS, that the girl, and the third she is having pregnancy, presently diagnosed with GDM. Family history, father is diabetic. General examination is normal, 7, and at the presentation RBS was 160. Then 75 gram OGTT was done, and 2 hours post glucose load was 188, and her HbA1c was 6.8. Patient was advised for MNT for 1 week by the gynecologist. Then after 1 week, she had FBS of 90 and postprandial 164. She was started on pre-mix insulin 3076 unit before breakfast along with MNT and advised for self-monitoring of blood glucose. And she was educated also with the insulin dose titration according to blood sugar. After 2 weeks, her FBS 82 and postprandial after breakfast 2 hours was 116. After 1 month, her FBS 78 and PPBS 2 hours 112, and her HbA1c came down to 6.1. And what is hyperglycemia is one of the most common medical disorders seen in women during pregnancy. IDF estimates that 1 in 6 live births are to women with some form of hyperglycemia in pregnancy. This slide, we all know about the types of hyperglycemia in pregnancy. I will go quickly through all these slides. And the incidence GD prevalence has been reported to vary between 1 to 28% in different regions. 10 to 25% of these may be due to diabetes in pregnancy, while the majority is related to GDM. These are the risk factors we all know. Maternal glucose regulation, tendency to maternal hypoglycemia between males lead to increased fetal demand, resulting in increased diabetogenic placental steroid, increased estrogen and progesterone, increased HPL, and that lead to increased insulin production. When maternal hyperglycemia occurs, there is fetal pancreas stimulated, fetal hyperinsulinemia, insulin resistance syndrome occur, which result in fetal growth and fetal well-being. Why to bother about DM, diabetes mellitus? Then with fetal concern, spontaneous abortion, congenital anomalies, macrosomia, neonatal prematurity, perinatal asphyxia, mortality, respiratory distress, hypoglycemia, hypercalcemia, polycythemia, jaundice, and long-term complication are diabetes, obesity, and neurodevelopment outcome. Maternal outcome, PIH and preeclampsia. These are the recommendations. First, prenatal visit in those with risk factors. GDM at 24 to 28 week of gestation in women not previously known to have diabetes. Screen women with GDM for persistent diabetes at 4 to 12 weeks postpartum using the OGTT. If GDM is not diagnosed, repeat 24 to 28 weeks or at any time patient has a symptoms or signs of suggestive hyperglycemia. Detection and diagnosis of GDM. Women with GDM history should have lifelong screening for development of diabetes or prediabetes at least every 3 years. Women with GDM having history found to have prediabetes should receive lifestyle intervention and metformin to prevent diabetes. This is screening procedure. We follow one-step strategy in which 75 gram OGTT and glucose was measured at fasting 1 hour and 2 hours. This will all know. And this is the self-monitoring glucose is the cornerstone of diabetes in gestational diabetes mellitus. ADA guidelines for pregnant patients requiring insulin. SMPG should be monitored more than thrice a day, and which frequently in morning fasting, pre-meal, and 1 hour postprandial and before bed. These are the targets. Patients with GDM pre-prandial meal less than 95, and patient with pre-existing type 1 DM or type 2 pre-meal bedtime overnight glucose that is 60 to 99, and postprandial after 1 hour less than 140 and 2 hours less than 120. And in pre-existing type 1 or type 2 peak postprandial glucose was 100 to 129. These are the management approaches. Early referral to a specialist is essential. Collaborative effort among obstetrician, midwife, endocrinologist, ophthalmologist. All team members should be engaged in patient education prior to throughout the pregnancy. An individualized treatment plan involving combination of glucose monitoring, medical nutrition therapy, pharmacotherapy, exercise, weight management strategies, and psychological support. When MNT in diabetes, pharmacological therapies is when MNT alone fails, pharmacological therapy is indicated. ACE guidelines recommend insulin as the optimal approach. Insulin therapy is required for the treatment of type 1 DM during pregnancy. Metformin and the glyburide are the two most commonly prescribed oral anti-hyperglycemic agents during pregnancy. Postprandial hyperglycemia. It plays a more important role in causing fetal overgrowth. Data suggests that PPG levels more closely relate to macrosomia risk compared to FPG level. Based on studies in preterm birth, renal threshold for glucose in the fetus is probably less than 110 milligram per deciliter. When maternal glucose more than 110 milligram per deciliter, the fetal blood glucose load causes fetal glycosuria and consequently a glucose-enriched amniotic fluid. After 20 weeks of gestation, the fetus began to swallow the amniotic fluid. In addition to the placental transfer of glucose, ingested high glucose amniotic fluid also stimulates the insulin secretion. Thus, even transient elevation of blood glucose on the maternal side not only result in elevation of blood glucose on the fetal side, but also provide for glucose ingestion by the fetus for many hours. Thus, postprandial hyperglycemia for less than 1 hour once a day in the mother produce fetal insulin stimulus through the oral route for hours. Elevation of maternal glucose level more frequently may produce a more prolonged oral glucose load in fetus, resulting in overfed fat fetus. These are the associations between PPG at different time of point and mode of delivery. Patient undergoing operative delivery had significant higher PPG values from 75 to 135 minutes. Association, higher newborn birth weight was noted in women with significantly higher PPG value from 45 to 150 minutes. And these are the higher diabetes associated complication was noted in women with significantly higher PPG values from 75 to 105 minutes. There is also study between 1 hour glucose challenge test values and perinatal outcomes. This study suggests that the subject between 140 to 149 blood sugar postprandial have adjusted ratio was more than 1, which suggests that it is associated with a higher composite perinatal outcome, large gestation age babies, and macrosomia. Another study with postprandial versus preprandial blood glucose monitoring in women with GDM requiring insulin therapy. In this 66 women with GDM required insulin therapy at 30 weeks of gestation or earlier, the women were randomly assigned to assigned to have their diabetes managed according to the results of pre-prandial monitoring or post-prandial monitoring of blood glucose concentrations. And the study results indicate that in post-prandial measurement group, the infant birth weight was lower. The infant born to the woman in post-prandial monitoring group had a lower rate of neonatal hypoglycemia, less often large for gestational age, and were less often delivered by cesarean section because of cephalopelvic disproportion and then compared to the pre-prandial monitoring group. The conclusion is that adjustments of insulin therapy in women with gestational diabetes according to the results of postprandial rather than preprandial blood glucose improves glycemic control, decreases the risk of neonatal hypoglycemia and macrosomia. Result of this study support the hypothesis that PPG monitoring in combination with fasting glucose measurement can significantly improve the outcome of pregnancy in women with gestational diabetes who require insulin therapy. Another study in which women with gestational diabetes, 33 women, those who had PPG control indicated by lower HbA1c levels, gave birth to babies with lower weight, lower risk of neonatal hypoglycemia, and were less likely to undergo cesarean section compared to 33 women randomly assigned to fasting plasma glucose control. Weight gain during pregnancy, gestational age at the diagnosis of diabetes and at delivery, degree of compliance with therapy, and degree of achievement of target glucose concentration was similar in these two groups. The diabetes in early pregnancy study group showed that high birth weight was closely related with the third trimester postprandial glucose levels. It recruited insulin-dependent diabetic and controlled women before conception, provide an opportunity to address the relationship between maternal hyperglycemia and percentile birth weight. Data were analyzed from 323 diabetic and 361 controlled women. Fasting and non-fasting venous plasma glucose were measured. Glycolated hemoglobin was measured weekly in the first trimester and monthly thereafter. More infants of the diabetic women were at or above 90th percentile for birth weight than infant of control women. Better glycemic control in patients with GDM was associated with reduced risk of neonatal hypoglycemia. Dimarini et al. Studied two groups of pregnant women with different target level of PPG, and infants in strict group control had a significantly lower rate of hypocalcemia than infant in the customary control group. There is also one study which showed that postprandial hyperglycemic control during gestation diabetes pregnancy predicts the recurrence. This we can see in the figure, that the figure trends no substantial difference between women with or without GDM recurrence regarding the preprandial glucose levels. Among women with GDM recurrence, the postprandial glucose levels were higher throughout the gestations. By controlling the PPG level, we may reduce the risk of GDM recurrence. Interventional studies are required to evaluate whether this is indeed a modifiable risk factor or it is a marker of a more severe insulin resistance. Either way, those women should be monitored carefully and strategies for GDM prevention should be implemented on this high-risk population. Postprandial glucose could be reduced using intensive diet, hypoglycemic drug treatment. For diet control GDM women, it was found that a home-based cycling program helps to maintain the daily PPG levels. Overall, by using a strict glucose monitoring with lower target values, along with the recommendation of avoid long inter-pregnancy interval and reduce weight, physicians may reduce the chance of GDM recurrence and consequently may reduce the chance of type 2 diabetes for some women. PPG management in pregnancy. In diabetic pregnant women, those requiring insulin, controlling PPG has resulted in better glycemic control than controlling fasting plasma glucose. Controlling postprandial blood glucose values further reduces the chances of neonatal hypoglycemia, as we discussed, macrosomia, and cesarean deliveries. After 2 hour post-meal blood glucose monitoring is suggested by Shishia et al., although different studies advocate varied intervals of 1 hour, 1.5 hours, and 2 hours. Indian guidelines further recommend that management of GDM should encompass medicinal nutrition therapy, oral hypoglycemic drugs, and insulin. Physical activity in pregnant women with diabetes has shown to assist in achieving better glucose levels. ADA recommend walking for 10 minutes after each meal to improve PPG control significantly in such patients. Evidence suggests that strict PPG control in patients with GDM correlates with lower risk of macrosomia, neonatal hypoglycemia, neonatal hypocalcemia with reduced chances to undergo cesarean surgery. Strict control in third trimester has the most potent effect on fetal body weight. Furthermore, physical activity also helps to reduce PPG levels. These are the recommendations for control of postprandial glucose in pregnancy. PPG rather than FPG should be used to guide management in pregnant women with GDM requiring insulin therapy. Post-meal monitoring should be performed 2 hours after meal intake. All GDM patients should receive nutritional counseling. Metformin alone or with supplementation with insulin is preferred. Premix to be initiated at 4 units before breakfast and to be increased by 2 units till 10 units. Rapid acting insulin analogs should be considered if PPG is still uncontrolled. These are the various types of insulins we can use in diabetes in pregnancy. The short acting, ultra short acting are Aspart, Lispro. There is regular and NPH and Detimir. Thank you.
So I think it was very nicely described by Dr. Mittal about the hyperglycemic issues which patients manifest during pregnancy, especially post-breakfast. A lot of patients do have craving for food, so especially during pregnancy. So how do you account or advise your patient, or what is your opinion for them?
Sorry, I'm not audible.
Lot of patients during pregnancy have increased craving for food, and most of them are not able to control. They take a lot of chocolates, or they do take many other things, especially in the later half of pregnancy. The craving is there. So how you advise or what a healthy diet you would suggest for your patients to keep away with those craving?
Yes, you definitely there is no craving for the things in between the meals. We advise 3 major meals and 3 snacks at the time, and we can go for with that. That's why I advise earlier with the 30-70. That will also control that the NPH part also control that postprandial value also in the during the lunch time if they have the craving with that.
And do you think anything like split breakfast will be helpful, especially for those patients who have the habit of taking a very heavy breakfast?
Sorry, not audible for me.
Do you advise split breakfast for those category of patients who persistently have a higher PPG value in spite of taking their breakfast in lesser amount, or you can say inadequate? There are some split breakfast sometimes helps. So have you tried, or what is your opinion about that?
Yes, we can advise that split meal also, that after regular intervals they can short small meals in between these after the major meal they can have. And the
okay, I think my course chairperson can ask other questions.
So, Dr. Surendra, wonderful talk. I mean, before we move on to the next speaker, just a quick comment. I think what we really see in these gestational diabetes patient is some of them have a habit of binge eating, and that's kind of increases their glycemic load. So I think addressing the postprandial hyperglycemia becomes actually a big challenge, just not the post-breakfast, but also the post-lunch and the post-dinner. And of late, of course, we've been doing a lot of CGMs on our patient, and we've been seeing that, you know, this postprandial hyperglycemia is actually contributing to the majority of the hyperglycemic surge in gestational diabetes patients. So once again, thank you very much for your beautiful case presentation and the discussion. And now we can move on, Dr. Pratap.
Thank you.
Yes. Can we have the slides? Yes. So now I would invite Dr. Sanket Panse, and he's MRCP UK DMV General Medicine Postgrad Diploma in Diabetes, and he is presently working in Nagpur. So over to you.
Thank you, sir, for the introduction. And, at the onset, I would like to thank Dr. Rutul as well as the team of PSG for giving me this opportunity. I hope my slides are visible.
Yes.
So my brief case presentation is on an important topic of elderly gestational diabetes mellitus. And this is a fairly straightforward case of a lady who is 38 years old and who is right now completed 8 months of pregnancy and is awaiting her delivery in the next couple of weeks or so. So this lady is 38 years old, married for 4 years, and she was
sorry to interrupt. Have you
Yes,
shared
sir.
the slides? Because I think I'm not able to see.
Okay, I will share.
Can you make it in screen slideshow mode?
Yeah. Are you able to see the slides?
Yes, yes. Can you go to the first slide?
Can you see them?
No.
Okay, wait for a minute.
It's showing some blank gray.
Reshare my slides. Can you see them now, sir?
Yes, but can you make it in the
Yeah.
slideshow mode?
Can you see them now?
I can see, but when you convert it into the slideshow mode, it is.
Is it okay if I keep it in this mode?
If you can go like this also,
Yeah.
it should not be a problem. No issues.
Sure. Thank you so much. So this is a case of a 38-year-old female married for the past 4 years, and she was referred by her obstetrician in view of new onset of hyperglycemia, which was detected at 16 weeks of gestation. So when she was evaluated by her obstetrician in her clinic, her fasting blood sugar was found to be 99 milligrams per deciliter, and her 2-hour 75 gram post glucose was 166. So this lady was referred to my clinic, and she was 16 weeks pregnant with a primary gravida. It was her first pregnancy. And from the recall of her weight prior to pregnancy, we could calculate that her pre-pregnancy BMI was around 25.5 kg per meter square. On examination, she had mild acanthosis nigricans. Her blood pressure levels were normal, and rest of her clinical examination was normal. So, both her parents had diabetes, and she had come to my clinic after 1 week of her initial assessment. So, in my own clinic, we had to reassess her current glycemic status, and at this time also her fasting blood sugar was 99 milligrams per deciliter. Her 1 hour post meal was 176, and 2 hour post meal was 156 milligrams per deciliter, and her HbA1c was almost normal, 5.8%. So she was more or less asymptomatic, except she had some mild nausea and slightly reduced appetite, which was consistent with the nausea, vomiting associated with pregnancy. And at the same time, she was also very anxious, very apprehensive, as she was aware that she was elderly. Her age was 38, and it was her first pregnancy, and that now she had a complication which she had already Googled, and which was gestational diabetes. So she was extremely apprehensive about her diabetes. So at this point of time, with her glycemic profile, we started her on a standard dietary therapy, that is a balanced meal. She was asked to take small frequent meals and avoid energy dense junk food, etc. And she was also suggested to monitor blood glucose at home with her glucometer at least 3 to 4 times every week, with a fasting blood glucose measurement and postprandial blood glucose measurement also. And she came back with 2 weeks of diet control, and this was her blood glucose profile of the last 2 weeks. So her fasting blood sugar had come down to below 95, but she had a slightly elevated post breakfast blood glucose levels of 136 and 146. Rest of her readings were fairly normal. So even at this point of time, some of her dietary problems were sorted out. She was suggested to continue diet control and come back after 10 to 14 days in OPD. So with this, at this time, I'd asked her to do a 4-point blood glucose test at 20 weeks of gestation, and these were her readings of 2 consecutive days, where her post breakfast and post lunch were persistently elevated. They had actually risen as compared to her previous visit, and the post dinner blood glucose levels were fairly normal. Her fasting was also around 95 or so. So at this point of time, we decided that to re-emphasize diet and also initiated her on insulin with insulin aspart 4 units before her breakfast and 4 units before her lunch. Subsequently, thereafter, for the next 2 to 3 weeks, the patient did not follow, but in absentia, that her husband came with her readings, and these were her readings after initiating insulin. So most of her readings of fasting as well as postprandial blood sugar were within normal range at this point of time. So again, she was asked to continue insulin as earlier, and he was also trained to adjust insulin doses as required depending on the blood glucose measurement. And they were in contact with me through WhatsApp as well as telephonic consultation. However, after 6 weeks of telephonic online consultation, it was observed that her blood glucose levels had started dramatically rising. And these were her pattern for the last 3 to 4 days when she came at 28 weeks of gestation. So even her fasting blood sugar had started rising. All her postprandial, including the post-dinner blood sugar, had started rising. And by this time, she was already on thrice daily novorapid with 8 units in the morning, 6 in the lunchtime, and 2 units before meal, which was started on telephonic consultation. So, at this point of time, I had increased her dose of novorapid to 12, 10, and 4, and I had also started her on a basal insulin detamere at bedtime. Subsequently, she is still under follow-up, and over the next 4 weeks, after monitoring her blood, her insulin requirement has dramatically increased. Now she's on aspart dose of 16 in the morning, 12 before lunch, 8 units before dinner, and Levemir of 8 units at bedtime. So it is almost approaching 44 units of insulin per day. And like I said earlier, she's near completion of pregnancy and is about to deliver in the next 2 to 3 weeks. Fortunately, in the all this while, all her obstetric scans were normal, and she did not have any additional complications that are seen apart from diabetes. So like I said earlier, this is a pretty straightforward case, but still there are some more concluding observations that I would like to make from this case. The first is that GDM in this particular patient was diagnosed at 12 weeks of gestation. Generally, we know that majority of the patients, they develop GDM between 24 to 28 weeks of gestation. Although it is very well known that some may develop earlier and some may develop in the last trimester also. And now it is a norm that all pregnant ladies are screened on the first antenatal visit for GDM, irrespective of their age or BMI or risk factor. So this lady was diagnosed at an early stage of her pregnancy. And if you look at the various reasons why somebody develops early GDM, then there was a paper published from China which looked at GDM who was diagnosed at 24 to 28 weeks of gestation in older and obese women, and is it too late to diagnose? So they had 4 groups of patients. In the group 3 and group 4, patients were elderly, that is age more than 35, and BMI less than 25 in group 3 and BMI more than 25 in group 4. And they looked at the fetal abdominal overgrowth ratio, which was found to be higher, significantly higher in group 3 and group 4. So the elderly ladies had a higher fetal abdominal overgrowth ratio as compared to patients who were younger than 35 years of age. So probably if someone is diagnosing an elderly lady with GDM after 24 weeks, probably she might be having GDM for quite some time, and it can only be diagnosed by repeated screening or more frequent monitoring of blood glucose. So whenever we come across a lady who is elderly, one has to be on high alert to screen this lady maybe repeatedly with either blood glucose measurements or a post glucose load also. The second observation that I would like to make is that this lady, at by 32 weeks of gestation, she was requiring almost 40 to 48 units of insulin per day. So again, generally, a GDM patient does not require very high insulin doses. Very high insulin doses are required by pre-gestational diabetic patients. But this lady was requiring almost 48 or 44 units per day of insulin, which is again fairly unusual. There could be two reasons in this lady. Her pre-pregnancy BMI was on the higher side, and secondly, she was elderly. These could be the two reasons why she might be having higher insulin requirement, or probably she might be having a pre-diabetic stage which was undiagnosed prior to her pregnancy. And the last observation is that there was a study, a registry-based study from Finland, which looked at pregnancy outcomes in elderly women, and they observed in the registry that the occurrence of preeclampsia, admission to NICU, and shoulder dystocia was very high in patients who are elderly and requiring insulin with GDM. So it is very essential that elderly GDM should be considered as a high-risk state, and one should be on very high alert to educate the patient to control their blood sugars, and more frequent monitoring and probably more frequent follow-ups are necessary. So with this, I would like to thank you for a patient listening. And if there are any questions, I would be happy to answer.
I think it was very nicely described in full details for your patient. Regarding elderly, do you have any cutoff to define elderly, first of all? And since complications increase with duration of age or as age progresses, so how is your approach usually for those elderly GDM who have had previous history of miscarriage or or who have had, say, bad obstetric history? So what is your approach for routinely for those kind of elderly GDM?
So probably the cutoff for elderly pregnancies more than 35 years of age, and for GDM, when we talk about GDM in elderly ladies, then probably, like I said, it should be considered as a high risk state, and we should be more proactive in monitoring this patient. Probably ask the patient to be doing daily SMBG, or like we can also do CGMS for these patients. And early insulin initiation may be a very important step in managing GDM in these patients. So early insulin initiation and more frequent blood glucose monitoring, as well as educating the patient about the risk associated with being elderly, having GDM, both.
And one more thing, since I think the chances of elderly GDM will also have increased chances of developing hypertension.
Yes.
So that also, I think,
well
is more monitored.
Yes, that needs to be monitored. So chances of preeclampsia, pregnancy-induced hypertension is more in elderly pregnancies as well as in elderly patients with GDM. Both.
And I think elderly GDM will also require some psychological support or adjustment regarding their parenthood, since they've been expecting at least. So that some amount of counseling will be required. So
we have to counsel them ourselves, because we can't ask the patients to go to a counselor. Generally, that doesn't happen. So we need to counsel our patients. Like this particular patient was also having a lot of distress because she knew that this is her first pregnancy and probably the only pregnancy that she will have. She's 38 years old and she has already developed a complication GDM, which she had already Googled and was very apprehensive about it. So definitely, like you said, psychosocial support from the doctors is very essential.
Because I think most of them will be very stressed out, and we have to reduce the stress because that itself has its own deleterious effects. I think very nicely described. Thank you.
Thank you, sir.
I think all the three cases have been very nicely discussed. If there's any questions from panelists or if there's any questions from the audience, or if you want to add your any insights, if anyone has to say something.
Yeah, just it was a very nice discussion going on. Dr. Anush Mehta for IVF, PDM, then Surender Mittal told about isolated post-breakfast hyperglycemia, and then elderly GTM. Just I want to address both to Drs. Pansy and Dr. Nusri. Mode of pregnancy, I mean to say whether it's natural or it's with aid, I mean to say IUI or IVF, and association of GDM. And so what is in that context, and also for the prevention of GDM for these cases, are there any primordial things or are there any preventive steps do we incorporate in routine practice, or just we advise monitoring?
So I actually did look for this association of IVF with GDM. I found different articles, very mixed results. You know, some of the articles said that there was an association because of therapy given during IVF, and then some of the articles said that it is only the pre-gestational weight gain during that period of them undergoing IVF that is associated with the risk of developing GDM. So when you talk about primordial prevention, I think it is very, very important. One is that to prevent weight gain during the cycles of IVF. Second is, I think a lot of these patients, especially when it is an elderly patient, they may have pre-diabetes or, so that does need to be monitored. And if lifestyle changes are incorporated before conception, I think it will have a much lesser risk of getting GDM during the pregnancy. I think sir is nodding, so he agrees. And sir, if you want to add to this.
So regarding elderly, so age is a non-modifiable risk factor, unfortunately. So the patient will always present it after 35 years of age with pregnancy. So age can't be a modifiable risk factor, but like ma'am said, Dr. Mehta ma'am said that lifestyle changes, if she comes for pre-pregnancy counseling, then that should be addressed. And screening for pre-diabetes at that time should be done so that we can probably reduce the chances of developing GDM, or at least detect GDM early as early as possible.
Just to inquire further, is there any association of history of in past taken oral contraceptive pills for the patient for PCOS per se, for regularization of their menses even, and they are then in future getting more cases of GDM or any this sort of association if you have come across?
No, I haven't come across this. I couldn't find anything. I did look for it. I'm sorry for the disturbance, but I couldn't find any association.
Okay.
It's mostly related to weight gain, pre-pregnancy and during the IVF cycles. That is what came out the most when I did the search online.
Okay. So to summarize, it's mostly the weight gain, which if we are able to prevent, we may be able to, save the lady from developing gestational diabetes, right? Okay. I just want to ask Dr. Surinder Mittal if just this isolated post-breakfast hyperglycemia, and is there any association of this with any sort of multiparity, or else any association with some other disorder or any other medications if you have come across, Dr. Surinder?
No, sir, that multiparity does not come, but it related to the postprandial hyperglycemia and isolated postprandial breakfast hyperglycemia results associated with some patients with those have hypertension, and these related to, as discussed in the slides, related to the more postprandial hyperglycemia recurrence in the next pregnancy also.
Do you translate this just because of patient's lifestyle, or any other factors are also maybe responsible?
Mostly the first is the factors are the responsible for the recurrence of GDM, that, and second is the lifestyle interventions and the physical activity the patient is following also depend on that.
Fine. Thank you. Thanks a lot. If our other panelist speaker wants to add on, or else would like to again hand over to our moderator, Dr. Pranav Phatak. So here we will move for the next session, and would like to invite for the case symposium our next chairpersons, that is Dr. Anli Goklani and Dr. Yes Lapsiwala. Over to you, Dr. Anli.
Yes, sir. So next slide, please. Here is Dr. Abhishek Arun. He is MBBS, MD, MRCP, FRCP, PhD fellowship in diabetes from CMC Vellore and Royal College of Physicians, diploma in endocrinology from University of Liverpool, UK. Visiting faculty, Department of Diabetes, Endocrinology and Metabolism, CMC Vellore. Speaker at various state and national level conferences. Investigator in over 200 clinical trials. Over to you, Dr. Abhishek Arun, sir.
to introduce Dr. Kaumudi. Dr. Kaumudi is MBBS MD in General Medicine, consultant diabetologist at Daya Happy Clinic, Ahmedabad. Areas of interest include diabetes reversal, obesity, technology in diabetes, GD. Over to you, Dr. Kaumudi, ma'am.
Thank you. Am I audible, sir?
Yes, you are audible.
Yeah, okay. I'll share my screen. First of all, thank you to Rutul sir, Dharmendra sir, Amit sir to give me this opportunity. And is my screen visible?
Yes, ma'am.
Yeah, okay. Just tell me if I'm able to, like when I move the slides, are the slides moving? Because sometimes...
Yes.
Okay.
Yes, it's moving.
Yeah. So good evening, everybody. I'm Dr. Kaumudi. And once again, I would like to thank Rutul sir, Dharmendra sir, and the entire organizing team to give me this opportunity. So today I'm going to speak about successful peripartum management in GDM. And it would be a case. So here we have a 33-year-old Pamigravida. She was diagnosed with GDM at 21 weeks of gestation. Initially, she was advised only dietary changes, but her control was suboptimal, so she was put on basal bolus therapy. With the insulin therapy, she had excellent results. Her fetal scan at 36 weeks was normal, and at 38 weeks, 5 days, she goes to the obstetrician with a complaint of labor pain since 6 hours. And she also mentions that she had taken the last night's basal dose. So on examination, as per the obstetrician, she is in the latent phase with dilatation of the cervix less than 4 centimeters. So all in all, we have a patient who is a Pamigravida, who has GDM and who is in labor. So now our concern is what are her sugars. So if you look at her sugars, so this is a sugar chart. So these are the sugars which have been recorded throughout the labor. Like she came at around 8 a.m. and she delivered post 5 p.m. So as you can see, initial up till from 8 a.m. to 12 p.m. around, she was in the latent phase. This is decided by the obstetrician according to the cervical dilatation and everything. And after that, she goes into the active phase. So in the initial phase, that is a latent phase, her sugars are checked every 2 hourly. And as you can see, they are pretty much controlled, 108, 104, 96. And as you can see, there is neither requirement of insulin infusion nor requirement of dextrose infusion. She's doing pretty well on her own. And once she goes into the active phase, you see there's a sudden dip in the sugars. The sugars dip from 96 to 68. And so this is what happens. So when the patient goes into active phase, because of increased metabolic demands, the sugars start falling, or you can say the requirement of some kind of dextrose increases. So once the sugars go to 68, she is started on dextrose infusion, a very low dose of 5% at 100 ml per hour. So that is effectively just 5 grams of sugar in a complete hour. So then at 3 p.m. her sugar is again checked. It goes till 85. But we continue the dextrose infusion. But just to make sure that we are still in that very stringent range of 70 to 110, we also start her on insulin infusion. But that is also at a very low dose of 0.5 ml. So basically the game is about balancing between insulin infusion and dextrose infusion to stay in that narrow range of 70 to 110. And then you see that her sugars are very well controlled, 85, 88, 84. And post 5 p.m., she delivers a healthy baby. So she delivered a healthy baby of 2.8 kgs at around 5 p.m. Post delivery, the doctor checks the sugars of the mother as well as monitors the sugars of the baby, and it is observed that there is no neonatal hypoglycemia. So this is what we can call as a successful peripartum management of GDM. So when you have a patient coming like this to you or to us, so what are the pertinent questions that come up? So first is, what is the ideal time for delivery in a patient of GDM? Like at what week should the patient be advised delivery? Like if you are planning, say, induction of labor or a CS, what is the ideal time? Then when say if the patient is already in the labor, what are the glycemic targets that we are looking at? And how do we achieve these glycemic targets? And how often should the monitoring be done? And what to do immediately after delivery? So to answer these questions, we will look at three major guidelines. That is the RSSGI guidelines, the NICE guidelines, and the ACOG guidelines. So the NICE are the UK guidelines and ACOG are the American guidelines. So to decide the ideal time for delivery, which is mostly done by the obstetrician. So RSSGI says that if there are metabolic or maternal or fecal complications, then you should take in the delivery little early, that is elective birth before 37 weeks for women with type 1 or type 2 diabetes. It should be considered. But the NICE guideline says that if the NICE and RSSGI guidelines are pretty aligned. So you can say that if the pregnant woman with type 1 or type 2 diabetes and has no other complications, you can take the elective birth by induced labor or CS between 37 weeks and 38 weeks plus 6 days of pregnancy. And if women with gestational diabetes, you can wait till 40 weeks plus 6 days, but no later than that. Because as you progress in the pregnancy, the later you become, there's more chance of stillbirth because of the osmosis which occurs at the chorionic villi. So because of that, you do not want to delay the delivery. And as per ACOG guidelines, it says that if the patient has diabetic complications, the delivery should be between 36 weeks 0 days to 38 weeks 6 days. And if it is well controlled, then up till expectant management can be done up till 39th week. And if the patient is of GDM, they're not type 1, type 2, you can even go up till 40 weeks. So this was the ideal time for delivery. Now, if you want to look at the intrapartum glycemic targets, all the three guidelines are very similar, and all of them suggest the stringent target range of just 70 to 110. NICE is a little more lenient, and you can go from 72 to 126. So whatever we are doing to control our sugars, our ultimate target should be that during labor, the patient's sugar should be between 70 and 110 to prevent neonatal hypoglycemia. And how often do we measure the sugars? In the latent phase, the frequency can be a little less, and you can measure 2 hourly. But once the active phase sets in, it is better to measure the sugars 1 hourly because there is sudden dip in the sugars. And how do we achieve these targets during the intrapartum period? All the three guidelines have similar in a way that they suggest IV dextrose and insulin infusion. But as you can see, none of the guidelines specifically give out like at what rate should the insulin infusion be or at what rate the dextrose infusion be. So that is like, up to the discretion of the doctor. So like mentioned, most national endocrine and obstetric governing bodies have not published specific guidelines regarding the rates of the infusions, and practice varies widely from institution to institution. So see, this is a protocol given by University of Cincinnati. So they have a very fixed protocol, like that if the sugar is between 100 and 120, keep the insulin at 0.5 unit per hour and start the infusion, dextrose infusion, 5% dextrose infusion at 125 ml per hour. So the doctors practicing there can be following these guidelines. But here we have article published by the Indian author which says that you can add 6 to 8 units of conventional regular insulin or analog to 500 ml dextrose normal saline. Like, in the pint you can add the insulin, and that is how you can manage your sugars. But I personally feel that having 2 different infusions gives the doctor more control over how to manage the sugar. So it is better to opt for 2 separate infusions. So what are the key points when managing these patients? First things to remember is that maternal euglycemia is critical to decrease the risk of neonatal hypoglycemia. And because neonatal hypoglycemia occurs in up to half of infants born to mothers with pre-gestational diabetes, that is either type 1 or type 2, or between 5 and 20% of women with gestational diabetes. And these neonates are prone to severe neonatal hypoglycemia because of secondary hyperplasia of pancreas and hyperinsulinemia. Hence, it becomes very important to keep the sugars tightly under control between 70 to 110. And what are the clinical pearls when it comes to management? During the latent phase of labor, the requirement of insulin is stable, but during the active phase, due to increased metabolic demand, the insulin requirement goes down markedly. Like what we saw in our case, like from 85, it dipped down to only 64. And immediately after delivery, postpartum insulin requirement further decreases as a result of the rapid decrease in diabetogenic placental hormone levels. And when the baby is born, even if your sugars intrapartum were controlled, please make sure to monitor the neonates very strictly. It should start immediately at birth, and the RBS should be checked at 30 minutes, 1 hour, 2 hours, 4 hours, 8 hours, and 12 hours to ensure that there is no hypoglycemia occurring. Because sometimes what happens is, if the woman had uncontrolled diabetes throughout the pregnancy but has controlled sugar during intrapartum stage, still there is a very high risk of neonatal hypoglycemia, because there has already been hyperplasia occurring in the pancreas of the baby. And if in some patients plan, it is always preferred to do the procedure early morning. The patient needs to take a usual 9 dose of long-acting insulin, and the morning dose of bolus insulin has to be withheld. And again, you can manage your sugars with IV dextrose and IV insulin. And once the patient is discharged, the patient should be advised to take a 2-hour 75-gram oral glucose test in the early postpartum period, that is around 4 to 12 weeks delivery. Yeah, that is all. Thank you.
Thank you so much, Dr. Kamodi, ma'am. Next slide, please. Do we have Abhishek, sir?
Hello. Ma'am, there's a technical error. I'm trying to join from a new device.
Okay, sir. So till then, we are going to introduce Dr. Saurabh Mishra. He is MBBS, PGD, RM, ESDPP in diabetes, emergency in charge at the Regency Hospital.
Hello.
Hello.
Please introduce Dr. Saurabh Mishra, sir.
Okay.
Yeah.
So good evening, good evening, everyone. So it's a pleasure for me to introduce Dr. Saurabh Mishra, sir, who is an MBBS, PGD, LM, ESDPPP, C DIA. He's also an emergency in charge of the Regency Hospital, Kanpur. He's a consultant physician. He's a consultant physician and diabetologist at the Mishra Polyclinic, Unnao. He's also a consultant at the Center for Diabetes and Endocrine Diseases, Kanpur. He has done several poster presentations at national as well as international conferences, and also had a poster presentation at the IDF 2013, oral paper at IDF 2017, and as well as IDF 2019. He also got the first prize in a paper, Medicine Non-Compliance in Type 2 Diabetes, Totally Untouched Issue. He got a second prize at the Diabetes India 2018 Kolkata on the topic Group Installation of Insulin Pump is a Better Approach. He presented oral paper at the ICEPAD Hyderabad 2018 on the topic Acceptance to Insulin Pump Therapy Increases with Group Installation and Group Education. Having good number of patients on both type 1 as well as type 2 diabetes on insulin pumps of all models. He got the 2019 Rising Star Award in Diabetes Care in North India, and he has been using Guardian Connect plus ambulatory glucose profile on good number of patients. So it's an honor for us to hear Dr. Saurabh Mishra, who will be speaking on the topic of insulin pumps. Over to you, Dr. Mishra. I guess there's some technical issue right now.
Dr. Saurabh sir will join you. Until then, Dr. Arvind sir, please continue.
My
Am I visible to everyone?
Yes.
Okay. So, wasting time, straight away go to the topic. That is, we'll be talking about an accidental pregnancy in type 1 diabetes, and it will be a case-based learning session. So, just to give you a background, pregnancy is one of the most important topics as it deals with two lives. And so preconception counseling is very, very important and essential. Accidental pregnancy is a condition where patients with pre-existing diabetes carry a huge risk of fetal complications, and often glucose control for diabetes is a very big challenge which often happens most challenging. Now, this is a particular case we'll be discussing. She's a case of 20-year-old lady with a history of type 1 diabetes for the last 18 years and coexisting hypothyroidism. She also had accidental pregnancy with a gestation age of 2 weeks and A1C of around 8.9%. She was advised to go for termination of pregnancy due to the uncontrolled diabetes on her first visit to an obstetrician, but she wanted to continue with the pregnancy. So the obstetrician immediately advised her to visit a diabetologist. Now, looking at background therapy, she was initially on a pre-mixed insulin until Aspart 3070, which was given at 18 and 12 units 2 different times subcutaneously, along with the tablet levothyroxine 75 microgram. She was irregular with the SMBGs, although it was much told to her earlier by a previous doctor, but she only used to do at 2 to 3 times in a week. And apart from that, she had very erratic meal pattern and she was not consistent with her exercises. So what was done was the patient was a diabetologist. She was shifted onto a basal bolus treatment, which was the gold standard in this case. Insulin Lancus 20 IU once daily subcutaneous was started after dinner, and insulin Aspart was alternatively started in a dose of 10 units before breakfast, 10 units before lunch, and 6 units before dinner. She was also advised to follow the 6-point SMBG, and which was clearly told to her. She was also taught about the carbohydrate counting and insulin correction factors according to her insulin sensitivity. She was also told about the exercise regime as permitted by her obstetrician, and she was also told about the hypoglycemic prevention and her statin management, how to manage those things as well. She was asked to use the CGM intermittently because she was not really comfortable with using it regularly. Option of insulin pump was also given, but because of the financial constraints, she refused for it. And she was also provided an application on mobile phone to upload the SMBG data so that we can keep a track of her blood sugar levels on frequent basis. Now, looking at an anomaly scan at 12 weeks, which was done, it was absolutely normal. Her subsequent visits were planned at every 45 days, and she maintained a blood glucose level with a good SMBG profile. Intermittent CGM was done, and of course, the A1C was routinely done for this patient. Looking at the blood sugar, how she fared. The first visit was done before the previous treatment. At the background, the A1C was 8.9, the TSH level was around 3.9, and the insulin requirement was around 0.8. With the subsequent visit happening on second visit at the treatment initiation, the A1C dropped once she was offered a basal bolus therapy, and the insulin requirement actually went up because of the corrected dose being offered to her. Third visit was at around 90 days, in which the A1C was again furthermore dropped down to 6.4%. The TSH drastically came down to 1.9, and the insulin units were also increased to 0.98. As the pregnancy proceeded further at 26 weeks, the A1C also showed better results. TSH was again within normal range. Insulin units per kg body weight were around 1.1 unit per kg body weight. Before delivery, she had 6.3 A1C with TSH 2.6, and insulin on average 1 units per kg body weight. So she delivered a healthy baby by using the basal bolus therapy, and she was well treated with this regime. So, in conclusion, I just want to summarize: pregnancy in the type 1 diabetes needs an multidisciplinary care to have a very good outcome. And I would love to answer any questions from the audience.
Hello, Rutul. How are you? Thank you. Thank you, organizers, for letting me having this opportunity. Can you listen me, please? Am I audible?
Yes, sir.
Okay. So, thank you all the organizers, specifically PSG and Rutul, for inviting me to just talk on very important topic: use of insulin pump in gestational diabetes. It has been many years of invention of insulin pump, and still the utility of insulin pump is still to be understood at its peaks. And I think so. All the credit goes to my respected seniors who have made me like this, that we are using technology at the flesh. So, insulin pump in gestational diabetes. Next, please. Next slide. As we all know, the tips for successful patient and physician experience is the basic thing which we need the call of the day. Next, please. The good physician treats the disease and the great physician treats the patient who has the disease. These are some important lines which we should keep in our mind. Next, please. Now, this was the first insulin pump which was experienced by a person who was just holding the pump over the back. And then it became very sleek, small, and might be people may do ramp walk with this insulin pump in near coming future, projecting that they are more powerful than people are taking MDIs because it mimics the natural insulin secretion of our body. Next, please. And as we talk about the history of insulin initiation, till invention of glucometers, then insulin pump, then we have gadgets, we have sensors, we have insulin pumps of latest devices. It has been an era of approximately 100 years of passed from discovery of insulin till the latest 780G model, which is available in our country, which is also known as closed loop hybrid insulin pump or artificial pancreas. So what the use we can give during pregnancy with GDM, this is the base of insulin pump which I had spoken about. Next, please. Now, the introduction. Next, please. Next slide, please. No, the previous one. The previous one. More previous. Yeah. So the introduction to insulin pump therapy in GDM, specifically the control of blood glucose during pregnancy, is difficult because with variations and in hormonal conditions, ongoing hormonal changes and mood swings. This is specifically needing multiple injections a day, and pain at injection site is the biggest problem. Then regular monitoring is very much required, and skillful handling of syringes and pens is so difficult. That is why this comes to an end with insulin pump therapy. This further makes insulin therapy more convenient when we give the insulin pump. Please. Next, please. Yeah, so specifically the physiological need of insulin is matched by insulin pump therapy. This is very nicely, beautifully, you can see through this slide. The red dots are the result of insulin secretion. The blue dots specifically are the boluses which can be given as when required when there are breakfast, lunch, any type of snacks or some type of middle meal or you can say you have brunches, or any snacks can be carbohydrate value can be calculated, and a specific peak can also be managed by insulin pump therapy. This has been known to all of us. Next, please. Now, with understanding this, what do you say to insulin pump therapy in GDM, as it is more physiological? So you say yes or no. So it is a big yes on my part, because I have been using it. Many people who agree to take the technology. The technology has first to be informed, then there will be a mutual consent, and then only the adherence of the technology can be there. So it takes 1 or 2 sessions to understand the technology. But in GDM, if you present in front of them the rental pumps, or you can say the pumps which are acquired by the physicians themselves, there you can give them these pumps for 6 to 8 months wherever it is required. So definitely, if physiological insulin replacement is on a part, so MDI and compares to insulin pump therapy, the guidelines also suggest the same.
Dr. Saurabh Mishra, would you please turn off your video, as your voice is cracking?
Okay.
Great. Thank you. Thank you.
Okay. Okay. So I think so. Now it's clear. Yeah. So it is very nice yes or a yes to insulin pump therapy in GDM. Next, please. Next slide. But then also these guidelines gives us power to prescribe, but we are the judge whom to prescribe, how much to prescribe or not to prescribe. So what are the advantages with this insulin pump therapy in GDM specifically? So multiple guidelines have recommended the use of insulin pump in pregnancy to maintain the glycemic control. The pump can release small doses of insulin continuously, basal or bolus dose close to a meal to control the spike in blood glucose after a meal, and the newer devices can do insulin delivery also before occurrence of hypoglycemia. There are 2 types of pumps available in our country. One is the conventional insulin pump, which is sensorless, and one is sensor augmented insulin pump, where now we talk about 780 that Medtronic has produced it. So that is also very nice, but specifically for GDM, if that is not available with the facility, and the normal pump also gives a good value by SMBG regular monitoring. Regular monitoring of SMBG is the primary call for any insulin therapy. So might it be it is insulin pump, or might it be it is your pens, might it be it is syringes, but SMBG is the most important thing which has to be done in regular. So 6 readings per day have to be mandatorily recorded for a person who is taking this technology. And for GDM in pregnancy, it is very important to record the values. Now, pump insulin of choice is specific rapid insulin. Rapid insulin is taken in insulin pump therapy rather than any other insulin. Next, please. So now, what are the most important things which we should look? So we should, as in GDM, look into insulin dose adjustment, then basal rate of testing, then bolus type of guidance in GDM. Correction formulas have to be understood and have to be propagated very nicely. CAR factor calculation can be done easily by smart pumps nowadays available, which we can correct during GDM. And avoid overcorrection of hypers and hypos specifically. Pump and exercise has to be cannula site exam. Next, please. I think so. The slide is not moving. Can you move the slide further? Next slide. I am always speaking on sometimes technology doesn't give when there is no good network. So networks has also been to be backed up very nicely. Now, what physician should look into insulin pump of using the insulin pump therapy in GDM? Most important, these 3 things: basal review, bolus history, and priming history has to be recorded. Next, please. Now, these are 5 important things which a person should always keep in our mind while we are using insulin pump therapy for GDM. Every meal to bolus has to be calculated and has to be delivered. Choose right type of bolus types have to be given. And bolus wizards are available on insulin pump. Then accordingly, you are taking rapid carbohydrate dissociated diet, and accordingly you can adjust your carbohydrate values. Keep 3 hours or more gap between the boluses. Avoid frequent correction and thus insulin. And treat glycemia 15 to 20 grams of glucose. This is the simple same regime which we use for other conventional insulin people, where we have to use in this insulin pump therapy. And fully specified for GDM, but more precautionately in where we are not using sensors, we have to check sugar 6 times a day. That is SMBG has to be done, and accordingly carb calculation has to be told to our person. Next, please. Some important tips for patients which we should tell. For person who is having GDM and she is using insulin pump therapy, we have to tell them to change cannula every 72 hours. And reservoir should not be used. The limited use of reservoir has to be made. Rotate the cannula insertion site, that as we are doing for insulin pens. Also the same we have to teach for this cannula also. Self-monitoring of plasma glucose has to be done for correction before meals. Then each meal, except exercise carb, to be covered with insulin specifically, and never suspend pump more than 1 hour. But for GDM, what I will say, if suspension is needed, you have to be very much precautionate. So I think so suspension of insulin pump in GDM is not permitted. Next, please. Now, how to initiate and specifically how to calculate the daily basal and bolus rate. So whatever amount of insulin is being decided to be delivered, suppose we take it by the formula of 0.4 into body weight, then amount of insulin which is required, out of which we have set the basal rate amongst the 40 to 50%. Suppose the total dose calculated for a GDM to start with insulin is 30 units, and we have to give approximately 50% as the basal rate, and the rest of the 50 to 60% has to be divided into 3. That we will start with from the boluses before breakfast, before lunch, and before dinner. So daily basal dose and bolus dose has to be calculated depending upon the total amount of insulin which we desire for a person which is having a weight related association, as we start with MDI. Next, please. Next slide, please. Why I am talking about insulin pump therapy? Because the basal rate varies all throughout the day in GDM. The requirement for basic variations can be only met very nicely by insulin pump therapy. So these guidelines gives us power to prescribe, but it is right choice of ours to prescribe or not prescribe. If a person is very much understanding insulin pump therapy, only then this will be available for a person to use it. So it has to be very much understood that this can be to people who are having tech. Next slide, please. This will be the last slide, I think. Next slide, please. So the take-home message from insulin pump and GDM point of view, I had to specifically discuss about a case. So there are several cases which I can discuss on the platform. I have recently used insulin pump therapy in a person who she was having GDM, but how to use this technology? Because they cannot buy the pump for 9 months. This is a very expensive technology, and the pharmacoeconomics offer for type 1 And type 2, it is another thing. They are already using insulin pump therapy, so that can be prescribed. But for people who are coming with GTM, so we have to have our pumps in our own clinic to offer this facility. So this facility can be offered by people who are having a proper team for insulin pump therapy, and they have their own pumps in their clinic. So in last, I will like to say insulin pump is gaining popularity in pregnancy because it mimics the insulin delivery of the healthy human pancreas physiologically. With this, I would like to end my session. Thank you. Last slide. Over to you, chairpersons. नापो तो जानो शक्कर से ज्यादा मीठी है जिंदगी. So it was quite disturbance because I am in mid of transit of taking one more conference in backup. So it was pre-planned, and the way I have done it, thank you, the organizers, for letting me having this opportunity to speak on this topic. Thank you very much.
Thank you very much, Dr. Mishra, for this wonderful informative session. And now I'd like to thank all the three speakers who are part of this session. And I also like to take this opportunity for congratulating Dr. Rutul and the whole diabetes PSG group for this wonderful initiative. I'd like to thank him for inviting us to be a part of this event. Thank you.
Thank you.
Please introduce yourself, guys.
Shall I start?
Yes, ma'am.
I'm not able to view the top part. Okay, I would like to invite Dr. Malay Parekh. He's a MBBS, DNB, and he's done his fellowship in diabetes in UK and ACCDRS STI, post-graduation diploma in diabetes from UK, PGDC from UK, PG diploma in diabetes, PGCC at CCS, consultant diabetologist in Rajkot. He's a member of a very prestigious several organizations. Over to you, Dr. Malay Parekh.
Yeah, thank you so much, Dr. Smriti, for nice introduction. And first of all, special thanks to my dearest friend, Dr. Rutul, Dr. Amit there, Dr. Dharmendra Panchal, for giving me this wonderful opportunity in PSG, for giving me this very, very important topic. So without wasting much time, I am sharing my screen. So is it visible? And
yes, yes.
Okay, thanks for confirmation. So my today's topic is successful lifestyle modification in gestational diabetes mellitus. It's very, very important because what is hyperglycemia in pregnancy? We all know GDM is defined as any degree of glucose intolerance with onset or first recognized during the pregnancy. Approximately 7% of all the pregnancy are complicated by GDM and range from 1 to 14% depending on the population studied and diagnosis test. And more than 2 lakh tests are annually. So what are the main risk factors for the development of GDM? We all know obesity, older age, personal history of GDM, liposuria, strong family history of diabetes, ethnicity, PCOD, hypertension, all are the very most common and very, very important risk factor for the GDM. And the adverse pregnancy outcomes are the metrosomia, shoulder dystocia, jaundice, polycythemia, respiratory distress, and hypocalcemia. And there is an increase in the fetal malformation and perinatal mortality. And it predisposes the child to diabetic phenotype in the later life. So what are the maternal complications? The weight gain, maternal hypertensive disorder, miscarriage, third trimester fetal death, cesarean delivery, and long-term risk factor of the type 2 diabetes. So what are the management of the hyperglycemia in the pregnancy? The first is the medical nutrition therapy, MNT. Second, exercise, OHA, insulin, and most important, psychological support. We all know the goal of the medical nutrition therapy is the first is to achieve the normal glycemia. Second, minimize the insulin requirement. Third, educating the healthy eating habits for the rest of the life. Fourth, balanced nutrition for the mother and fetus to avoid the excess weight gain. And fifth, prevention of the hypoglycemia and the ketosis. So what are the main recommendations for the treatment target to achieve the normal glycemia? And the test is the fasting plasma glucose should be between 65 to 95 milligram per deciliter. 1 hour postprandial is less than 140 and 2 hour postprandial is less than 120 milligram per deciliter. So all pregnant women gradually develop the insulin resistance during the pregnancy. So it's sufficient nutrient supply for the growing the fetus. And the energy requirement for the normal or underweight women, there is no sufficient evidence to suggest that the energy requirement for women with GDM should be different from the normal glycemic women or suggest a specific optimal calorie intake for women with GDM. So what are the main recommendation weight gain in the pregnancy? For twin pregnancy, recommended weight gain is 16 to 20.5 kg. For underweight, 12.5 to 18 kg. For normal weight pregnant woman, 11.5 to 16 kg. For overweight women, 7 to 11.5 kg. And for obese women with BMI more than 29, the recommended range of the weight is the 6 kg. So what is GDM diet chart? Total calories, 2,230 kilocalories per day are the recommend. So for total fat 25 milligram, total sodium 1000 milligram per day, carbohydrate 300 milligram per day, protein 60 to 65 gram per day, iron 21 milligram recommended. So for macronutrient, carbohydrate intake 50 to 55% kilocalorie intake, protein is 20 to 25% kilocalorie intake, and fat is 25 to 30% kilocalorie per day required. So carbohydrates are the important dietary source of the energy, vitamins, mineral, and the fiber content, and it is the main nutrient that affects the post-glucose level. So carbohydrate intake can be manipulated by the controlling the total amount of carbohydrate and distribution of the carbohydrate over the several meal and snack, and it depends also on the types of the carbohydrate. And glycemic index is very, very important because single food item rather than the combination of the food can impact the blood sugar differently. And it doesn't consider all the variables that affect the blood sugar, such how food is prepared or how much is eaten. And it only includes the food that contain the carbohydrate. And it doesn't rank the food based on the nutrient content. Food with the low GI ranking may be high in the calories, sugar, or the saturated fat. Even ADA, standard of medical state, the glycemic index can provide the additional benefit to total the carbohydrate control. Even food with low GI less than 55 produce a low post-meal glucose elevation, and food with high GI more than 70 show high postprandial value. And the glycemic load is equal to glycemic index multiplied by amount of the available carbohydrate food per serving divided by 100. So it high with the high glycemic load with more than 20. Glycemic load between 11 to 90, there is an intermediate, and glycemic load less than 10, there is a low glycemic. So these are the some foods which are suggest the high glycemic index. So dates, cornflakes, jelly beans, puff, potato, donut, French fries, white bread, all are the high glycemic index. But you just see the difference. The French fries has the 75 high glycemic index, but the glycemic load per serving is 22. So these are the glycemic index and the glycemic food chart. So white bread has the 64 glycemic index and the glycemic load per serving 23. These are the 10 low glycemic fruits for the diabetic patients. First is the cherry, grapefruit, dried apricot, pears, apples, orange, plum, strawberry, peach, and the grapes. How the carbohydrate counting? A dietitian determines a person's dietary needs. The individual is given a daily carbohydrate allowance, and the carbohydrate allowance can be expressed in the grams or in the number of the carbohydrate portion allowed per meal. So suppose the total 6 meal per day. So 3 is the main meal and 3 is the snacks. So distribution of the carbohydrate in the daily meals divided into 6. Breakfast in the 15%. After the snack 1, 10%. Lunch is the higher 30%. Snacks 2, 10%. In dinner 20%, and snack 3 is the 15%. That's the how it's 6 meals divided in the day. Even Deep Sea guideline also suggests calorie distribution, especially in the breakfast. So as part of the medical nutrition therapy, pregnant diabetic are advised to widely distribute their calorie consumption, especially the breakfast, because by this undue peak in the plasma glucose level after the ingestion of the total quantity of the breakfast at the one time is avoided. For example, if 4 idli or chapati or the bread applied to all the breakfast menu is taken off for the breakfast at the 8 a.m. and after 2 hours, postprandial blood sugar is 140 milligram. Suppose the quantity divided into 2 equal portions, 1 portion at the 8 a.m. and remaining after the 10 a.m. and after the 2 hour postprandial is almost 120 or 110. It fall by the 20 to 30 milligram. So this advice has scientific base as the picking of the plasma glucose is high with the breakfast, then with the lunch and the dinner. So GDM mother have deficiency in the first phase insulin secretion, and to match with the insulin deficiency, the challenge of the quantity of the food at the one time should also be less. So I just already mentioned, rather than the 4 idli at the one time, 2 idli at the 8 a.m. and another 2 idli at the 10 a.m., it falls the sugar almost 20 to 30 milligram, right? So what are the artificial sweeteners like saccharin, aspartame, neotame, sucralose, stevia? All are the data concern the use of the sugar substitute during the pregnancy are limited, so they don't suggest the increase the risk of the toxicity, even adverse pregnancy outcome or the neonatal issue. So it is recommended that it can be consumed in the moderation, and that pregnant women adhere to ADI level outlined by the regulatory derivatives. For fiber, 2 types, soluble and the insoluble fiber. So for soluble, there's a legumes, oats, and the fruits. And for insoluble fiber, there's a whole grain, bread, cereals, and some vegetables. So both increase the satiety, slowing the absorption time, and lower the glycemic index. So one study compared with low fiber, moderate fiber, and high fiber diet in non-insulin requirement the women with GDM, and this study conclude the pilot study demonstrated the high fiber diet were not associated with the lowering of the blood glucose level. So for dietary protein, ADA recommend the protein almost 15 to 20%, and protein content in the ADA diet and euglycemic diet up to 20% of the total daily calorie intake. And increased satiety has been seen with the meal that high in the protein content. So in Indian scenario, increment of the protein intake is necessary and up to total 1.1 gram per kg per body weight per day women required. So for fat, there is the less than 10% saturated fatty acid and up to the 10% polyunsaturated fatty acid required. And the remainder derived from the monounsaturated fatty acids. Even the fat contain calories to help the supply energy to you and your baby. So fat help your body absorb the vitamin A, D, E, and K. So fat also give you the essential fatty acids and help your baby's brain and nervous system development. So it is important to focus on the eating the healthful fats, and the following foods are good source of the fats like most nuts and the seeds, peanut butter, Protein oil like olive, canola, peanut, or the flax is very, very good. Avocado and the fatty fish like salmon. Even for the nutrient needs, there is no indication that the women with the GDM should not follow the same guideline for the nutrient intake for all pregnant women. Even exercise is an obvious adjunct therapy to MNT for the women with GDM, and light and moderate intensity activities such as walking for 20 to 30 minutes per day, it can be safely encouraged, and modest improvement in the glycemic control and might be achieved. For physical activity, planned physical activity of 30 minutes per day is recommended for all individuals capable of participating, and advising the GDM patient to walk briskly or do arm exercise while seated in the chair for at least 10 minutes after the each meal accomplishes this goal. And regular aerobic exercise with proper warm-up and cool-down has been shown lower the fasting as well as the postprandial glucose concentration in several small studies for previously sedentary individuals with GDM. Even exercise is an obvious adjunct therapy to MNT for women with GDM. One study of acute effect of exercise on the glucose level showed almost 23 milligram per deciliter drop in the glucose value at the 30 minutes. However, the safety of the prescribed exercise for glucose management has been a concern, and women should monitor fetal activity and blood glucose level before and after exercise and limit the physical activity of 15 to 20 minutes. And women who have been physically active before the becoming pregnant are encouraged to continue their active lifestyle. So before exercise, 5 to 10 minutes should be spent stretching in order to warm up the muscles and minimize the risk of the ligament and injury or the muscle cramps. Aerobic exercise will be most beneficial to control the blood sugar level. And this type of exercise include walking, stationary cycling, swimming, or exercise. And daily exercise for 15 to 30 minutes is recommended. Even exercise and glycemic control is very, very important in the GDM patients. Know the benefit of the exercise while you are pregnant. It is the back and pelvic pain, lower the blood pressures, prevent the excess weight gain, it relieves the constipation, it improves your mood, and it prevents the gestational diabetes. So how to manage the gestational diabetes? First is short meditation session. Second, walk after the meal. Third, monitor the fasting glucose level and after every meal. Fourth, plan for meal and snacks. Fifth, maintain a food load and understand the food that help or hurt. And sixth, it's difficult to manage, take the medication, but stay calm and still try to manage the diet and forwards. So 12 for the exercise through entire pregnancy, manage the glucose and stress hormone level, develop a safe weight training program with medication, stay with the low impact aerobic training, pilates and yoga are gaining popularity, and postpartum exercise, weight loss, depression, improve the fitness and lifestyle habits. So these are the current info on the exercise and the diabetes. Exercise in the equation. So by that, I conclude my slide. Nutrition recommendation for the women with GDM including the management of the gestational weight gain, control of calorie intake, modifying the macronutrient composition and distribution, and providing vitamins and minerals to meet the pregnancy need. And food plans should be designed to fulfill the minimum nutrient requirement for the pregnancy, for achieve the glycemic goal without weight loss or ketonemia, and be culturally appropriate and individual to take into account the patient's body habits, weight gain, and physical activity. And nutrition intervention for GDM emphasize healthy food choice, portion control, and put in practice that can be continued postpartum and may help to prevent the later diabetes, obesity, cardiovascular disease, and cancer. By that, thank you so much.
Thank you, Dr. Malay Panik, sir. That was a wonderful, wonderful slide and presentation. Okay, next we have Dr. Arun Shankar, sir. He's a medical director and consultant diabetologist at Jyoti Dev's Diabetes Research Center in Trivandrum, alumnus of Government Medical College, LFP, chief coordinator of diabetes telemanagement systems at JDC, investigator in various clinical trials. He's a speaker at local and national forums, including RSSDI and Diabetes India, etc. Major publications in international journals. He's a GC member, RSSDI Kerala chapter, joint secretary IMA New Mom branch. Over to you, Dr. Arvind Chakra.
Thank you, Dr. Smriti. Am I audible? Thank you. So let me share my slide. Yeah. So at the outset, first of all, I would like to congratulate Dr. Rutul, Dr. Amit, Dr. Dharmendra, and the entire team of PSG. And also, thanks a lot for this wonderful opportunity. And that too, to discuss on another important topic, that is continuous glucose monitoring in pregnancy. So let me start with two different case scenario. Actually, I'm not going into the details of this case, but just showing the basics of this two particular cases. The first one, a 28-year-old lady working in a bank. She's very busy and diagnosed with diabetes during pregnancy. And as usual, going by the recommendation or guideline, started treatment with diet modification. But during monitoring, sugars were very high. So she was forced to be on medication, that too started on insulins. And she was happy with regular monitoring as we were advising, because pregnancy is that particular time. If you are going to advise your patient regarding something that they should do in their management, they will do, or they will continue the advices being given to them properly, because they are very keen to have a healthy child as well. So she started monitoring as advised, but her fasting sugar as well as the BP was high. It was not getting controlled with the usual initial treatment approach. She was not having any other comorbidities. Yes, of course, she had few hypos while managing with insulins. And definitely we were titrating insulin dosage according to the blood sugar values. And at that time, the team advised on having a proper glucose monitoring rather than the usual recommendation to go for 6 or 7 times SMBG a day to titrate the insulin dosage as well as to modify the lifestyle accordingly. But when we advised regarding the continuous glucose monitoring system, which she can use amidst the busy schedule which she is having at her work, she was willing and she started using that. So let me move on to the second case. You can see the second case as well. 26-year-old lady, software engineer. Again, a very, very busy scheduled person. She's having a hectic schedule at her work and diagnosed with GDM, started on management. Initially, this particular patient was not at all willing to go for a regular monitoring of blood glucose, just like what I had explained in detail regarding the first case as well. But this patient, she was not willing to have regular pricks. And initially, she was not even willing to go for any medical intervention as well. But the team has to convince, and her gynec also discuss in detail about the risk for having uncontrolled blood glucose, which can affect her child as well. So again, she was not having any other comorbidities. She was having hypos. She was having frequent hypos by initiating and continuing the management. And again, she was not willing for regular monitoring. So with this two different case scenario, let me share with you their continuous glucose monitoring data. You may be thinking like the second case, she was not willing, but after regular motivation and counseling, she was willing and she went for the continuous glucose monitoring initially. So the first graph, you can see the first case. Again, the graph shows the continuous glucose monitoring data shows there is huge blood sugar variability. The second graph is much more worsened than the first one, which I have shown here. So again, we are discussing today and tomorrow, and we are going to listen more and more about gestational diabetes. So the increase of or the prevalence of gestational diabetes is more along with the increase in the obesity. And see why we are discussing about the better control in blood glucose level, that is being highlighted here, because you can prevent something which can happen to both mother and child. So definitely the maternal glycemic control is a modifiable risk factor which can have a better result as well to prevent prenatal or postnatal or the health issues going to happen for your pregnant mother or the child. So the glycemic target being recommended with the SMBG levels being highlighted here very clearly. I'm sure that this will be discussed in detail in these 2 days as well. So fasting glucose 70 to 95, 1 hour postprandial 110 to 140, 2 hour 100 to 120. So we were monitoring so many other blood sugar parameters as well, including HbA1c. But in pregnancy, you know very well that we are not having a clear data on the glycemic variability with regard to the particular patient if you are going to have just SMBG or HbA1c. So the lack of information regarding the glycemic variability, again, the excursion which is happening is important, and there lies the importance of going for continuous glucose monitoring. And again, with the data which we are discussing about time in range in diabetes management, the glycemic variability which we are discussing, you can see very clearly that the usage of continuous glucose monitoring, excuse me. Yeah, so in type 1, type 1 and in type 2, you can very clearly see the recommendation of time in range being advised and the different other categories of diabetes as well. So if the patient is able to achieve better glycemic control, that is the time in range being achieved. Excuse me? I'm getting some disturbances. Yeah. So for each 5% increase in time in range in a pregnant lady who is having gestational diabetes, the increase in the benefits both for mother and baby is much better. That is the data which we can get. So again, while discussing about the existing data which we are having already, it is sure that the clinical trials or the real life scenario with the usage of continuous glucose monitoring in pregnancy is very less. You can very clearly see that the different trials both in type 1 and type 2 diabetes, and what was the outcome with the usage of continuous glucose monitoring, that too the real-time continuous glucose monitoring in these patients. So in type 1, the data shows that the incidence of baby going for macrosomia, or the weight gain for the baby, is less with the usage of proper continuous glucose monitoring, as well as the other neonatal risk involved. Both type 1 studies have clearly shown, but the type 2, we are not having a clear-cut data where the CGM is being shown with benefits just like type 1 studies. So type 1, definitely you have so many data, so many clinical trials or real-life scenario available. So here again, going for the time in range in the different trimesters will help in reducing these events or associated with a lower risk of preterm birth that starts with first trimester of about 46.2%, 68% in second trimester, and more than 90% in third trimester. So definitely the usage of CGM in type 1 diabetes will help, and in type 1 diabetes already these patients will be on multiple daily injections where the CGM will be getting benefited or will be useful for proper titration of insulin as well. So here again, I'm going to show the difference of recommendations in time in range, both in type 1 and type 2 being highlighted here. See the first one, the type 1 case, in type 1 diabetes patients, that time in range or the target range being advised is more than 70%. But in type 2, it is a little more than 90% is the recommendation to have a better glycemic control. So in type 2 as well, the data is very limited, and the technology, while advancing, going for more and more advancement in technology, again, we should have more data or patient safety records available with the usage of continuous glucose monitoring in pregnancy. So when we compared with the healthy with mild gestational diabetic pregnant woman, this was the observation. Blood glucose remained in target in women with mild GDM, but we were not able to have a proper idea or picture of the glycemic variability. So when we measured the glycemic variability, it was very clear that patients with gestational diabetes was having much higher glycemic excursion when compared with the healthy counterpart. So blood glucose values were more than 160 milligram observed in 41% of GDM versus 18.2% typical pregnancy. And you can see the glycemic excursion which was seen in gestational diabetes as well. So here again, another observation was with the usage of continuous glucose monitoring, HbA1c reduction was benefited to have a better pregnancy outcome in a randomized controlled trial in Malaysia. So we don't have that much data to discuss on time in range and the glycemic goals in pregnancy with type 2 diabetes, and better glycemic variability being addressed will definitely help. That's what the data shows. And in that gestational diabetes, definitely the variability in glycemic excursion seen is very, very high, and which has to be addressed with the usage of proper glucose monitoring, the only way with which we can address that matter. Because SMBG, the snapshot being observed or monitored like 6 or 7 values a day, won't be giving a clear-cut picture of the glycemic excursion. Why we are going to monitor the continuous glucose monitoring part in pregnancy? So with regard to all those things in a pregnant lady, let it be with regard to diet, physical activity. My dear friend, Dr. Malay was explaining in detail about the monitoring of blood glucose while the pregnant lady is going to plan for a physical activity. So with regard to diet, physical activity, and the treatment part, let it be insulins or any other thing which we are advising for the diabetes patient, usage of continuous glucose monitoring will help to have an idea and to plan accordingly to have a better glycemic control. But the tips which you can give or the advice which you can give for the GDM person while using CGM is expect out of range readings, because like what I said, for going for SMBG, you won't be getting the exact glycemic picture of that particular patient. And with the usage of real-time continuous glucose monitoring only, the lady will be seeing her huge blood glucose values at times which are missed during the SMBG. Do not overreact for readings. These readings are meant to act properly with the help of the treating team involved. Expect slow insulin absorption. Make the best dietary choices. Definitely, the continuous glucose monitoring data will help your patient to have a better diet modification, so that many a times what happens in GDM is you have to take care both need of mother and child. So the nutritional deficiency which can happen in few of your diabetes patients, because they fear that when they have a proper healthy diet as well, the sugars will go high. So with the usage of continuous glucose monitoring, they can plan a better diet with the help of the team and the dietitian involved in the care. Timing of insulin before meals. See, it is clearly shown. The different trimester also, the difference in the insulin timing is there, which again can be obtained from the continuous glucose monitoring data. And again, with regard to physical activity, which I have discussed. So while using continuous glucose monitoring, that is the real-time monitoring where the patient is seeing the blood glucose trend or the levels or the arrows which she can have the blood glucose trends while monitoring with the usage of continuous glucose monitoring. So with the down arrow and the up arrow, the decision can be made accordingly. Again, insulin titration can also be made with regard to the arrow or the trends which we see in the glucose monitoring. So different organizations, different forums advise on the usage of continuous glucose monitoring, including the recent ADA updates also. It was clearly discussed that usage of technology, that too the continuous glucose monitoring will definitely help in better glycemic control. So this again shows different forums explaining. And from around part of the world, it was clearly discussed and published in the PubMed. From the paper, you can see that. And the recommendation or the frequency of CGM being advised with regard to the existing time in range. If the subject is having 90%, you can have a recommendation to go for once in 6 months. And if time in range is more than 70%, once in 3 months. And if time range is more than 50%, you can at least do in once in 2 months time. So definitely our aim or our idea is to achieve a better glycemic control among your patients. It won't be that easy to achieve 100% time in range, but still you can try to have a better glycemic control with the usage of continuous glucose monitoring. So again, in type 1 diabetes pregnancy, more than 70% of time in range is recommended. In type 2, that is the gestational diabetes, which we see time in range advised is to go for more than 90%. So with regard to the cases which I have discussed, the team involved in our diabetes care, the diabetes telemanagement system, where the doctor, the dietitian, diabetes nurse, educator, all are involved. And these two cases which I have started with were continuously counseled and educated with regard to the usage of regular monitoring, either with SMBG or for going for continuous glucose monitoring. Both of the patients went for the continuous glucose monitoring, and they are doing very well. And the first lady almost completed 7 months now. Blood sugars are under control. Almost 90% of the glycemic trend is in time in range without significant hypoglycemic episode. The second case, which she was not that okay with regular monitoring, she again went for the continuous glucose monitoring, but not up to the mark which we expected. So this was the observation and the case scenario which I have discussed. To summarize, definitely the technology will help you to manage your diabetes patients. So the advancement or the newer technology with the aspects of glucose monitoring being specifically discussed, definitely you will be able to control your patient's blood sugar, and each incremental 5% increase in time in range is associated with clinically significant benefit in pregnancy, both not only in type 1, definitely your type 2 patients will also be getting benefit of that. But definitely our data, the available data is very less. We would have to have more and more data or clinical trial involved in continuous glucose monitoring, in particular with pregnancy, so that our patients will have a better control without going for any complications further. So with this, I would like to conclude, and I would like to thank the entire team of PSG, Dr. Rutul, Dr. Amit, all those involved, and congratulate for the whole huge success of this event. Thank you.
Thank you very much, sir. That was a great presentation. Next, we have Dr. Padmanabh Zinzuvadia, sir. He's an MD Medicine and Consulting Diabetologist, running his own diabetes center in Adya Diabetes and Medical Care Center. Co-consultant with Dr. Sanjeev Pathak. He's also a diabetologist at Vijay Ratna Diabetes Diagnostic and Treatment Center. Honorary services at Dev Hospital, Vasna, and Thakur Sri Charitable Trust Hospital. He has published articles in Nutrition Journal as well as in National Journal, conducted several clinical trials as a principal investigator or as co-investigator, life member of various organizations. Over to you, sir. Dr. Padmanabh Zinzuvadia, sir. Welcome.
Thank you. I think my slides are visible to you.
Yes, sir.
So thank you, PSG Group, and particularly the Rutul Goklani and Dr. Dharmendra. I am very thankful to both of them for inviting me as a speaker. And PSG as a whole group has done the successful and great event year by year. So I wish that the group continuously doing the same events year by year. Today my talk is pregnancy with complication in GDM. So here I am presenting the case that a 29-year-old female patient that is referred by our dear gynecologist. Patient is primary gravida with a 20-week of pregnancy. Her glycemic profile are disturbed, like A1C of 6.4, fasting sugar is 123, post-prandial is about 168. Her body mass index is about 27 before the conceptions, and now the patient has a polyhydramnios as well as baby is last for gestational age. There is no particular significant about the medication, past medication history, or there is no significant thing in the family history. So overall, the case of gestational diabetes with a complication like polyhydramnios and large for gestational age,
our gynecologic friend interested for the team management and referred the case to the diabetologist. So I really happy that the team approach, particularly in case of GDM as well as in the pre-existing type 2 diabetes or type 1 diabetes with a pregnancy, is very important aspect. What is the difference between the GDM and pre-existing type 2 diabetes? I want to highlight that. So main important point is that the level of glycemia, the burden of glycemia, that in case of pre-existing diabetes, fetus is going to exposed to the hyperglycemia from time of conception till the delivery, but it is not so in case of the GDM. So particularly pre-existing diabetes patient facing the higher morbidity as well as the complications. So like congenital malformation or teratogenicity is more common. But by saying that GDM is also not spared with other complications, it has also its own complication due to the hyperglycemia. So are there any data that hyperglycemia has complication? So there is one important study, that is a HEPO study, document that there is a strong and continuous association of maternal glucose level that is below the diagnostic of diabetes with increased birth weight and increased cord blood serum C-peptide level. So increased serum C-peptide level is a marker of insulin resistance, and insulin resistance is a pathognomic feature of gestational diabetes mellitus. So GDM is not only associated with the increase in the birth weight of a baby, large baby, but there are the battery of complications with gestational diabetes like preeclampsia, premature delivery, primary cesarean delivery, shoulder dystocia, intensive neonatal care, or other complications as shown here. So the complications are documented in the HEPO study, but there are the data from the various regions across the globe saying that same complications. For here, I am quoting one data presented by the Ethiopia. Even though small country has a data that GDM patient GDM patient facing the comorbidities like a cesarean delivery, pregnancy-induced hypertension, induction of labor, premature rupture of membrane, and so on. So here the data are also supporting the HEPO study. So overall, we can say that if there is a hyperglycemia above the normal range, then the patient is going to face the complications. How to diagnose the gestational? How to diagnose the GDM? Usually in India, we prefer the DIPSI test, and we know about that. And what are the criteria for the diagnosing the GDM is also we are very well aware of that. The important point that I would like to highlight that it is a logical that presence of hyperglycemia is associated with complication. Similarly, it is a logically true that if we reduce the hyperglycemia, we can get the better outcome. So is there any data? ACOIS trial, it is there where the treatment of gestational diabetes reduces the serious perinatal morbidity, and there is an improvement in the woman's health-related quality of life. So even the correction of the hyperglycemia gives the good maternal outcome. So in our case, patient has polyhydramnios as well as the large baby that is a large for the gestational week, and there is a hyperglycemia. So overall, the team approach for the management of obstetric part as well as the diabetes part is very important. So basic main part of the management is the lifestyle modification, diet, exercise, and the drug medication, that is insulin or oral anti-diabetic drugs, and lastly the monitoring. This is not sufficient for the overall management. I would like to emphasize that patient education is very important, as one hand cannot clap. Similarly, without patient education and involvement, we cannot offer or ensuring get the optimal outcome. So it is better to encourage the pregnant woman to take charge of her own health and well-being. Most pregnant women want the best for their unborn babies. So the education provides them the tool to achieve this goal. What should be the component of education? So it is a knowledge about the diabetes as well as the GDM. but it is not. It should not be end here. The importance of the regular follow-up, importance of the compliance with diet, exercise, and medications, as well as the how to store insulin, how to administer the insulin, and technique regarding that. Sick day rule for the sick patient, as well as what to do in case of hypoglycemia, and importance of retesting glucose after delivery. These are all the important things that should include in patient education. From the monitoring aspect, I would like to say that frequent monitoring of glycemic control and prompt changes in the management are essential to ensure good outcome. So the options are here like self-monitoring of blood glucose, that is SMBG, HbA1c, CGMS, as well as the serum fructosamine assay. In detail, the CGM is very well explained by Dr. Arun Shankar. So I have to say nothing. SMBG is, I can say that it is easily available. It is approachable for the every patient, as well as it is a cost effective. So according to the need of the patient, we can ask for the patient to do 1 sugar per day to the 3 profile, 4 profile, 5 profile, or even 7 profile per day. It is depend upon the need of the patient. There should be the monitoring part also include the fetal abdominal circumference, which is a marker of maternal glycemic control. So better rapport with a gynecological friend and better communications gives the idea about how we are going further in case of the GDM. As well as we have to also address the other comorbidity if it is there, like hypertension, thyroid dysfunction, and we have to also address, or we have to keep in mind that hypoglycemia and ketosis should be avoided. When we considering the therapy of a GDM patient, the glycemic control very well we cannot get without medical nutrition therapy. So the MNT is the first line of management. It should fulfill minimum nutritional recommendations, and MNT should achieve glycemic goals without weight loss or undue weight gain, and we have to avoid ketosis. What should be the component of the MNT? Meal plans should be tailor-made and easy to understand and follow. Small frequent meals are ideal, or avoid the hypoglycemia and starvation ketosis. Avoid prolonged fasting. Bedtime snack is advisable to prevent the development of ketosis at night and ensure adequate hydration and avoid fruit juice. Regarding the diet and modification, lifestyle modification and exercise, Dr. Malay has mentioned very well in his slide. So I shortly describe the component of each of that. Physical activity, planned physical activity of 30 to 45 minutes per day is recommended. It is better to avoid sedentariness. Activities that increase the blood pressure should be avoided, like lifting the heavy objects. Upper body resistant training has been shown to reduce the glucose level in the 3rd trimester. And if the physical activity is restricted by the obstetrician, then it is better to avoid. The patient should adhere to this advice. If the MNT is failed to achieve the glycemia, then insulin is the treatment of the choice. So we can wait up to the 2 weeks. If sugars fasting of more than 95 and 2 hours persist about more than 120, then it is better to switch over to the insulin. If at the time of diagnosis, blood sugar fasting that is more than 120 and 2 hours if it is more than 200, we can straightforward start the insulin therapy. And during the whole therapy, target should be according to DIPSI guideline, fasting should remain 90 or below that, and 2 hours should remain 120 or below that. So insulin is the mainstay of the therapy, and we know about the various type of insulin. Depending upon the time action profile, the insulin preparations, we can categorize them into the short acting insulin, intermediate or long acting insulin. So Lispro, Aspart and Glulicin are the rapid acting, regular insulin are the short acting, NPH and Datamirs, we can say that they are intermediate acting, and Glargine, Degludec and Glargine U300 are the long acting insulin. But all insulin are not approved for the use in the GDM patient. The approval given to the some of them are regular insulin that have a category B, short acting insulin like Aspart and Lispro that has also the same B category, but Glulicin has a C category, so it is better to avoid Glulicin. NPH and Detamel both are intermediate acting and both have a B category approval. So we are using usually the Detamel insulin as well as the short acting insulin, either regular or either the aspart. Degludec and the Degludec insulin and the Glargine U300 have a C category C, so they are avoided. Recently, the Glargine U100, which has a previously C category, now it is removed from that category, but there is no human pregnancy data, so it is still not to be avoided. But there is some paper about the Glargine U100 I would like to highlight here. So here the paper published by the author Dr. Pratap Jethwani, Dr. Bansi Sabu, and so on. What is the conclusion? That use of insulin glargine during the pregnancy, insulin glargine can be continued safely during the pregnancy in women who are already taking it prior to the pregnancy and have achieved good glycemic control with it. However, we require preferably randomized control trial or larger prospective observational studies to establish it as a first line or preferred basal insulin for management of hyperglycemia during the pregnancy. So now there are some data for the usage of Glargine U100 in the pregnancy, but it is still better to avoid. If insulin, alternate to insulin, there are the oral hyperglycemic therapy. Metformin has a B category, and we are using the metformin during the pregnancy, but other medications still we have to avoid. So are there any data for the safety and efficacy of metformin during the gestational diabetes? One study, that is a MIG trial, is there, which is mentioning that in women with gestational diabetes, metformin is not associated with increased perinatal complication as compared with insulin. So we can say that metformin is safe during the gestational diabetes management in case of GDM patient. Here, one of the follow-up study of a MIG trial, that is a MIG tofu. Also,
Dr. Padmanabh.
Yes.
Sorry to interrupt, but please try to finish in 2 minutes and 30 seconds.
Now, last 2-3 slides. So MIG tofu is also supporting the same way that children exposed to the metformin had a larger measure of subcutaneous fat, but overall body fat content remain the same as that of a patient treated with insulin alone. So safety data of metformin is there. Glibenclamide has a limited data. Safety is still not there. So therefore its use cannot be recommended, as well as same for the other oral anti-diabetic drugs. So their use cannot be recommended during the pregnancy time. In our case, patient is delivered at full term with a baby weight of 3.2 kg without any complication. So overall, what are the take homes in women with a GDM? MNT is the first line of management. If glycemic target are not achieved with MNT, pharmacotherapy is indicated. Insulin is the treatment of choice, and metformin can be introduced if glycemia not at goal or higher insulin is required. Thank you for listening, and here I would like to conclude. I hand over to the chairperson. Thank you.
Thank you very much, sir. That was a very informative session. Now I open the floor for discussion. I do want to thank everyone, Dr. Gokulani, as well as Dr. Dey and Dr. Dharmendra sir, for this wonderful, wonderful conference.
Yeah, we can have 1 or 2 questions, not more than that, as we are starting ACP symposium here only. So, thank you.
So if there are no more questions, I think
yes, we can move forward to the next symposium.
Can conclude the session and we can move forward to the ACP. So I invite Dr. Anuj Maheshwari sir to take over for the ACP symposium. Dr. Anuj Maheshwari is an MD, FICP, FIACM, PIMSA, FRSSDI, FSCP. He's a professor in medicine at Hind Institute of Medical Sciences, Lucknow. He's been a mentor for all of us, and a person who needs no introduction. Over to you, sir.
MBBS more 100 time leader. This figure, please.
Anuj sir, unmute, please.
Sir, you're on
sorry.
mute.
I'm sorry. Now, so I must congratulate Dr. Amit Dey and Rutul for organizing this wonderful update, and which is virtual as well as physical, and collecting all great faculties from across the country. And I really feeling proud of both of you, and I am feeling proud to associate American College of Physicians of India chapter with this particular update. ACP Symposia, we are trying to make it more and more to be useful for users, as for listeners, as well as our members. We always try that link should be reaching to all ACP members whenever any such program is being organized. This time we are also having a very wonderful topics in this symposia. Our chairpersons are Dr. Ajay Tiwari, Dr. Surajit Patra, and Dr. Ashish Saxena. Dr. Ajay Tiwari is very closely associated with me in RSSDI UP chapter. He is from Lucknow, and he is helping me now, not only in RSSDI, but also in ACP Governing Council as a Joint Secretary. He is helping me. And Dr. Ajay Tiwari himself is a very good diabetologist in Lucknow. He is running a Jaya Diabetes Center and clinic in Lucknow. And he is a well-known personality as well as well-known figure and well-known diabetologist at Lucknow. Dr. Surajit Patra is again a very dynamic personality. He is having the fellowship in diabetes. He is director and consultant diabetologist, and he is running a Dr. Surajit Patra's diabetes clinic at Bhubaneswar. Dr. Ashish Saxena, a person who is having a lot of research inclination and very research inclining personality, working and practicing at Ludhiana. He is a consultant of the internal medicine, diabetes, as well as non-invasive cardiology, in running a diabetes and cardiac center at Ludhiana. So I will request all my three chairpersons to chair one session each. Dr. Ajay Tiwari will request Dr. Ajay Tiwari to introduce our first speaker, and later on summarize the talk and run the question answer. I shall always be there to help you. Over to Ajay Tiwari. Dr. Ajay Tiwari, is he not there? So I think he's disconnected for somehow. So I must do that job. Dr. Rakesh Sahai is again a very prominent figure in India. He is a great personality as well as he is very great clinician. He is president-elect of the RSSDI, which is the largest body of the diabetologists across the world. He is a professor and head in the Department of Endocrinology, Usmania Medical College and Hospital, consultant endocrinologist at Sahai's Endocrine Diabetes Center at Hyderabad. He is president of Endocrine Society of India, vice president of the South Asian Federation of Endocrine Societies, section editor in Tropical Endocrinology, Endotex, online textbook of the endocrinology, editorial board member of the IJEM, national EC member of RSSDI, organizing secretary RSSDI National Conference 2016. Actually, he is president-elect RSSDI now. He has been promoted from the national EC members to the president-elect. So he has got multiple awards. I don't think I should waste my time on reading all the awards, and a lot of publications, more than 150 publications in various national and international journals. And he is a terrific speaker. We are going to listen his deliberation on thyroid and gestational diabetes very soon. Over to Dr. Rakesh Sahai.
Thank you, Dr. Anuj Maheshwari, who's a very dear friend, and we have been working together for many years now. So I thank him for the kind words of introduction, and I congratulate Dr. Rutul, and all the other members of the organizing committee for putting up such an excellent show, excellent program. and I think I should congratulate them. As Dr. Anuj mentioned, it was both virtual today, and also I think it is going to be physical tomorrow. So I'm sure it's going to benefit many people. So I will go on to my talk. My talk is on the link between thyroid dysfunction and diabetes. So we see, and GDM. Particularly, we see a lot of people, a lot of lot of women having these two problems, because both of them are independently very common endocrine problems. That is, both gestational diabetes, we have been hearing about it, and we also know that thyroid disorders are also equally sort of common in pregnancy and have a significant impact on the outcomes of pregnancy. And therefore, what we want to see is that what is the link between these two? Are they just that they are two different independent disorders that are happening simultaneously, and coincidentally they are occurring in the same patient, or is there some link between them? So that I'll try to sort of dissect out this in the next 15-20 minutes or so. So if you look at the prevalence of, I don't need to do this because this has been discussed a lot of times now, that diabetes in pregnancy is very common. 1 in 6 live births are affected because of diabetes, because of pre-gestational diabetes or gestational diabetes, and we know that there are more than 5 million women with gestational diabetes in India, and the prevalence rates have been variable across different states. Some of the states having high prevalence, while others may be having a slightly lower prevalence. And at the same time, if you look at hypothyroidism, what we would like to say is that we have actually looked at the prevalence of hypothyroidism, and we have found that from the earlier studies where the prevalence rates were very less, as you can see in some of the studies, it was about 2 to 3% hypothyroidism in pregnancy in the US. But in our country, we find that it's quite higher. This is one study from North India showing 6.47 prevalence. But we did a 11 city study across 9 states of India, and we found that the prevalence rate is to the tune of about 13%. When you're looking at 4.5 cutoff of TSH, we found that the prevalence was 13%, and showing that it is quite a significant problem. Anti-TPO antibodies were positive in 20% of the patients. So this was a study which we published in 2016, and this was published in IJEM, and I was part of this study, and we had other investigators from across the country. Dr. Dinesh Dhanwal was coordinating this. We had from all the 9 states we had representation, and we found this prevalence of 13% in this study. Now, so what we are saying is that there is a significant change in thyroid function during pregnancy. There is, because of the fact that there are hormonal changes that happen in pregnancy. There is increase in estrogen levels. There is increase in the peripheral metabolism of thyroid hormones, and because of the and also the other important thing that happens in early pregnancy is that there is increase in HCG levels. HCG has a similarity in the structure with TSH, and that causes suppression of the TSH values, but there is also stimulation of the T4 levels, and there is also, in addition to that, there is increase in plasma volume, and so because of this there are changes happening. Because of the increased estrogens, there are increase in thyroid binding globulins, because of which there is increase in the total hormones, that is total T3 and total T4, but the free hormones will remain normal. And there's a transient decline in TSH in the first trimester because of the increase in HCG levels. And similarly, there is this increased peripheral conversion of T4 to T3, and so this happens because of placental deiodinase also that is there. So all in all, there is increased demand for thyroxine in pregnancy. Thyroid metabolism in pregnancy, the maternal requirement for thyroid hormones increases, and even in the first part of in the first few weeks of pregnancy itself, and later on the fetal thyroid starts functioning from the 10 to 12 weeks, and then probably the requirement is not as much as is there in the first 10 weeks of pregnancy. And untreated hypothyroidism, if it is not picked up and treated, it has several important effects on the on the mother and all the fetus, as you can see here. and it can increase the risk for antepartum preeclampsia, eclampsia, gestational hypertension, placental abruption. So all these things are the influence of untreated maternal hypothyroidism, and there is also association with fetal problems like growth restriction, increased perinatal morbidity and mortality, impaired psycho-intellectual development is another issue which most of us are worried about, but it has not been clearly shown to be very significant. But there are some minor grades of psychological developmental problems in women, in the infants of women who are not treated for hypothyroidism. So let's look at some of the studies which have looked at the impact of maternal hypothyroidism, untreated maternal hypothyroidism. There was a trend for adverse outcome, but it was not very significant in terms of the neuropsychiatric development. And now looking at the link between the two, that is thyroid dysfunction and glucose homeostasis, what we see is that the thyroid hormones regulate the hepatic gluconeogenesis, intestinal absorption of glucose, peripheral uptake of glucose. All these are influenced by the thyroid function. They promote the thyroid hormones promote glycogenolysis. They modify the circulating insulin levels and counter-regulatory hormones, and modulate the messenger RNA and protein expression of glucose transporters. Therefore, thyroid hormones have a significant impact on the glucose metabolism also. Now, if you look at the thyroid hormones, they act differentially in the liver, skeletal muscle, and adipose tissue. They oppose the actions of insulin in some of the tissues, while they synergistically act with insulin in the other tissues. So, as you can see here, in women who are euthyroid, you can see that there is an effect on the glucose increases the sort of, while the glucose has a stimulatory effect on the beta cell production of insulin. Thyroid hormones also have a complementary effect on that. They also influence the peripheral insulin resistance through influencing the GLUT4 activity. So thyroid hormones have a significant influence on the glucose metabolism. So is the link purely coincidental? Since we are seeing this relationship in the pathophysiology of these two problems, there is probably something more than just being coincidental. So some studies have found no clear association between GDM and thyroid dysfunction, while other studies have shown that there is that hypothyroxanemia or low thyroid hormone levels or hypothyroidism is clearly more common among patients with GDM. So this is what some studies have shown, and some other studies have shown that hypothyroid patients are at higher risk of GDM also. So both these may interact, may correlate. I mean, the prevalence of these problems may correlate because those who are having hypothyroidism, they tend to have higher risk of developing GDM also. And thyroid autoimmunity in GDM, is it associated? Could there be a causal relationship between thyroid autoimmunity and the autoimmunity that happens in GDM also? So these are some of the interesting issues which have not been very clearly studied. We don't have very clear information on that, but we have some studies which have looked at that. I'll just show you those studies, and then probably we can then conclude based on the available evidence, understand what is the available evidence showing. So if you look at the thyroid autoimmunity in gestational diabetes, we see that there is a clear clinical association between chronic autoimmune thyroiditis and type 2 diabetes in relation to the to certain common antigens that are shared by the pancreatic beta cells and the thyroid follicular cells. So these common antigens stimulate can initiate autoimmunity, which can be directed against the other cell type, as we can see. So hyperglycemia at the time of pregnancy or immediately after delivery triggers the autoimmune disorders. And it was shown, these are all animal data, that 10 millimoles increase in glucose levels in cultured thyroid cells can upregulate the major histocompatibility complex class 1 expression. This phenomena causes the thyrocyte to become an antigen presenting cell and possibly to overcome the self tolerance, and therefore there is thyroid autoimmunity initiated. Just because there is severe hyperglycemia, it can initiate thyroid autoimmunity. So this mechanistically this can happen. This is what has been shown in vitro models. And so we can see this interesting study which was looking at gestational diabetes and thyroid autoimmunity. This was an Italian study where what they did was they looked at 4 groups of individuals, 91 subjects in group 1. They were GDM pregnant women, non-GDM pregnant women. In the second group B1 had post-GDM women, and group B2 had healthy mothers. They studied thyroid autoimmunity by measuring the thyroid 3PO antibodies, the TG antibodies, the TSH receptor antibody positivity, and thyroid dysfunction. They looked at thyroid dysfunction, whether it was TSH was less than 0.4 or more than 4.2, or the combination of these. And what they found was that there was no difference for both thyroid function and prevalence of autoimmune disorders during pregnancy. A significant increase in thyroid autoimmunity was seen in women previously affected by gestational diabetes. So as you can see, those who had gestational diabetes, as we discussed in the previous slides, there was an increase in thyroid autoimmunity, and the increased prevalence of thyroid autoimmunity was not associated with the development of impaired glucose metabolism after pregnancy. So probably it has whether the GDM itself had an impact, or was it a inherent abnormality in these women, was not clearly made out in this study. So the other studies who have looked at there was a meta-analysis of 20 studies, of which 10 were cohort studies, 10 were case control studies, and they looked at the association between thyroid antibodies and gestational diabetes. And you can see, there was no clear message coming out of it, because some studies showing a negative association, some studies were showing a positive association, and finally, if you look at the final summary out of this, what we find is that overall, if you see the result, there was a 12% increase, you can say, in the prevalence of thyroid antibodies amongst women with GDM. And if you look at thyroid antibodies and the risk of gestational diabetes in youth-thyroid pregnancy, so what we can see is that again, we can see that there is a slightly increased risk of gestational diabetes mellitus in youth-thyroid pregnancies. Now let us look at the effect of hypothyroidism or hypothyroxemia on the risks of GDM. So in this study, this was again an interesting study which looked at the frequency of isolated maternal hypothyroxemia with gestational diabetes in a moderately iron deficient area. So this was not a totally iodine sufficient population. There was an iodine deficient area. 50 GDM participants and 60 non-GDM participants formed the control group, and TPO antibody positivity was 30% in the those with GDM, while 15% in the control group, non-GDM. So showing that there is increased TPO antibody positivity amongst the GDM patients as compared to non-GDM, and clearly showing that there is some association. And among the women with GDM, isolated maternal hypothyroxemia found in 8 and 14% in second and third trimesters. There is no significant difference between the case and control groups in terms of first trimester TSH and FT4 levels. So although there was autoimmunity, it did not significantly impact the occurrence of hypothyroidism. As you can say, the thyroid function was more or less equal between these groups. However, there was a slightly lower T4 levels in the first and second trimesters, as you can see in that study. So higher isolated mental hypothyroxemia, which means that there is a low free T4 level, but the TSH is not significantly affected. T3 levels are normal. This could be due to the effect of both pregnancy and glucose metabolism on thyroid function, because we know that in pregnancy also, normal pregnancy also, there is a slight decrease in free T4 levels because of the increased demand, and the total T4 levels are high. So that clearly is not made out in that study, because those studies were also having smaller number of participants. Now another interesting study looked at the low thyroid hormone in early pregnancy. Is it associated with increased risk of gestational diabetes? So this is an interesting study. So what they looked at was that those who had got thyroid hormone deficiency, and they looked at their development of GDM, because the deficiency in thyroid hormone comes up early in pregnancy. GDM comes little later in pregnancy. It comes in the second trimester. So they have looked at those who are having non-GDM versus they looked at the thyroid dysfunction, and they found the levels of free T4 in early pregnancy in GDM woman was lower than in non-GDM woman. That is, if a woman has lower thyroid hormone levels, FT4 levels, in early pregnancy, then she has got a higher likelihood of having GDM later on in pregnancy. So that was what was the conclusion from this study, which had a reasonably good number of patients. As you can see, there were almost about 23,000 non-GDM versus and 3,000 GDM. So almost about 26,000 individuals were studied. This was a Chinese study which looked at almost 26,000 women, and they found that those who had lower thyroid FT4 levels in the first trimester, they had a higher tendency to develop GDM in later in pregnancy. And another study, which was again a Chinese study, looked at thyroid dysfunction and autoantibodies in early pregnancy, and looked at its association with increased risk of GDM and adverse birth outcomes. So out of 1170 patients who were studied, participated in this study, maternal serum samples in the first trimester were tested for all that, and subsequently they looked at the occurrence of GDM. And what they found, although this is a busy slide, what I will say is that there was a 4-fold increase in risk of gestational diabetes in women with high TSH levels and thyroid autoimmunity in early pregnancy, showing that if you have a thyroid dysfunction in early pregnancy, the risk of GDM is higher. And this was a meta-analysis looking at the same relationship between hypothyroidism and the incidence of gestational diabetes. So they had several studies in this meta-analysis, and what we find is that there is almost 80% increase. As you can see, 1.89 is odds ratio for development of GDM in women who have got hypothyroidism. So clearly showing that it is important. That is, this is overt thyroid dysfunction. With subclinical thyroid dysfunction, the risk is about 1.58. Odd ratio is 1.56, showing that almost a 56% increase in risk of developing gestational diabetes. So clearly, these studies have shown that there is an increased risk of developing gestational diabetes in those who have early onset of thyroid dysfunction in early pregnancy. So it's important. The message that comes out is that although universally we are screening all women, but we should be a little more careful in those women who have thyroid autoimmunity or thyroid dysfunction early in pregnancy. We should look at doing that. We should not miss out checking them for GDM and appropriately managing them. Thyroid function in early pregnancy is an indicator of subsequent risk of GDM. The free T3 and free T4 level ratio in early in pregnancy is an independent risk factor for GDM. And increased levels of either marker makes the risk of GDM greater. The FT3 FT4 ratio is most strongly associated with GDM. Women with isolated hypothyroxemia in second trimester had an almost 3-fold greater risk of GDM. So what we are seeing is that with overt hypothyroidism, these risks are there. Even with subclinical hypothyroidism, the incidence of gestational diabetes is higher. This is another study showing the same thing, but that maternal TSH level and TPO antibody status in pregnancy and their relationship to the gestational diabetes. Clearly, we saw that over 7,884 pregnant women, out of which 1,141 developed GDM between 24 to 28 weeks. When they compared them and they looked for the thyroid function status and they looked at that, they said that women with overt hypothyroidism were at a significantly greater risk of gestational diabetes when compared with euthyroid women. Women with subclinical hypothyroidism also had a significantly higher risk of developing gestational diabetes when compared to euthyroid women. So hypothyroidism appears to negatively affect glucose homeostasis by inducing insulin resistance, and pregnant women with hypothyroidism have further amplified insulin resistance, and thus they have increased risk of gestational diabetes. Now, having looked at that, so clearly the message that we have got from all these studies, although some of them are small studies, but a meta-analysis of these studies has clearly shown that. Now, let us just quickly, in a minute or so, look about hyperthyroidism and gestational diabetes. So, hyperthyroidism has also effects on glucose metabolism, and it increases the hepatic glucose production, changes the insulin metabolism, increases the response to beta adrenergic stimulation, and increased plasma free fatty acid levels. And what we can see is that there is a clear relationship between the subclinical thyroid disease, even hyperthyroidism. Subclinical hyperthyroidism also leads to increased risk of GDM. As you can see that subclinical hyperthyroidism, the odds ratio for GDM, as you can see, hyperthyroidism, subclinical hypothyroidism is increasing the risk, whereas hyperthyroidism, subclinical hyperthyroidism is decreasing the risk. The incidence of gestational diabetes increases from subclinical hyperthyroidism to euthyroid to subclinical hypothyroidism. So clearly what we are saying is that the hyperthyroid ones, subclinical hyperthyroid ones, have a lower risk of GDM as compared to those with subclinical hypothyroidism, which tend to have an increased risk. So we are seeing that there is a connection between GDM and hyperthyroidism also, and hypothyroidism, which we have already discussed. Studies are showing conflicting results on the risk of gestational diabetes with hyperthyroidism. Few studies have found no association, but some have shown a negative association and some have also shown a positive association. So this is something which was not very clearly, although one of the studies which I showed, which showed this clear association, other studies have been having conflicting results. So we'll not keep that as an important factor, but subclinical hypothyroidism and overt hypothyroidism clearly have an increased risk of gestational diabetes. Now, with gestational diabetes, there is a higher risk of postpartum thyroiditis also. That is another link between the two. So with this, I'll summarize because we are running out of behind schedule. So I'll restrict my time and summarize by saying that conflicting results among various studies may be due to patient selection methods, inter-assay variability, and different number of participants in each study. There is need to carry out a universal screening for thyroid dysfunction among pregnant women in the first trimester, and this is this is something which we have been recommending in our country, that we should do this, and similarly we are also recommending that all women should be screened for gestational diabetes. So finally, I would summarize by saying that thyroid dysfunction is common in gestational diabetes. Both subclinical and overt hypothyroidism are associated with higher risk of gestational diabetes. In the presence of thyroid autoimmunity and thyroid dysfunction during pregnancy, women should be followed carefully in subsequent pregnancies for development of gestational diabetes mellitus. Though hyperthyroidism increases glucose intolerance, studies are inconsistent over its association with GDM. GDM may increase the risk of postpartum thyroiditis also. So these are the important associations that you should keep in mind. So with that, I'll conclude and I'll stop sharing my screen. I'll be happy to answer any questions if there are.
Thank you, Dr. Rakesh Sai, for a wonderful talk. We got really new information, and many things has been very much clear, which were not so much before. One thing comes in my mind always, that people, those who are being treated, especially female, those who are being treated for hyperthyroidism, do they have more risk of getting gestational diabetes, or those who are being treated for hypothyroidism, they are having more risk of getting GDM in their pregnancy?
Yeah. So I think the important message from this thing was that the hypothyroidism is clearly associated with increased risk of GDM. Hyperthyroidism, that association not very clear. There is a little confusion, and we can say it's not very clearly associated. We can't say that clearly that hyperthyroidism is associated with GDM, but hypothyroidism clearly has a good association. Overt hypothyroidism has a very clear association. Subclinical hypothyroidism also has an association, and these women should be, particularly we should be careful to screen them for gestational diabetes, because what happens is generally they get compartmentalized for being treated for the thyroid dysfunction only, and sometimes there is a delay in picking up gestational diabetes. So that should not happen. That is the message that we should convey to all our colleagues.
Thank you, Dr. Rakesh. I don't see any question in the chat box. If there is any question of our colleague, they can ask. And I think Dr. Rakesh's talk was so.
Other message was
clear.
that yes. Other message was finally that the GDM women have a higher risk of having postpartum thyroiditis. So
yes, sir. That is more important. That is very much important, and that is very much clear.
Yes.
There is, I think, evidence is very much clear about this, what I understand from your deliberation. Now, I think your talk was so clear and so lucid. I don't think any question must have been remained in anybody's mind. So people are very much clear about their doubts. Now, I will request my another chairperson, Dr. Surojit Patra, if he is here. What is happening to chairperson? They are disappearing. Surojit Patra has been disappeared. No worry. Ashish is there. So I will request Dr. Ashish to introduce our second speaker and do take the charge.
Well, thank you, Dr. Anuj. It is always a pleasure to introduce Amit Gupta, a leading diabetologist from the Center for Diabetes Care from Noida. He needs no introduction because he is available as a advisor to ADA. He is a reviewer, a scientific reviewer, as well as an executive editor. He is a program coordinator for RSSDI with multiple awards. So let me just give over to Amit so that he can give his deliberation and we get enlightened by his talk this time also, like always.
Thank you, Dr. Ashish, for the kind introduction. And thank you, Dr. Anuj Maheshwari, sir, for giving this opportunity for this prestigious ACP India Chapter Symposium of this Pregnancy Study Group India. I am thankful to you, sir, for giving this topic to me because it was totally a new topic to me and it was not my domain of expertise. And when Amit talked to me, he insisted that I speak on this. So I had to do a lot of research and I am thankful to you because I learned a lot while preparing for this topic. So I hope it will be useful for all the members who are attending this seminar. If my slides are visible, then I will proceed with the presentation. So today I am going to talk about whether dyslipidemia is a risk factor for the gestational diabetes mellitus, and we are going to look into this association. So why I find this particular topic very interesting is that it gave me a chance into the normal physiology of what actually happens during the pregnancy and what are the changes which happen during the lipid profile of a pregnant lady. So pregnancy in healthy women is associated with normal changes in lipid metabolism, and these lipid changes are essential for the growth of the fetus as well as for the development. Over the last few decades, we have seen that there is a surge in the number of patients with obesity. And now we frequently encounter patients who not only have pre-existing diabetes, but pre-existing hypertension, cardiovascular disease, and many other metabolic disorders before they conceive or they attain pregnancy. Also, there are a subset of populations of the women with gestational hypertension as well as diabetes, preeclampsia, and they have more marked derangement of the atherogenic profiles. So this is a new area which has now inciting a lot of research interest. And this is a field of dyslipidemia in pregnancy, and this is one of the hot area for the outcomes and the research. What I could understand from my research while preparing for this topic. So what happens during the normal gestation is that during normal gestation, there are changes which can be predicted in the lipid metabolism. And there is an increase in the lipid concentration as gestation progresses. What happens during the first trimester is that there is a marked deposition and hypertrophy of the maternal adipocytes. And this increased expression of the insulin receptors such that glucose is available to meet the metabolic demands of the growing fetus. So this is a physiological demand which is placed on the pregnant women to meet the demands of the growing fetus. An increase in maternal insulin in addition to the production of the progesterone leads to lipogenesis and decreased lipolysis and increased production of the lipids, which are then transported across the placenta and metabolized. This signifies the essential role of lipids to the normal fetal development. So what we understand is that rise in lipid levels happens in all the pregnancies, and this rise in lipid parameter is important for the growth of the fetus and the development of the fetus. If you look at this both during the early pregnancy as well as the late pregnancy, the changes which happen in the lipid profile, they actually bring the nourishing elements which grows the placenta and help the fetal metabolism and the fetal growth. So this is one part of the talk which I think now it is clear that why the lipid parameters they increase and why it is essential for them physiologically to increase. This is just a very busy slide, and it gives the same information which I have just narrated, that how the lipid parameters they change, how the lipid is metabolized, they cross the placenta, and how they support the fetal development and the growth. Now we look into the individual parameters, that what happens. Both the total cholesterol as well as the triglyceride levels, they rise throughout the pregnancy. While the triglyceride, they rise in particular, and the rise is disproportionate in comparison to the other lipid fractions, and they may attain 2 to 4 times pre-pregnancy levels by the third trimester. So for example, the rise can be almost up to the tune of 2 to 4 times in the TG levels. However, these changes are felt to be generally non-atherogenic and fall precipitously to pre-pregnancy levels following delivery. So what has been seen that the rise in triglyceride level is non-atherogenic during the pregnancy, but the inflammatory milieu, if it sets into pregnancy, leading to other conditions, can also increase the cardiovascular risk. So pregnancy is also associated with alterations in the composition and the size of the LDL particles. This is also very interesting. There are certain studies which have demonstrated that as the triglyceride levels they increase, there is a decrease in the overall LDL size, and with an increased proportion of the smaller, denser LDL particles that are thought to be more atherogenic. So there is a change in overall LDL size, and this may be contributing to the atherogenesis that happens. Also, it is not just the LDL levels. What happens to the HDL cholesterol levels in normal physiology? The HDL cholesterol rises, and the apolipoprotein A1 level also increases during the normal gestation, while this level peaks during the second trimester. And there are studies which have suggested that there is a potential protective effect to the mother to the offset elevations in the atherogenic LDL cholesterol and the triglyceride levels. It has also been seen, interestingly, that the multiparous women tend to have relative decrease in HDL cholesterol levels in comparison to their primiparous counterparts. And these derangements of the elevated LDL cholesterol fractions with lower HDL cholesterol levels, they can be more pronounced in women with gestational hypertension and diabetes, as well as the preeclampsia. Furthermore, it has been seen that women who have higher concentration of small dense LDL fractions during pregnancy, they tend to have increased risk of cardiovascular disease later in the life as well. So this brings to me the other important topic, that what happens, how does the rise in lipid can be related to the preterm birth risk and the other complications. One of the study called the ABCD study, it has shown that the atherogenic lipid profiles during the first trimester increases the risk of adverse pregnancy outcomes, including maternal morbidity, mortality, as well as the preterm delivery. Another European community-based cohort study involving almost 4,000 known diabetic, otherwise healthy women. The investigators, interestingly, they found that elevated triglyceride levels, but not the total cholesterol levels during the first trimesters, were independently associated with adverse outcome for both the mother as well as the newborn. And these adverse outcomes, they can be defined in the form of gestational hypertension without proteinuria and preeclampsia in the mother, and the preterm babies who are too large for the gestational age. So what happens during the lipid profile, or if somebody who is already having diabetes before the pregnancy? This is interesting to see that lipid profile in women with uncomplicated pre-existing type 1 diabetes are similar to healthy women without diabetes. So presence of diabetes in a controlled environment does not lead to any further rise in lipid. The change in lipid profile can be matched to the normal healthy women. However, when confounded by the other metabolic risk factors such as the obesity, hypertension, poor glycemic control, preeclampsia, it can also lead to more than normal elevations in the first trimester TG levels and lower levels of the HDL cholesterol in comparison to the healthy counterparts, so predisposing to the other complications. Also, one of the gray area is that most of the time we are not able to do any studies in the pregnancy group because there are ethical concerns. And one of the criteria, you will always find the exclusion criteria of any trial, any drug, you will find that pregnancy is always excluded. So practically, we don't have anything to treat this dyslipidemia during pregnancy. So now this brings to one of the key questions to the topic of the day, that whether the dyslipidemia is a risk factor for the GDM. So we know that GDM is one of the most prevalent metabolic complications or the disorder during pregnancy. And there are studies which have suggested that there exists an association between disordered glucose and lipid metabolism in the development of the GDM. And however, the results have been inconsistent. So I searched the literature, and to me, this one paper appeared to be the most attractive because it is a meta-analysis published it is a part of the Lancet Discovery Science eClinical Medicine. And this study looked into association of maternal lipid profile and GDM, a systematic review and meta-analysis of 292 studies and almost 97,000 women. So it is interesting to look into the design of this meta-analysis. The meta-analysis includes a used database search was carried out, including Medline, Web of Science, Cochrane, Scopus, clinical trials. Duplication was removed, title and abstract screening was done, and more than 7,244 research papers were excluded. Full text review 733 were selected, and when further modification of the research criteria was done, only 292 articles could be found eligible to for inclusion in the meta-analysis. So what I will not be going into too much details, but I will be highlighting what are the key takeaways from this very important meta-analysis, which was published as a part of the latest science discovery. So this is clear that the cause of GDM is not fully understood. Obesity, maternal age, women from certain ethnic groups, they have been identified as being at high risk. More attention has been given to the association between impaired glucose metabolism, abnormal circulating lipid levels, and consequent worsening of the glucose intolerance. While the exact relationship between the maternal plasma lipid metabolism and maternal glucose remains unclear, there are recent studies and enough data to highlight that GDM induces a state of dyslipidemia consistent with insulin resistance. Also, the rise in lipid levels can lead to increase the risk of GDM also and future diabetes mellitus also. So women with GDM had significantly higher levels of triglyceride. In addition, significantly higher levels in total cholesterol level as well as significantly lower HDL cholesterol level were also observed during this when this meta-analysis was carried out. Since a physiological increase in plasma TG and total cholesterol is a normal phenomenon as pregnancy progresses, it is expected that there will be significant heterogeneities across the populations, and this was also seen in this meta-analysis because it is difficult to draw a line when the normal physiology becomes a pathology and leads to disorders and the diseases. So this is expected given the physiological increase in circulating TGs and TC as pregnancy progresses. So it is very difficult to determine what exactly is happening with the rise in the lipid levels. Also, it has been seen that significantly higher triglyceride levels were found in women with GDM compared to women without GDM for the first trimester, as well as the second trimester, as well as the third trimester. While the data for the total cholesterol, HDL cholesterol, as well as the LDL cholesterol in women with GDM compared to women without GDM were similar. It has also been seen that the East Asians, that includes India as well as Pakistan, they showed a higher vein-mated difference in the TG levels compared to the European counterparts, while South Asians and the other Asians had lower vein-mated differences in the triglyceride levels. So as a population, the East Asian population is again more predisposed to lipid abnormalities, and these lipid abnormalities leading to impaired glucose metabolism also. Also, so some of the key messages from this meta-analysis are that the elevation of TG levels in women with GDM is more pronounced in certain populations, that is South Americans as well as the East Asians, and this suggests that more severe complication associated with GDM in these populations. Secondly, differences in diagnostic and screening protocols, as we know that they are not consistent all across the world, and different protocols and different guidelines are followed when the diagnosis of the GDM is concerned. So heterogeneity again increases. So there is a variation in TG levels differences between women with GDM compared to women without GDM in different studies. So this finding was of this finding is of implication that more population compared to the previous meta-analysis, and there is a high level of heterogeneity whenever we compare such data globally. So this meta-analysis has found that there is convincing evidence of biological possibility linking hyperglycemia and dyslipidemia. And why they are saying is that when you compare normal women, normal pregnancy, and you see the rise in the lipid levels, and when you see those women who actually developed gestational diabetes mellitus, the meta-analysis found that the cholesterol levels, TG levels, they were higher in those pregnant women who were having GDM. So this gives leads to this possibility that this is the higher lipid levels, which is probably predisposing to the GDM also. However, a bidirectional relationship may also be true because that requires further investigation. So for women with GDM, insulin resistance and high estrogen levels during pregnancy may cause the normal pregnancy associated fluctuations of the lipid metabolism to exceed the physiological adaptation. Also, it has been seen that the lipid changes which happen in the women can lead to endothelial dysfunction of the fetoplacental vasculature. And this leads to the development of the fetal aortic atherosclerosis, which predisposes children born to mothers with GDM to the development of the cardiovascular disease later in their adulthood. So the findings from this study also says that the elevated lipid levels, particularly TGs, is associated with future risk of GDM and could potentially be integrated into a risk stratification algorithm to calculate the risk of GDM. So this is just to draw a parallel where we can see that obesity with gestational weight gain, glucose intolerance, hyperglycemia, insulin resistance, hyperinsulinemia, and dyslipidemia, they are all happening simultaneously, predisposing the women to the gestational diabetes, increased supply of glucose and fatty acids to the fetus, and developmental programming and the fetal adaptations leading to various kind of complications. Cardiometabolic disease development in the offspring with the age can happen. So this is a fetal origin of the diabetes, which we call. So I would like to thank you all for the patience listening. Thank you very much.
Yeah, thank you, Dr. Amit, for such a wonderful deliberation. You have actually covered all the topics as well as the latest, which article was published in the Lancet, covering all the various trials. Yes, pregnancy with gestational diabetes with LDL is a complication which a cardiologist and a diabetologist definitely faces. There are restrictions because of the ethical issues in dealing with pregnant ladies. None of the ethical committee easily passes. And yes, it is noted that because of decreased catabolism of the adipose tissue as well as the hepatic lipase changes, this happens. But we always see that pregnancy with the diabetes with LDL turns out to be something which is very, very prone for endothelial dysfunction, which is actually a preset for diabetes, and they fall into the pre-diabetes complications. So that is why we see that these patients have to be monitored very frequently. And now, as the advancement is increasing, we are seeing a lot of cardiac patients, young cardiac patients with gestational diabetes that is also coming. So this is a very, very important topic. Thanks to Amit Dey and to Rutul, who has placed this topic, and thanks to Dr. Anuj for placing it in ACP, because as physicians, we see a lot of patients post-gestational, they come to us. So this is a very important placement, and you have done a wonderful job. No questions for that. We can proceed with the further lecture.
One comment I would like to make, Ashish. So Amit, you have really made a wonderful efforts, and you really did the lot of work and lot of I think hard work in making this presentation. What I understand, because what I know, there is a very difficult. It was really very difficult topic. I was not even thinking that you will accept this when Amit has told me that I am going to ask Amit Gupta to this topic. And in fact, when I talked, you said, no, I shall be very much doing that. And you must have gone in the long way of getting the literature search and all that. One important thing I would like to say here, whenever Dr. Sheshia always says that gestational diabetes is a information that future a person is going to develop a diabetes, or you can say that gestational diabetes is the pre-information, or it is the alert for a woman that she is going to be having diabetes in her next few days or next few years, or in the next few weeks, maybe in the next few months. And that is because of this reason, that if a person is having high insulin resistance, that lady only is having a more chances of developing gestational diabetes when body's demand is increasing in the pregnancy, because pregnancy is a state in which the insulin resistance is physiological. Very well said you, Amit, that when does the physiological needs become the pathology, doesn't know. And very difficult to mark that point, at which point of pregnancy the physiological need will change into the pathological problem. So it is really a very good thing. And once we know that a woman who may have the gestational diabetes, she is carrying a lot of insulin resistance before entering into the pregnancy, dyslipidemia must be excluded at that time and must be looked for. So all pregnant women, especially all women who are having a first degree relative of type 2 diabetes, or those who are having a history of insulin resistance, those who are having overweight or obese, they must check their lipid profile before entering into the pregnancy, as we suggest that they should check their glucose and diabetes before entering into the pregnancy. But one thing is very much difficult here, that pregnancy doesn't allow to take the statin. So if a lady is found hyperlipidemic, she has to correct it before the start of the pregnancy, and then only we should start, we should allow that to be in the pregnancy. So this thing, what can I understand from your presentation, which has really was is very much stimulating and very much enlightening. Over to the, I think still we don't find Surajit Patra here in this on our screen. So I think.
Anuj sir, I would just like to say one thing, because this is the right forum, the PSG.
Yes. Sure,
right
sure,
now,
sure.
we definitely test for the GDM in all the pregnant lady, and we have guidelines, but we don't test for the lipid profiles. I don't think whether it is ethically allowed or not. And
actually, problem kya hai na, Amit,
Yes.
what is the problem there? Because even if we check, we can't give the treatment.
Yes.
This is the issue, because of what very rarely it is said that you should check it. If you will check it, and it is found hyperlipidemia or dyslipidemia, at that point of time, what will you do? You won't be having any option. So better either you check it before entering into the pregnancy, or the pregnancy is completed, then you check. There has been seen sometimes that I've gone through a few of the studies. You know that my interest regarding the gestational diabetes. So I have also gone through a lot of literature, and I have seen that few of the pregnancies are having the uterine artery occlusions, uterine artery narrowing because of the atherogenesis and atherosclerosis. They are found to be hyperlipidemic, and for that hyperlipidemia or dyslipidemia, which is causing so much of the atherogenesis that they are not getting even nutrition for the fetus, then it becomes mandatory to terminate that before it reaches to its natural end. And many times we see that the fetus are born low birth weight. LBW childs are being there with the a lot of complications may also be there in that way. Anything more you want to say, Amit?
No, sir. I was just trying to say that we can think of planning some studies and look into this.
Sir, I wanted to add, because like dyslipidemia or the lipid profile should be included. It's not a universal, but definitely, because it's a lots of studies or the data which has shown to be a risk factor for GDM. We can change the, though statins cannot be used, but definitely the eating habits, because the pregnancy is a state we say kuch bhi khao, and how that high rich energy foods are being given as a tradition. So like more of protein diet needs to be, we needs to counsel and educate, especially to be pregnant females and the pregnancy itself, though the medication may not be the option, but at least a healthy eating habits can be counseled to them.
Yes, I agree 100% with you that healthy eating habits should we have that while having the pregnancy, but this test should be done before entering into the pregnancy.
Yes,
so that healthy eating habits should be started before entering into the pregnancy. And in fact, for 6 months, a person should have the healthy habit, then she should plan the pregnancy. But this is very, very much artificial. It's not really possible. It not exactly happens most of the time. Many people want the things go as per the directives, but pregnancy is a kind of the thing that may not be with the directive. Now over to the third talk. I think that job has also to be done by me only. So we'll be introducing Professor Dr. Anubha Srivastava. She is a very prolific personality, very versatile personality, as well as very nice professor, very learned professor, and always is smiling. That is the great that is the great thing with her, which must be with anyone, that she always smiles in any situation, and this is quite motivating. So Dr. Anubha Srivastava has got a lot of awards. She has got the best publication award at UPDA, ACP Wellbeing Champion for 2022 and 23. She has been one of the main motivator with Dr. Srinivas Murthy for the state of health study of healthcare workers and doctors which has been done on the initiative of the American College of Physicians India chapter. She has been the Joint Secretary of the Diabetes Education Foundation, member of the editorial board of Journal of Internal Medicine of India. Publications are numerous, book chapters are numerous, and I have also been blessed to have her few of the chapters. So organized the various conferences as an organizing secretary, and she has been the scientific secretary at the Prayagraj in multiple conferences. And now she is going to organize one RSSDIUP chapter as an organizing secretary capacity. So without wasting much time, over to Dr. Anubhav Srivastava for the last session, but not the least.
Thank you, sir, for the kind words. And you have been a source of inspiration to me. And I would like to thank for the ACP Symposium on this PSG conference, and thanks to Dr. Rutul and Dr. Amit. A difficult topic, I should say, but a lot of learning after, and I think I would be able to convey the association between anemia and GDM. On listening, we agree anemia is very, very common during the pregnancy. So what role it can play, or let's just see to it. So as we have been hearing throughout the day, pregnancy is the journey with ups and downs. Anemia is one of the most commonly encountered medical problems seen during pregnancy. The Southeast Asian countries, the WHO estimate India has the highest prevalence of anemia in pregnancy. Around 50% of Indian women are anemic, pregnant Indian women, against the global prevalence, and iron deficiency anemia being the most common type of anemia during pregnancy. By definition, during pregnancy, anything hemoglobin less than 11 grams will contribute to anemia, or will be labeled as anemia. The causes could be the enhanced demand, or due to the hemodilution, which could be physiologically seen during pregnancy. So not only this definition of anemia, the value of less than 11, but a condition where the RBC number or the oxygen carrying capacity is insufficient to meet the physiological needs. In the postpartum females, hemoglobin less than 10 will be classified as anemia. Like majority of disease, today what we talk about, the non-communicable disease, this also is an iceberg phenomena, especially in women throughout her reproductive age, but also during her pregnancy. I have seen and heard people talking, my hemoglobin never goes beyond 10, educated and a healthy women. So anemia is an iceberg phenomena. Globally, talking about the pregnancy, 25% people of pregnant women are affected, 75%, especially in the developing countries. And it is very important when it is associated with the factors of hemorrhage, sepsis, and PIH. In India itself, if we see the data in 2011, the percentage or prevalence of anemic pregnant female, they are a severe public health problem and a matter of concern. The anemias, out of which 90% are iron deficient. They are the nutritional anemias, which are more common during pregnancy, but they can be folate deficiency, which should be corrected prior because it may lead to neural tube defects. B12 deficiency being very common in the areas of vegetarian diet. The infections of malaria, hookworm still holds there, and the certain other condition of hemorrhage or bone marrow or the renal disease will always remain maybe prior to pregnancy also, complicating pregnancy. The genetic disorders also on the background. But talking about anemia in pregnancy, the iron deficiency anemia affect around 36% in the developing country. And if you see, the prevalence of anemia across is more than 20-25%. This burden in India is more than 80% if we see in the pregnant females, as there is 9 times higher iron requirement during pregnancy. The causes could be nutritional, pre-pregnancy poor nutrition, other than the iron deficient, the folate and B12 deficient, as we have talked about the causes of anemia. So the presentation of anemia is usually microcytic hypochromic, and in the developing country, maybe the intakes are not proper or the demands increases during the pregnancy out of the other causes, and too many and too frequent pregnancy and plural pregnancy may be the cause. Symptoms and signs are usually non-specific and may mimic normal pregnancy changes unless the anemia is severe, so the neglect may be seen. So the untreated iron deficiency during pregnancy may have a 2 to 3 higher risk of worsening of preterm delivery or a low birth baby with lower infant APGR and a poor maternal health also, causing increases high risk of bleeding, PPH and infection post-pregnancy. So there can be antepartum complication, intrapartum, postpartum and fetal outcomes because of the consequences of iron deficiency in anemia. MCV, serum iron stores, serum ferritin may be help as a guide of the iron stores in the body, and especially the anemia levels. But here is a catch. So we see the burden of anemia is huge. All the gynecologists are making sure that the females are having adequate level of iron in the female group. But definitely the pregnancy outcome with high hemoglobin and increased iron stores have been documented, resulting in increased stillbirth and growth restricted infants. A word before I'll talk about the association. We have been talking daily. We have talked about the gestational diabetes, which is increasingly common public health problem and complicating pregnancies. Dr. Amit discussed the established risk factors of gestational diabetes, and definitely there are specific uncontrolled diabetes risk in pregnancy and also fetal risk and maternal risk of metabolic syndrome in future also. Universal testing, as Rakesh sir was emphasizing, not only of sugar but also of thyroid is being done there. But what about the impact or association of this, a very common, I'm talking about something which is very common. CBC is done for most of the patients on their first visit, doesn't need a mandate. But what is the association or impact of iron deficiency anemia on prevalence of GDM? So this was one of the study published way back in 2004 in the diabetes care. It was a retrospective case control study of 242 women with iron deficiency anemia, which were less than 10 gram per deciliter of hemoglobin and features of IDA, and were compared with 484 non-anemic women matched for year of birth. So the three groups were divided: anemia at the first trimester, at the time of reporting, and the third trimester, group 2 before the third trimester, and group 3 only in the third trimester. So what was found was the prevalence of GDM in relation to the duration and timing of iron deficiency. A significant inverse correlation was found between prevalence of GDM and the severity and duration of anemia. So the study concluded the prevalence of GDM is reduced in iron deficiency anemia, which probably served as a surrogate for other factors such as nutritional inadequacy and reduced gestational weight gain. And further studies on relationship between nutritional improvement and increasing prevalence of GDM in the developing world was warranted. So this was an interesting observation. Pregnant or non-pregnant, women or non-women, free iron produces inflammatory state and oxidative stress over the pancreatic beta cell and causes decreased insulin secretion. This high iron levels in the liver produces insulin resistance. This high iron at the level of the adipocytes, at the level of muscles, it produces fatty acid oxidation and insulin mediated transport. So there is decrease in insulin secretion, there is enhancement of insulin resistance, and a state of insulin resistance can be seen in individuals. So the association between high hemoglobin with glucose intolerance may represent a universal phenomena and may be independent of sex or pregnancy status. Just getting in, understanding more in detail what happens during the pregnancy. Pregnancy also is a condition that favors an oxidative stress. The iron overload and associated oxidative stress contributes to increased risk of type 2 diabetes. Excess iron affects the insulin synthesis and secretion. Insulin increases the oxidation of lipids, as we've just discussed this. So what happens? So during normal pregnancy, there is an increase in oxidative stress. There is routine iron supplementation without iron depletion might also contribute to oxidative stress. So the iron deficiency is very common among pregnant women, and iron supplementation is a rule and is often recommended left and right. A significant association has been observed between the greater iron status and disturbance in the glucose metabolism, including increased risk of type 2 in even non-pregnant individuals. So this high iron stores were significantly associated with elevated risk of type 2 among non-pregnant individuals. So this was another one study which was done to assess the prevalence of diabetes, of anemia in diabetic patient. So anemia is very common. It's a disease. Diabetes is a chronic disease. So anemia of chronic disease definitely occurs in diabetes. The 2.18 times higher in type 2 anemia is prevalent, and 1 out of 5 adult patients have anemia. And females are nearly 3 times higher when compared to males. Another study, now there was association we were trying to find about anemia and GDM. So incidence of gestational, this was a studies published in Turkey, incidence of GDM in women with iron deficiency anemia was significantly lower than in non-anemic women. The nutritional improvement and correction of anemia could be contributory factors in increasing the prevalence of diabetes and GDM. GDM is an independent risk factor of macrosomia, of increased incidence of children. A twofold increased risk of GDM for women in the highest quartile of serum ferritin in the first trimester and nearly threefold in the third trimester. This positive correlation suggests that iron stores may play a role in the development of GDM in non-anemic gravidas who develop GDM have high level of serum ferritin, iron, and transferrin. So incidence of GDM in women with IDA was significantly lower than in the non-anemic women. Another study which was seen where comparison of higher hemoglobin levels as an independent risk factors for GDM. So in this study, it was shown the hemoglobin levels as an independent associated parameters for GDM. High maternal hemoglobin level with a normal variation are an independent risk factor for GDM in this patient, but have little effect on the perinatal outcome. One of a famous Finnish trial is a multi-center study of 1800 population. It also checked the hemoglobin parameters with the association of GDM and the perinatal outcome. So this you can see there was significant correlation of the pre-pregnancy body mass, the fasting blood glucose and glucose level in the GTT, the systolic blood pressure levels. The highest quartile of hemoglobin had more chronic and gestational hypertension and the most adverse outcomes of the metabolic parameters. Another Chinese study which studied the dietary iron intake, iron status, and gestational diabetes. This was a review article which actually reviewed lots of studies, and they showed the dietary iron intake and risk of GDM. The dietary heme iron intake was significantly associated with increased risk of GDM, though this was not inconclusive when it was seen in the non-heme iron. And this was the dietary iron intake. Even the iron supplementation, the study of the GDM were inconclusive because the protocols were not very stringent. So there is lots of hypothesis, but that we need more an exhaustive study to follow the role of oral supplementation, role of injectable supplementation, the effect of him and the non-him, that is the vegetarian source, which may be safer than the non-vegetarian source of iron. The indicators what the study used for the assessment of the body iron status of the serum ferritin, we also know it is one of the inflammatory markers. So they showed a positive association, though they took CRP as a confounding factor. Another markers they used was soluble transferrin receptor, which is an indication of tissue iron deficiency and not influenced by acute phase reaction. This showed an inverse association, the ratio of the soluble transferrin receptor to ferritin in both first and trimester. Hepcidin, which is a master regulator of iron homeostasis and doesn't affected by the inflammation, shows a positive association with gestational diabetes. So to summarize, anemia, especially nutritional deficiency, are very common in pregnancy and is a public health problem, more so in the developing countries, and they have moreover maternal and perinatal mortality and morbidity. Iron deficiency anemia continues to be the commonest anemia during pregnancy owing to poor dietary habits, which is usually treated by oral or parenteral iron therapy. Folic acid deficiency is associated with fetal neural defect, and they should be supplemental pre-pregnancy levels also. And the certain geographic areas where thalassemia and sickle cell, so the consideration should be done for these individuals also. And especially the iron stores being higher in these patients. So what I would like to sum up from this talk would be the hemoglobin concentration in pregnancy was positively associated with the risk of GDM, though this was not consistent in all the studies. The serum iron concentration in relation to GDM have also conflicting with mixed reports. The dietary intake of iron supplement, or indicators of iron status with respect to subsequent GDM risk are emerging and as of yet are limited. The dietary heme iron intake during or before pregnancy is significantly and positively associated with GDM. In general population, however, iron supplements were not significantly related to type 2 diabetes risk. Pregnant women are particularly vulnerable to iron deficiency and related adverse pregnancy outcome, and as such are routinely recommended for iron supplementation. So pregnant women without iron deficiency should not use iron replacement therapy. And with this, I would request, as sir has already invited, I would request everyone to block their dates for a meeting of UPRSSDI in Prayagraj. And I would rest my case as such, and I would be happy to answer any questions.
Thank you, Dr. Anubha, for the wonderful talk, very lucid and very clear concept, and would like to add strength to your presentation by one Chinese study which I have recently gone through, which has said that females, those who are being given iron supplementation in their pregnancy, they are more likely to be detected gestational diabetes in their pregnancy. So this is very much concurrent with your observation, what you have done and what you have done the literature.
Especially during the first trimester, those patients were not anemic or non-anemic, I should say. And if they were given iron supplementation, they had a higher chances. And this was a huge data of the Chinese study. So this was then lots of studies were done on the same thing. So the message should be this, that at least if anemia is very prevalent, but we should actually have a workup of anemia. We have to know the cause of anemia, the level of the stores of iron, and then only, because all cirrhosis patients, all are bleeding, they are anemic, and people again giving them again iron, and iron is so toxic, as we have seen, not only liver, on the adipose tissue, on the pancreas, and producing a higher risk of metabolic syndrome. So routine supplementation of iron with only hemoglobin should not be done, especially in GDM, in pregnancy, I should say. But
that's a $1 million question, whether to treat anemia in pregnancy or not. If anybody says that we should avoid treating the anemia, I won't agree with him or her, because anemia is a thing which should always be treated. And it is a roots of multiple evils. It may lead to the cardiac dysfunction, it may lead to the heart failure, it may lead to the it may lead to the fetal maldevelopment and malformation. It may lead number of problems in the body. So we cannot say that anemia is there and you should not treat, otherwise gestational diabetes may be there.
So we should actually look for anemia. We should look for anemia.
Yes, definitely. We should look for anemia. We should treat for anemia. Even if the gestational diabetes is coming up, no worry, gestational diabetes is manageable. It can easily be managed. And we have the data in multiple cities of the India, and especially in the South India. 90% gestational diabetes could be managed on the dietary management or nutritional management, medical nutrition therapy. So this is not a thing because of what we should fear that we should not treat the anemia. One thing is very much clear. If there is anemia, we should treat it. But at the same time, we should not give the iron therapy just as a general supplementation or general nutritional supplementation without any definite reason that patient may be having anemia or may not be having anemia. If patient is having anemia, should be treated. If GDM comes, should be treated accordingly. If she is not having anemia, then unnecessary iron therapy should not be given. What I could understand from your talk. So I just tried to share with all of you. And if anybody is having any comment and question, you all are welcome. I think there is no question in the chat box. So talk was so clear that yes, Ashish, you want to say something, I think. No?
No, sir. Dr. Anubha has covered very clearly, and yes, we should evaluate anemia in patients. That is the crux which goes all.
It should be done in day-to-day practice. I see lots of patients having unnecessary iron prescription. It may be only rheumatoid or diabetes, anemia of chronic disease, and they are being burdened with iron supplementation. So at least a message to all our ACP, because we are talking on the ACP platform where the physicians are there, we should do a workup of anemia. And this
of course, this message to the doctors who are handling pregnancy also.
The mind doesn't know, the eye doesn't see. So now when the mind will know, our ACP people, they'll be able to see.
Ashish, I just want to say that this message is not only for physicians. This is for those doctors also who are handling pregnancy. May not be physician, because physicians rarely get a chance to handle the pregnancy. Mostly only after it is being referred from the doctor, maybe MBBS, maybe gynecologist, maybe obstetrician, maybe anybody who is taking care of that pregnant female. Whenever she or he refers to physician, then only we get chance to interfere. So on the baseline, on the bottom line, we should give this message to all doctors, in fact, all MBBS doctors or primary healthcare physicians, that don't distribute iron tablet like anything which can be given to anyone.
Yes.
So,
there are
I think
many aspects.
Last lecture was also very good, and we enjoyed in the last lecture also. With this, Amit, is there any more agenda, or you take over for the final comments?
The last and the best symposium of I think PSG 2022, and we had 3 very important topics, and one was a very offbeat topic of Dr. Amit Gupta, and I think about just a few days back, I spoke to Dr. Anubha, and I said that you need to take up anemia in GDM, and she said that it's a really interesting topic, talk on that. So I think
10 years before, Amit, 10 years before the same topic I have spoken in Calcutta Dipsy.
Wonderful.
It was held in 2010.
Yes, sir. That is
I
that
remember
was the data as it coming.
Right.
So I just remembered when so many things when Dr. Anubha was speaking today.
Wonderful. And I think we have very important take-home points out of the symposium. And thank you very much to all the speakers, Chairperson, Dr. Saxena, Dr. Anubha Srivastav, Dr. Amit Gupta, Dr. Rakesh Shai, and at the end, very much Dr. Anuj Maheshwari sir for moderating this session and being a part of PSG 2022. Thank you once again, ACP India chapter, for joining in with all your support.
Thank you.
May I add a few words?
Yes, please.
Yes,
Now
Harish.
over to Dr.
Most
Loplani
welcome,
and
most
Dr.
welcome.
Dharmendra Panchal. Yes.
Yeah.
Yes. Thank you, sir, Dr. Anuj Maheshwari, sir. I was not in contact with you since long, though Dr. Amit Dey took care very well for you. So really sorry for not being there sometimes. But it was amazing, that symposium. And Dr. Anubha Srivastav, I liked the talk like anything, because I was searching for the materials for so long for diabetes and so gestational diabetes and anemia, but you talked so well, and I would ask for the PPTs to you.
Sure. I actually, after that, I also thought of giving a thesis topic to the students.
You were looking for
Very
material,
clever.
and now you are having encyclopedia of that.
Very clever.
Good. Thank you.
Thank you. My pleasure.
Thank you, ma'am. Thank you, Maheshwari sir, and thanks all the ACP members. Thanks a lot.
Thank you all for being with us, and keep on joining with us in such kind of the activities all the time. Bye-bye.
Bye-bye, sir. Bye-bye.
Day one, and we look forward to see everyone tomorrow physical at Hotel Novotel. Thank you once again for joining in. Thank you.